Okay. Yeah. Wash kara ke aur khwa de. Edit.
Right.
Shall we start? Yeah. Good evening, everyone. Again, it's my privilege and pleasure to welcome you all, the audience, and also the panel today, which is again, it's a galaxy of stars from different places of the country.
Slightly louder if you could.
Yeah. We have Dr. Satish Jain, who will be the hero today again, and with the help of Dr. Rajeev Pachauri. And we have Dr. Nishi Gupta from Delhi and Dr. Sandeep Karmakar from Pune. And we have our Dr. Parmita Saha, who is our moderator today. Before we start the session, this is Mahendra Verman. Once again, I would like to give my warm welcome to everyone.
Can you hold that again, please?
Yeah.
Thank you.
Yeah. Speaker under hai. Yeah. Can you hear me?
Yeah.
Yeah, better. Yes.
Today is 2nd of July, and yesterday was the Doctor's Day. On the occasion of Doctor's Day, all of us in Sun Pharma sincerely thank you for self-love services at all times, and especially during the challenging COVID pandemic. We would like to have a tribute to all the doctors as expressed through the voice of real patients. And I would like to play a small video. Yeah, Dinesh.
पहली मीटिंग में डर निकाल दिया
और बेचैनी से भी।
हाथ थामा, दिल जीत लिया।
मेरा बर्थडे सेलिब्रेट किया, मेरे लिए बर्थडे केक लेकर के आए।
हर दिन जोक सुनाया।
उम्मीद दी,
हौसला दिया,
आंखानी रोशनी की, मौत के मुंह से खींच लाए,
खुले आसमान से मिलवाया,
दोबारा घर से मिलवाया, माँ से।
माँ जैसा ख्याल रखा। थैंक यू डॉक्टर।
थैंक यू।
थैंक यू डॉक्टर।
थैंक यू।
Thank you for saving my life.
थैंक यू।
You're my hero.
It got stuck. Dinesh, it got stuck.
Sun Pharma, reaching people, touching lives.
Yeah, I think there is a small problem in the video
डर निकाल दिया
relay. But anyhow, in our tribute from Sun Pharma to all the doctors, and wish them a very have a safe practice and safe life. And again, it's my privilege to hand over the session on behalf of Sun Pharma to Dr. Rajeev Pachauri. This is Mahendra Verman, Pharma Care Division. Thank you.
Thank you.
Rajeev sir.
Yes. Good evening again, all my friends from my country, from abroad, and all dear friends for joining us again on this 9th. This is a series of our Explore the Legends, and we all know that we are exploring our single legend, Dr. Satish Jain, with all along with our guests. And today we have Dr. Sandeep Karmakar from Pune and Dr. Nishi Gupta from Delhi. And today we have a live session of few cases like internal triploplasty, fresh case, and thyroidectomy with hemiglossectomy with supplied neck dissection. We have a carotid body tumor which may require carotid artery repair. And I think more than surgery, we have a galaxy of speakers, and Dr. Satish Jain, of course, is there. And we want lot of discussion from all of us, along with many questions should be there from the viewers who are sitting in front. And just watching from starting to evening. So let's come again for this great evening. We're starting now. And I think right along with you, and I think enjoy this, because this part of today is the surgical experience the person is having. So please enjoy the basic concept of basic surgery. I welcome you all, and the questions you can ask me directly or to the YouTube also. So the link given to you, Dr. Paramita will take all the questions, make this live discussion lively. So I would like to hand over the mic to Dr. Satish Jain, and Dr. Paramita has also joined us. Any comment from Dr. Paramita, any suggestions? And
We'll be starting from an interlate tympanoplasty. So from basics till the advanced, we will have a good discussion today. So without any delay,
Rajeev sir, I mean, with all due respects, and the statement which you have said, exploring the legends, is absolutely true. And Satish boss, we are not only exploring the legends, we are exploiting the legend of Satish Jain. We are exploiting it. So it has been a wonderful, wonderful 9, sort of innings till now, and it's going on without getting out. So fantastic. Please, boss.
Thank you, boss. Thank you. Am I audible?
Yeah, you are audible.
So, good afternoon, everyone. And once again, we invite you to this, the 9th session of this webinar. And big thanks to so much of efforts in making this event happen. And of course, Sun Pharma has always extended unconditional support to each and every scientific activity. Thank you so much. Thank you, Paramita. It's a special day again for us. And believe me, the people you see, our guests today, are very, very close to our heart for their academic excellence and the kind of human being they are as well. So I welcome Madam Nishi Gupta, who is, heading the department at the Shroff Charity Hospital in Delhi. She is Associate Director of the hospital as well. And besides her clinical excellence, her academic excellence, a lot of number of publications and invitations and medals and prizes. Very, very special book on DCR. And now the 3rd edition is coming up, for which Professor Elder Stam has written a forward. So, Madam, thank you so much for being with us. And I'm sure everyone will be enlightened with her thorough knowledge, comments, and her involvement. Thank you so much, Madam. And then we have our own Dr. Sandeep Karmarkar. This man, he is from Pune, and he has opportunity to have worked with top stalwarts in the world. Professor Tepan, Professor Movani, and he has worked for more than 1.5 years at Gruppo Otology with Professor Mario Sana. And he was the one who contributed his name is featured in the latest edition of Scott Brown in the otology session. Great boss, and he has been organizing a lot of workshops, temporal wound courses. He is a dedicated lateral skull-based surgeon. And more than that, he's coming up with a novice idea of one of its own kind, the Skull-Based Institute in Pune. So that's a great thing. Great boss. We are looking up to it, and I'm sure he will take this science to a new height.
Thank you very much.
Thank you.
Thank you.
So to begin with our scientific session, today, as Pachauri boss said, we have to emphasize more on basics. And our first case we are starting is the patient is a young male with a subtotal perforation in both the ears, having moderate conductive hearing loss. I will show the intraoperative, the tympanic membrane picture and all. So our plan is obvious, like we always think of doing a tympanoplasty in a perforation. What I want to emphasize here for the junior colleagues, this is not a mechanical surgery. There is a lot of science involved in it. It's not like a puncture that you have to repair with something. It cannot work like this in long run. And repair the perforations I will show our technique, which we have been using for last more than 20 years with excellent results, which I learnt initially from Dr. ABR Desai, Dr. Ashim Desai, and then we modified also a little bit with time. And this is something, the reason is, as science is evolving, we are striving for the better and better results. For tympanic membrane perforation, whatever technique you use, like underlay is the most common technique, and worldwide people have given more than 90% results. Then only also is a very good technique, I would say, though little technically challenging, but has amazing results. You get more than 90% results. Now, going into the physiology of this middle layer and the Eustachian tube, and some advancement in the technique, we can still improve our results. In our series of thousands and thousands cases, we have been able to take this up to 99%, and which is I'm going to share with you. So besides, before I go to the surgical part, I would like to emphasize a little bit on the physiology of the middle ear and Eustachian tube. That is, I believe, essential for everyone to understand. So God has given us a middle ear. Why? The reason is very simple. The middle ear acts as an impedance matching device. The reason is, whatever sound coming from the air, when it strikes the tympanic membrane and goes to the cochlea, the sound running through the air has least resistance. But as it comes in contact with the fluid with so much of resistance, most of the sound is obviously going to be reflected back and we can't hear. In order to make this sound reach to the inner ear fluids, God has interposed the middle ear. That is the function of middle ear. That is impedance matching. Whatever impedance which is provided by the fluid, inner ear fluid, take care of by middle ear. By means of its structure, the ossicular chain, it it amplifies the sound coming to the tympanic membrane through its unique ossicular chain system from tympanic membrane to the small stapedial foot plate. That is the function of middle ear. Impedance matching. Now, for this middle ear to stay healthy, it has to keep its composition of air, the quality of air, and the pressure of the air normal. At the same time, it has to keep its system clean as well. Middle ear has to secrete and it has to clean the secretion from the middle ear for its optimum functioning. And for that, God has given us a eustachian tube to keep the middle ear pressure equivalent to outside atmospheric pressure and to keep the middle ear clean. I hope you're getting my point what I'm trying to say. We need a healthy middle ear in order to function as an impedance matching device. And for a healthy middle ear to stay, God has given us a eustachian tube to maintain the middle ear pressure equivalent to outside ambient air pressure, as well as to keep the middle ear clean of secretions. And these two functions of the middle ear are the eustachian tube are very important to keep the middle ear healthy. Anything happens in the middle ear cleft. See, this perforation is not a small thing. Perforation can be end result of pathology anywhere in the middle ear cleft, or perforation itself can lead to further pathology in the middle ear cleft. Middle ear cleft means the eustachian tube, the middle ear itself, and the mastoid air system. That is entirely known as a middle ear cleft. So anywhere in the pathology in the middle ear cleft, maybe in the to stay healthy for long run required to be perfect in serving all these functions. So when we reconstruct the middle ear, whenever we reconstruct the middle ear, we hope the long-term results. Though you go to the lot of studies done, the long-term results are not as encouraging as primary results. That's why we need to look into the eustachian tube functions. Now, a lot of people work about the eustachian tube as an anatomical conduit, So like, it's not that something which is only anatomically important, which is important for us. What we want, a useful functioning eustachian tube. And as I mentioned, it serves two functions: to maintain the middle ear pressure, that is ventilatory function. How does it serve? Every time we swallow, the eustachian tube opens and deliver air to the middle ear. What happens? In middle ear, there is a constant absorption of air. Constant. It's a constant process that the middle ear air is constantly absorbed by the mucosa and the, the vascular system in the middle ear, in the capillaries. And because of this constant absorption of the air, the middle ear air pressure is getting towards the negative pressure all the time. So in order to neutralize that negative pressure, the eustachian tube keeps on opening. Intermittently, the eustachian tube opens and that neutralizes the negative pressure. So that is the ventilatory function of eustachian tube. And you can imagine how sophisticated this system is. I can say this middle ear and eustachian tube you can refer to like a lung and tracheobronchi system, where the middle ear acts as a lung reservoir of air and the eustachian tube acts as a tracheobronchial system. So every time the middle ear gas is getting absorbed constantly, which is provided to the middle ear by intermittent opening of the eustachian tube. That is one function of the eustachian tube, that is ventilatory function. And other function of the eustachian tube is to clear the secretions from the middle ear, and that is the mucociliary function. So if these two functions are good, sound, whatever middle ear you reconstruct is, you can hope for that middle ear to function for longer adequately. So our first goal before we take up such surgery, see, it's a usual practice that you see a perforation and you can fix up for the surgery, and it works in most of the time. To improve your results to the maximum, if you focus on the nasal pathology and the pathology like eustachian tube, we can further improvise our results. So how to test this function? Anatomically, even if you put a probe from the nasopharynx to the ear or ear to nasopharynx, in spite of being intact, it doesn't serve this function. We want to test this ventilatory function and mucociliary function. These are two physiological functions of the eustachian tube which need to be checked. So normally what happens? Every time we swallow, the eustachian tube opens. And whatever eustachian tube, nasopharyngeal tube opens and closes, it pushes the air contained in the isthmus of the eustachian tube. And that isthmus is so narrow. Every time eustachian tube opens, it delivers of air of, say, 2 microliter. Such a small air is delivered every time the eustachian tube open, and that is good enough to neutralize the middle ear pressure. Whatever air being absorbed in the middle ear is neutralized by intermittent opening of this eustachian tube. So whenever the eustachian tube opens, it neutralizes the pressure. In our daily routine, in say 24 hours, we swallow almost more than 1,000 times. And every time delivering 2 microliter air means every day in 24 hours, our eustachian tube is delivering 2 to 3 milliliter of air into the middle ear. That's it. 2 to 3 ml is the air every day which is delivered by the eustachian tube, keeping our ear healthy. And that function can be tested even in the perforated drum by means of tympanometry. Come this side. So how can you test in a perforated ear this ventilatory function? If you have a tympanometer is what? Tympanometer is an electroacoustic bridge. What do we do in tympanometry? We plug the ear with a probe that is hermetically completely sealed. And now if the patient has a perforation, when you raise the pressure of the ear with a manometer in the ear through the tympanometer, there is only one way where the pressure can leak. That is through the perforation and then through the eustachian tube. So how can you test? That is Williams maneuver, which you can easily do with a tympanometer. Put a tympanometry probe, seal it hermetically, completely, and make artificial pressure of 300-400 millimeter in the canal. And ask the patient to swallow. If the eustachian tube is functioning adequate, with every swallow, the pressure will come back towards normal. And that, if you see on temporometry graph, that means your eustachian tube is functioning well. If it doesn't come back to normal, partially, that means partially functioning. If it is absolutely functioning, it means more swallows. That is how you can simply test ventilatory function. Number two is mucociliary function. That is different. So how can you test? You can put a saccharine pellet in the eustachian tube orifice in the middle ear and ask patient when he perceives the sweet test. It comes, that is normal. Doesn't come, absolutely abnormal. Late means partially functioning. So by means of this, you can prognosticate, because many of such patients ask how will they behave post-operatively, and you can use this test. And it will give you confidence as well that the patient has a good eustachian tube function, and whatever you are going to do is hopefully going to work well. So these are two things which we, if we incorporate in a practice, we can still improve our results. Now the third thing is, as I mentioned, this is not simple patching of perforation. It's not patching of perforation. This is simple reconstruction of the entire middle ear cleft. We need to see at the eustachian tube, like I mentioned, intraoperatively, as well as we'll see mechanically if something obstructing. We need to repair the tympanic membrane perforation. We need to see the ossicular system of the tympanic membrane so that its impedance matching function works optimum. And at the same time, we need to see the mastoid air cell system, whether it is adequately being aerated down the eustachian tube or not. Because for that air cell system to function optimum as a reservoir, it should be aerated down the eustachian tube. So while doing this tympanoplasty, we call it as a middle ear cleft reconstruction. We need to see all the aspects of the middle ear cleft, eustachian tube, middle ear, ossicular chain, and the mastoid air cell system, which is aerated down the eustachian tube. So this demonstration will involve like a middle ear cleft demonstration. Yes, during grafting of the tympanic membrane, a technique involves interlay. That is something different. So underlay tympanoplasty is what? When you place the graft underneath the three layers of the tympanic membrane, all the three layers. Interlay means when you push the graft in between the layers of the tympanic membrane. Only people earlier used to place the graft above the fibrous annulus but below the epithelium. The only issue is you have to elevate the entire epithelium, and in case you leave a bit of epithelium, can lead to cholesteatoma. And you make the surrounding canal so blunt with a single epithelium layer, so raw, when you replace it back, can lead to blunting, particularly anteriorly, and that results in contact. That's why this technique is going to disrepute at most of the centers. So the technique, what we have been following for years, take care of all the disadvantages of underlay and interlay. The technique is interlay. That means the interposition of the graft between the fibrous layer and the mucosa. And here I am going to demonstrate a proper segregation of the three layers of the tympanic membrane. Though we all know the total thickness of the tympanic membrane is less than 0.1 millimeter. Still you can separate into layers. I will show that. And then if you place the graft between the fibrous layer and the mucosa, that is the most physiological place for the graft. Physiological in the sense, graft is the fibrous tissue that has to be placed between the mucosal and the epithelium layer. So the graft will be placed on the mucosal bed, mucosal layer below, and then the rest of the two layers will come above. So this way there is no question of blunting, no question of cholesteatoma, and it is a very, very safe bed for the graft. And more than that, that mucosal layer having additional vascularity is a good vascularization of the graft earlier. So that is how we are going to execute our case today. Boss, anything you do differently or any opinion?
No. It's absolutely well justified, and I think the function of middle ear is so well explained. Now, what I want to know is, in your practice, do you incorporate doing a tympanometry as a prerequisite for all tympanoplasties?
It is always better. Always better.
And another very tip is commonly told by the patient ourselves is that whenever they put some eardrops in case there is a discharge, they will feel a very bad burning sensation down into the throat. So
Yes.
that gives a little bit of hint about the anatomical continuity, which may not really matter for
So
the post-operative
that
vision.
cannot show the physiology,
Absolutely.
the eustachian physiology.
Correct. And one more thing which I want to know is, technically, I mean, we have been taught that tympanoplasty is basically underlay and overlay.
Yes.
I mean, although I also do the classical full cuff interlay tympanoplasty since many years now, and thanks to you, we've picked it up. But I still regard that interlay is nothing but a more refined version of actually underlay.
Believe me,
where
it's
you
not
put the graft-
difficult.
yeah, where you put
Whoever
it below the
joins
oil.
our center, the first surgery gets his interlay. Believe me, and you can get used to it so fast.
Yes.
More than that, I will show in the end. We use a fresh graft, which had its advantage. We believe we'll show it.
Yeah.
Yes, madam, you are saying
can I
something?
ask you a rare question, not related?
Yes, please.
I got a study from somewhere about Ostman fat pad, whether in chronic otitis media, the size versus comparison, just a study I got.
That is related to
comment
the
on that.
eustachian tube functioning. A lot of work has been going on towards understanding the eustachian tube function and improving it. Like if you go to the Professor Tarabichi's talks in Dubai, is working a lot on lots of eustachian tube endoscopy, eustachian tube, dilatation, stenting. So many things are going on, but yet, what I believe, nothing is standard of care. It will take time to establish their role in improving the eustachian tube function. Okay.
Do you do interlane? Sorry.
Yes, madam.
Do you do
Mostly in all large perforations. Yes. Large and subtotal perforations.
Otherwise, underlay.
Yeah, in posteriorly placed perforation, in like perforation when in the center involving the malleus, we do over and underlay. In more superiorly placed perforation, different scenarios, but yes, mostly we deal with large perforation and subtotal, where we find the indications of surgery, and then obviously it is
Wahid from Pakistan, you want to know, you ask for tube function in all the cases, or you
always better, because every patient wants to know the prognosis. The first question is, will this surgery going to work, or how it is going to work in long run? So you need to have something to answer, and that is always good.
Which test you recommend for that? Which one you ask for that?
William test on tympanogram is the test.
Test.
Yes.
Dr. Pawan Singh
that can easily tell you.
Pawan Singh comments about the...
Yes, that is another technique which is being popularized by our own Dr. Suri Prabhu, and a lot of people have taken up, like Sudeep Munjal demonstrated our center earlier, then Arshad, Pawan is doing, a lot of people are doing and coming up with. So very few people are doing so far. I have no experience, but what do they do? I know I've seen, they excise the entire annulus and place the graft underneath. So the question is, the fear that whenever you do tympanoplasty, otherwise what they believe is you leave the mucosa over the graft. And if you leave the mucosa over the graft, it may suppurate. That's what I'm going to show this on the interlay tympanoplasty. There is no question of leaving any mucosa over the graft. There is clear-cut separation of the mucosal layer below the graft, and then we'll place over there without disturbing the natural function of the anatomy and the function of the ear. The only thing which I'm, having resistance with the TA is, you destroy the natural annulus of the ear which God has provided. And anything so far in the science we have learned, the more you destroy the natural anatomy, less are the long-term results. So still, let's see the long-term results as far as the hearing and the stability of the middle ear is concerned with other technique. But so far, we have been, I've been myself doing this interlay technique for more than 20 years. I'm getting amazing results. And for that, I learned from Dr. ABR Desai, who had been practicing this for another 30 years before. So it's been almost 50 years we've been seeing and getting the best results of as compared to any other technique. So it is a time-tested technique. Anything which comes better, we are always open-minded. Let's see the long-term results, and if it is good, there's no question in not getting into it.
Correct.
Some some audio issue was there. Please repeat the tube function again because some.
You second tube. Okay. During surgery, I will repeat again.
Yeah, just
during the surgical process. So, do we go ahead or any question before?
I mean, one of the biggest problems. One of the biggest problems why total annular excision came into fore was this, persistent myringitis in spite of a healthy drum.
Yes.
And that's why they thought about mucosalization. So we've in fact given this as a thesis to one of our students.
So that is something you need to understand. Absolutely. And that is the biggest problem with the underlay technique. When you make the undersurface row and place the graft underneath and you leave the mucosa. Now, first of all, we should not be dogmatic about it. In spite of having a fact that we place the graft underneath the mucosa, more than 90% of the underlay have success. Success in long run. If you say that if you leave the mucosa above, it is not going to work, I don't believe in that. And the results are in front of you. Those who are doing, like Pawan says in TAE, he must have done a lot of underlay and getting good results. So you cannot blame one thing to admire another thing. See, all techniques are good. Or relatively, there is some difference relative. It doesn't mean that this technique is bad or other is good. All are good. What we are, expecting is the best technique which is evolving, which can give you better results.
Correct.
It's relative, nothing, hard and fast. It's always relative. All those people who are doing underlay are getting over 90% of results. Everyone who is watching must have done underlay live and must have got good results. You can't say underlay is bad. You can say what you are doing may be a better technique. Yes. And that's what we are here to discuss. That's how the science is evolving, to discuss pros and cons of various techniques. Now, somebody said this is the only technique, others are wrong. That is something not believable.
True. And good technique with good results over a long period of time.
Yes, people will automatically.
All of our teachers have also been doing underlay, and we have managed good results.
Yes.
So I think there's no question about it.
Yeah.
And some amount of gaseous exchange in the middle layer and mastoid, because it plays a big role in the surgical outcome.
That is the whole game. Everything is all about the eustachian tube function. If eustachian tube natural gas exchange process is hampered, the middle ear is going to be affected by pathologies. That is how the middle ear science is. So before we start, I saw in the screen Dr. Vishal Arora.
Yes.
Can I see him?
Yeah, he can.
So we have this young man, Vishal, with us. For this case, this man practicing in Surat is a new concept of a group practice, wherein 25 ENT surgeons are practicing together. That is amazing.
Under one roof.
And I am fortunate to have Vishal, who has worked with me for almost more than a year when he did his PG from Jaipur, and afterward he joined us. And he's amazing otologist. Believe me, if I have to get my tympanoplasty done, I will go to Vishal and get it done.
You will never need it.
He has done so many private cases. Believe me, he's amazing. He's a shy guy, but believe me, what a surgical hand he has.
Can't get a better
Unbelievable.
compliment.
Thank you, boss.
Vishal must have been done thousands of interlay, Vishal.
Yes, definitely.
Speak out of your heart how it is, and the results you must have seen yourself, and that's why you are continuing.
This is all because of you, boss. I have learned from you.
Amazing. You're doing so great. So let's start with the surgical part.
Yes. What are pre-operative protocols for the surgery? Is investigations, at least minimum.
Investigation in brief, the specific one we have already discussed about the specific test for the eustachian tube beside the routine audiogram and all. So audiometry is essential to assess the hearing and give the hearing aid gain. At the same time, you can have a good idea of the ossicular status sometime with the audiogram itself. And I will mention here Dr. ABR Desai would always do a gel foam patch test. You know
Yes.
what he would do? He would put a wet gel foam over the perforation. He would pass through the perforation gently so that it comes in contact with the ossicular chain. And if hearing improves, that means your ossicles are not fixed. To rule out any associated tympanosclerosis, otosclerosis, which has resulted into fixation of the ossicle. And that is what that man, Dr. ABR Desai, phenomenal. And this Sunday, we are doing a big event that is all about stapes. The full day dedicated to stapes. A lot of live surgeries and a lot of discussion with hundreds of issues to be discussed on stapes. And that event is totally dedicated to that phenomenal Dr. ABR Desai. I have had the opportunity to work under him for some time, and what a committed person he was. I will tell on Sunday in detail about him. So this technique I learned from him initially, though he modified. I share with him, sir. I started taking wet graph. I started taking this, and he was so happy about it. He was so open. He would do every case with a mini endural technique so beautifully. He would himself do after every surgery intraoperative audiometry.
Audiogram, yeah.
Even after tympanoplasty, any slightest doubt of even 5-10 dB, which was not justifying that much of hearing loss, he would open up everything and revise again. So he is a different soul.
And what is the role of X-ray mastoid? Because there are so many questions.
X-ray mastoid, yes. There is no harm in getting done. Number one, it tells you the pneumatization system.
Yes.
And secondly, I told you, we will check the mastoid air cell system in this case. In every case we do. It's a check. It's not mastoidectomy, cortical, I would say enterostomy or anything. It's a check. What we want to check, as I said, the entire middle ear cleft need to be checked. So we'll check the mastoid as well, whether it is being aerated down the eustachian tube or not. So this X-ray will give you a good idea of the pneumatization, about the anatomy, if anything like dura is low or the sinus is anterior placed or whatever to prevent complications. So it's good to have.
Yeah, you will scrub.
So let's start the surgical part. I'll be back in minutes with a microscopic picture. My associate has already given a post-oral incision.
Okay.
So that to save time, we can straight away go to the point. Okay.
So, what is the concept about Dr. Sandeep and Dr. Nishu and Dr. Vishal? The concept of doing surgery on wet ear, dry ear. What's your protocol?
So, I mean, technically, as far as possible, if our appointments are scheduled in such a way that suppose a patient is going to be see me after 15 days, then I would generally emphasize that I give him a 5-day preoperative course of an antibiotic, a steroid, and antihistamine, and want to ensure that the ear is dry. For me, it does not matter about the technical, graft take-up rate, whether in a dry or wet ear. For me, it's all about the skin of the external auditory canal. I mean, in a wet ear, definitely the skin of the external auditory canal is a bit more angry than in a dry ear. And eventually that might help in that might alter my healing. So I prefer a dry ear, but it's not a prerequisite. Sometimes, we have patients who come for a date after about 1 month of surgery, for surgery. And we find the ear is little bit moist. We don't go ahead. We don't mind going ahead for surgery. So for me, it doesn't really matter. It's not a complete no-no.
So, and
I would say that the status of the middle ear mucosa is more important for me. If the middle ear mucosa is unhealthy, then I would defer the surgery. But if it is slightly wet and patient has received treatment, there should be no fungus. But otherwise, slightly wet ear is fine. If there is profuse discharge or even if there is mucopurulent discharge, then we, like anybody else does, we give antibiotic, everything till the ear is dry. But there is no sacrosanct about a minimal mucosal discharge in the middle ear when
that is the So when you recommend for the culture test, suppose you're getting recurrent ear discharge and it's a yellowish color or foul smelling. Yeah. So when you recommend culture sensitivity in your case, or
I mean, if the discharge is really recurrent, when I mean the recurrent does not mean once in 2 months or 3 months. If the patient just keeps discharging for 2-3 weeks.
Yeah, Satish.
Yeah, Satish boss.
Hello, boss. Can you hear me?
Yeah,
we
very
can
well,
hear you.
very well.
Are you getting the microscopic picture?
Yeah, we're
Yes,
getting good picture.
So this is I told you the post-oral incision has already been given, and we don't harvest the graft in the beginning.
Yeah.
As I told you, we believe in fresh graft. Fresh means at the time of grafting, we'll harvest from one bed to another bed we transfer. That is fresh graft. It has nothing to do with like wet graft or dry graft or anything. It is fresh. So this is the initial picture after the post-oral incision.
Yeah.
That's a regular one.
Yeah,
You can, like I told you, Dr. A.B.R. Desai would almost always do with a mini end oral, and it gives equally good exposure. It is how you are used to your entire system. You know, like in our center, our junior to senior most, everyone are used to this technique, so we don't want to change. Anybody can help anybody with the same technique followed by everyone. Now,
I was just discussing about wet ear, dry ear surgery, or when you recommend culture sensitivity in your case. What your protocol?
So wet ear, dry ear, I would say one thing. The definition is to me is not hard and fast. Yes, obviously, we are not supposed to do in a absolutely actively infected ear. But yes, in ears having mucosal discharge, not having purulent discharge for some time, you can take up. Because the reason is, it's not that we are just raising the flap and placing the graft. We are going to inspect the entire middle ear cleft. So anything leading to any issues with, the persistent wetness to the ear will also be addressed at the same time. So, can you see the perforation?
Yeah, very big, very big.
How's the picture, boss?
Very good.
Very good, very good.
So this is our favorite microscope, the Varia one.
Varia one.
So Satish, was this cottonoids which you had placed inside, were they having some adrenaline? Or
Yes, boss.
And we should ensure that they go into the middle ear also, if possible, so that the mucosa gets decongested.
Pardon?
Do you put some gel foam into the middle ear in this time, by the time the incision and all is taken, to do a preparation of the middle ear mucosa? It helps decongest a bit.
Yeah, a little bit. We keep this adrenaline ball only.
Yeah. Okay.
Yeah, that had been kept for last 10-15 minutes, which I removed just now. So, like for the junior colleagues, believe me, this is a very, very physiological technique, not difficult, but yes, it requires every part of the middle ear cleft to be addressed. So, the first thing, like any other technique we do in the underlay or whatever, we freshen the margin. And the reason is very obvious. Why do we freshen the margin? So that this tympanic membrane layers, why it has become so non-healing perforation? Because this tympanic membrane is composed of 3 layers, and at the margin of perforation, this outer epithelial layer grows along the margin of perforation to join the inner mucosal layer, and those persistent mucoepithelial junction prevents the natural healing of the perforation. So in order to initiate the healing now, we need to do something to break these mucoepithelial junctions, okay? And that is what we call it as a freshening of margins. See this? I am taking a small rim. Though in an interlay, this is actually not required. But still we do it for the reason, sometimes these mucoepithelial junction may go even further from the distance of the margin, and you can leave the epithelium inside if you are not doing this fact.
Yes, that's
so it is always better to do. And I will enumerate at every point of time the advantage of this interlay technique over the other two techniques. Why we have chosen this technique. Forceps. So
sometimes we get very wet ear and we ask for the culture sensitivity, and we very oftenly we get pseudomonas in that culture report.
Yeah, pseudomonas is
what do you mean protocol? You want to make it dry before you give
yes. Yeah. I mentioned if there is active infection, obviously you have to take care of it. So active infection is never something you should take up a case like.
In these days, the culture is resistant to all the antibiotics.
Yeah, most
except
of them.
imipenem.
Yes.
Nothing else works.
So many cases are coming like this.
Yeah.
Yeah.
But you
Because
know,
of the overuse of antibiotics.
yeah, exactly.
And there's
Yes,
no
sir.
further invention coming up. I mean, maybe I'm not aware, but it's just imipenem that you have to admit and give to the patients.
And sometimes polymyxin B. That's
Yeah, I mean colistin,
polymyxin B, and
imipenem, altapenem, and meropenem. These are the three.
Yeah, these four.
Yeah, absolutely. But quite often I see Pseudomonas so commonly in an immunocompetent patient that we really should not worry about it too much. And we just give a routine course of even quinolones. Even if it is resistant, I've seen that so many people, especially a lot of people who are trained in the UK, do culture for even a slightly discharging ear. It's a routine, yeah. And then we find that there are certain things. Yeah. Sorry, Satish. Yes.
Yeah, please.
Yeah.
What I'm trying to say, be liberal in freshening the margins.
Absolutely.
Doesn't matter that if your perforation goes bigger, the reason is we don't want to leave any epithelium which have ingrown underneath the margins. To leave as a epithelium underneath this margin. Okay?
Yes.
Freshen the margins liberally. Can you see that?
Yeah, very clear.
Very nice.
Now, the next step, like any other tympanoplasty method by underlay or anything, next important step is raising the flaps.
Yeah.
In this technique or flap raising, the incisions are all tailor-made. What do we want to do? We want to make incision beyond the margins of the perforation. We want to raise the flap beyond the margins of perforation. So like for this thing, this is the superior margin of the perforation. Can you see?
Yes.
My incision is few millimeter beyond the superior margin of the perforation. Can you see?
Yeah.
The canal incision.
Yes.
And deep down to the bone and going medially right up to the level of the just before the annulus. Okay?
Correct.
Yeah, I'm raising this part of the flap is quite thicker, the posterior one. I was trying to raise with a 15-degree blade.
Dr. Satish, I have noticed.
Yes, please.
If the posterior canal wall flap is thicker, generally the temporalis fascia is also thicker.
Maybe that's a good observation. That's a good observation.
That is
great.
Yeah, practical observation.
Yeah. Now see, this is my inferior margin of perforation. Can you see?
Yes.
I change my microscope angle and now see my inferior incision little different from the superior. Again, few millimeter beyond the inferior margin. Can you see this?
Yes.
And then right to laterally, but I am limiting my medial length of the incision straight.
A little short of annulus.
Little short of the annulus, not right up to the annulus because I intend to raise the circumferential flap. The reason is we want to segregate the tympanic membrane in layers. And for that, we need to raise it circumferentially. So how will I continue that? I will show you later. First of all, we'll raise whatever flap we have marked now. See, inferior part, it is not so thick.
Can I ask you a question here? Yeah.
Yes, please.
Yeah. Sometimes, you can get a really annoying anterior canal hump.
Yes.
During and do your incisions change in that
Yes,
situation?
that's a very important question, boss. Very important point. I can see my anterior margin very well here.
Correct. Exactly.
A little bit of the overhang I will manage with my, microscope.
Tilting. Yes.
Now, if there is too big an overhang, see my circumferential incision will go like this medially. If there is an overhang laterally here, I would make my incision lateral to overhang, raise the flap and drill away the overhang.
Correct.
That is the difference.
Correct.
So if you have a significant overhang, make your incision lateral to overhang, elevate the flap over it, and then you can easily drill it away. Okay?
Absolutely.
Boss, one question.
Yes, please.
So many people are doing canal plasty in every case.
Yes,
Means
I am not a strong proponent,
Yeah,
and
yeah.
I'll tell you the reason behind it. See, this flap we raise, earlier people would say there is a concept like vascular strip.
yes, yes.
yes,
You know,
yes,
there are
yes,
no vessels to it. Believe me, if I make this entire tympanomeatal flap, free, totally free, and raise, bring it out of the body and keep in saline and replace it back, it works.
yes,
How come? Because it has been proven that it acquires its vascularity from the underlying bone
yes,
through the eversion system of the bone where the vessels go.
Yeah, it's a diploid bone, so it gets
Yes.
absolutely.
So, when we use a diamond burr, what happens, Vishal? When there is oozing from the bone,
yes.
we use the diamond burr to clog the
Eversion
vessels.
system. Yes,
So, by means of doing too extensive a canal plasty everywhere, you are literally preventing that vascularity to come to the flap, and that is something we never do.
yes. For
Especially
me,
with
If
guys.
some canal
Yes.
plasty is required, I will do limited in that area. That's
Yes.
it. Not very obsessed about doing a extensive canal plasty.
Yes.
I
And
think
it has proven.
Vishal, yes. I think Vishal, the thing is, if we by a little bit tilting or obliquing the microscope are able to see 360
Yeah,
degrees.
and that's
Yes,
what I want
definitely.
to show this.
Exactly.
This canal is not as straightforward as you think of. With
Exactly.
the bulge and all, it will show you how you can manage
Yes.
And
without compromise. Ultimately, what we want is a good result. Anything
True.
if happens to hamper the result, affect the result, I would never follow that, never advocate that. Now see, while raising this posterior part of the flap, see what I'm doing. I'm reaching to the level of the annulus. See this?
yes.
But not going beyond this because I need to raise a circumferential flap. See this?
Yeah.
Reaching to the level of annulus. Now what I will do, I will deposit it back in the simplest manner.
And most of the time we get tympanoid patch in the membrane. So what you do?
That is the advantage of interlay. See, wherever the patch is going to be, when I raise the epithelium from the fibrous layer from the mucosa, the tympanoid sclerosis will become evident. We'll remove it immediately. So, since we get a circumferential exposure with this technique, which we don't get in underlay and all, if there is anterior superior tympanosclerotic plaque, how will you remove in underlay?
Yes, that's
Here, it is so simple, you don't need to do anything extra. Now, having this inferior incision limited few millimeters lateral to the tympanic membrane. See this?
Yes.
Yeah.
Few millimeters. This is my tympanic membrane annulus level, and I am limiting few millimeters, this much of width, and I will convert it into a circumferential one. Now see the difference. This part of the skin is very, very thin.
Yes.
Sometimes even a single layer of membrane. So don't go bone deep in one go. Go in multiple goes,
Yes.
Pour over it.
so that to prevent the tearing. This flap is so vital.
Absolutely.
This is platinum for this patient, tympanoplasty.
Yeah.
And now what is going to be my anterior extent of this circumferential incision? Beyond the anterior superior margin of the perforation. See this? This is my anterior superior margin and I am going even much beyond that. See that?
Yeah.
Yes.
Now my next goal is to raise this flap completely circumferentially. The only thing you have to exert regarding care is be careful, be equal all around.
Yes.
Not to raise at one place deeper so as to prevent the tears.
Yes.
It is circumferentially.
You're doing this kind of local or GA? And what?
Local. We do all ear surgeries under local with sedation.
Okay.
All ear surgery, maybe a child, we do under local.
Okay.
With a good local infiltration and a good sedation.
Yeah, because quite often at the time of annulus, generally, the patient starts complaining a bit of pain.
Now, I will show you the hallmark of this technique, interlay. For everyone who has doubts what is interlay, now I am going to clear that. See, this step of the surgery, I told you my first goal is to reach to the level of annulus. Can you see the annulus?
Yes.
Now be careful, reach annulus all around, not at one place. See annulus anteriorly, anterosuperiorly, anteroinferiorly. Okay?
Yes.
Then I will tilt posteriorly and posterior-inferiorly.
Absolutely.
Do this.
True.
And reach to the level of annulus everywhere. See this annulus. So this is a very, very important point. See this annulus I am reaching everywhere.
Yeah.
Hope the picture is good?
Yeah,
Very yes. Slight zoom in, boss.
Okay.
Little magnification, we
Yeah,
can see it better.
Yeah.
I think because of that McEwen spine, that's obs.
Yeah, this because of this.
Maybe we can drill that or.
Really, madam, why to disturb that?
Boss, can I comment, Satish sir?
Yes, boss.
Yeah. See, this step which you are doing now, no, this I do it as the first part of the procedure even before doing the posterior flap. Now, that is one modification which I've found, that if we do this anterior thing, the visualization, because the posterior flap often can be a little thick and come into the natural axis with the microscope. So if you try doing the anterior flap first, which now for me has become a routine, I find it that the visualization, especially in the anterior superior area, becomes much more easier. Yeah.
Yes. Now see, this part of the annulus is sitting in the sulcus.
Yes.
The bony sulcus.
Yeah.
Now my next goal is to get this annulus out of the sulcus. See, gently, you can get it out. See this annulus?
Yeah.
Getting out of this is the steep angle antero-inferiorly, where you have to be very, very careful not to traumatize the annulus at any point of time. See, annulus keeps the tympanic membrane taut all around like a tennis racket is tightened. See this?
Yeah.
The annulus, this is the second step, that is annulus being brought
out of
the sulcus. See this tympanic sulcus. See this. When you bring it out, you can see the reflecting mucosal layer below.
Yes.
True.
Very clear?
Yes.
Very clear.
Now, annulus is what? Annulus is condensation of fibrous layer.
Yes.
We did not disturb at all the epithelium layer. See this epithelium?
Yes.
Yeah.
Along with the fibrous layer intact.
Yeah.
That's why it doesn't lead to blunting at all, which is the biggest problem with the only technique.
Only.
It doesn't leave any raw area here. See this?
Yes.
So this second step is bringing the annulus out of the sulcus.
Yeah.
And the third step is the hallmark of this technique, separating the tympanic membrane into layers, wherein we leave the mucosa below and elevate the rest of the layers. See this annulus?
Yeah.
Lifted all around, everywhere. See this?
Yeah, very well.
Now my third step would involve separating this into layers. So what I will start? Where I will start? First, antero-inferiorly.
Antero-inferior.
That is the acute angle. You can do it easily to begin with.
And the safest.
Yes.
Sometimes we get a bleeding at this level.
Yes, sometimes a fibrous band you may get, that you have to divide it sharply. Now see, this is the anterior-inferior annulus, very clear?
Yeah, very clear.
See my instrument. This is a 45-degree blunt hook. I am engaging it underneath the annulus. Can you see this?
Yeah.
Yes.
I'm peeling it off the mucosa. Can you see this?
Yes.
Beautiful.
Yes.
I am not dividing the mucosa at all. Just peeling it off. See this?
Yeah.
Yes.
To leave this mucosal layer below. Can you see this?
Yeah.
That's the middle ear. See this distinct mucosal layer below.
Yes.
Rest of the two layers are coming with the flap and the mucosa are being left below. Now this has to be completed all around.
Yeah.
Those who have a question that will leave the mucosa above, which can secrete later, can see it again.
Yes.
That's the tympanosclerosis. Can you see?
Yeah.
Yes.
See, you don't need to do anything additional to the tympanoid sclerosis. It will become obvious on its own. See this?
Yeah.
Yes.
And now I can easily remove this tympanoid sclerosis.
Yeah. Absolutely.
See, this is a big plaque.
Very big.
Now, the same thing as I said, what I will get at the end of this, the mucosa as a distinct layer below and rest of the two layers with the flap. See this?
Yeah.
See this?
Very well.
See this? Peeling off. See my inner layer, mucosal layer intact.
Yes. That's
Absolutely.
See the distinct layer. I told you the entire thickness of the tympanic membrane is 0.1 millimeter thick. Yet you can separate into layers. And what is this mucosa? This mucosa of the promontory, after draping the outer walls, it comes underneath the tympanic membrane. The same mucosa. Okay?
Yeah.
So this you can easily peel off. See this?
Yes. Very well.
I am not dividing the mucosa at all. See, this mucosa is going to be the bed for the graft.
golden layer.
Yes,
golden layer.
my graft will be laid all around over this mucosa, and that will serve as an amazing bed. And this entire mucosa is left below. Those who have a slightest of the doubt that I am leaving the mucosa can interrupt me here. Those propagating other techniques saying that this technique leaves the mucosa above the graft can see now themselves. It cannot.
And that's the reason a good freshening of edges ensures it further.
Yes, I was over.
Yeah.
Removing few 1 or 2 millimeter extra.
Exactly.
Because sometimes the epithelial may grow beyond the edges.
Absolutely.
See, I placed it again. Now see the same perforation.
True.
See the same perforation. The difference is, it is now minus mucosa. See that?
Yes.
Because if I elevate, you see the mucosa separate below.
Yeah.
The only thing is I have not removed the tympanoid sclerosis yet, which I am going to now.
Any contraindication of internet technique?
Not really, but why to, do for a smaller perforation?
Yes.
Contraindication of?
And interlay. And one is reverse interlay technique, means when there's an anterior perforation, then.
Yes, reverse interlay is what? See here in this technique, my graft and the flap is attached to the superior part,
Yeah.
around the malleus.
Yes.
Now, if you have a perforation which is centered superiorly over the malleus, then I will leave it attached.
Yes.
I will leave it attached inferiorly. And then I will raise reverse like this. I will raise everything from there and leave it attached inferiorly.
Yes.
If my perforation is centered superiorly. That is reverse interlay. So depending upon the location of the perforation, and see I have gone beyond the perforation margins.
Yeah.
Quite often we have to use the reverse interlay, especially when we are doing, retraction pockets.
Yes, reverse.
Yes.
We have to do
Those are all those are superior problems.
Absolutely.
Anything superiorly centered, when problem is superiorly centered, that part you have to expose fully. So this is my, the tympanoid sclerosis, which has come out now. Can you see?
Yeah.
And see the mucosal margin fresh.
Absolutely.
Absolutely fresh mucosa, ready to take the graft. Can you see this?
Yes.
And this vascularized layer is amazing. What a bed for the graft.
Yeah, wonderful.
When I sandwich my graft between these two layers, you will see it looks so amazing to place the graft in the most physiological position between the epithelium and the fibrous layer. There is no question like which happens in underlay. The graft may medialize. It is all over supported by the mucosal bed and the canal all around. It cannot go, it cannot medialize. Then it cannot lead to blunting, which is the biggest problem with the onlay. So it obviates all the disadvantages of onlay and underlay. See the flap I'm repositing back.
It's already half covered.
Just to orient you what I have done so far.
Yes.
So what I have done so far, this is the hallmark of interlay, that I divided the tympanic membrane in layers. I removed the tympanous sclerosis. You can see now my mucosal bed is below and the epithelium and the fibrous layer is above, which in between I am going to interpose my graft. Okay. Now,
Kusum is asking Dr. Kusum Patidar that
yes,
there is no bleeding. How you control the bleeding besides local injection, local infusion, anything else you do?
Nothing. You inject the local and wait for 10-15 minutes. That's it.
Yeah. Satish, what is the anterior limit of your flap exposure? I mean, do you come right up till the handle of malleus?
I can. See, I told you, it is tailor-made. I need to go few millimeters anterior to my anterior superior margin. See, this is my anterior superior margin here.
Right.
And I raise till here.
Correct.
See, more than 2 millimeters beyond that. Can you see this?
Yes.
So my graft will be tucked beyond the margin of perforation. Can you see?
Yes. Because in this technique, that is the only area if we do not elevate well.
Yes, the anterior superior is the
graft will not come
important
up.
region. And it is addressed much better in this technique than any other technique.
True.
Okay.
And you've left a strip there up the incision.
Now, what you see there in the depth.
Satish, sorry, 2 comments.
Yes, please.
Hi, this is Ashish.
Yes.
2 comments.
Hey, Ashish.
Hi.
Hi, Ashish.
To be able to do this, your canalplasty has to be done very well.
But why? I can do without canalplasty. Why to unnecessarily?
No. In this case, he could, but usually there's an anterior superior overhang, and the area that Sandeep was asking.
Ashish, we have already mentioned. If you have a limited overhang in any area, you can drill away that.
Yes. No, it is important to drill it away. Otherwise, your instrument keeps butting against the short process of malleus.
Yes.
That area in which you have to elevate anteriorly, what Sandeep is asking now. There, it's very important to have a good exposure, a bony exposure.
Yes. See now, everywhere I can show you the annulus. Can you see?
Yeah. In this case, we can see this is a wide canal.
So that part we have already discussed. We cannot do blindly anything.
Yes. Okay.
Now my second part here. Yeah.
Other comment of Kusum's, why no bleeding? I think bleeding is afraid of Satish. If you see even in angiofibroma, Kusum, I hope you get
there was a lot of bleeding in cadaver.
Because
now see what I'm doing. Now what I'm doing, this is eustachian tube orifice. Can you see?
Yeah.
I'm flushing it to remove any mucus plugs. Can you see this? See this mucus plug?
Yeah.
See what I mentioned about the eustachian tube in the beginning. Like the middle ear is like lung and eustachian tube is like tracheobronchial tree. See, lot of things, lot of work has been understood about the eustachian tube, and the maximum work done on the eustachian tube. I salute that man, Jacob Sade, who is the father of eustachian tube, physiology. Jacob Sade, if you go through his publications, amazing work and understanding he has given us about the eustachian tube. So what happens, these mucus plugs, why do we put ventilation tubes? If the mucus plug block the eustachian tube, the resultant negative pressure, if you just puncture the tympanic membrane and push the air inside, the mucus plug is propagated and everything reverts back to normal. That's how the ventilation tubes have been working. So here we take the advantage of this exposure and flush the eustachian tube of any mucus plugs. Many times instead of long-standing perforation, I have seen we have removed flies, mosquito from the eustachian tube orifice lodged inside. And lot of times
matchsticks.
Yes.
Matchsticks. People have a habit of picking the ear.
Yeah.
And these being long-standing perforation, the broken matchsticks we have removed from that. Now, this small maneuver, flushing the eustachian tube, though it's not a big maneuver, but that helps you preventing from such disasters by means of, if you don't do, you can leave the matchsticks, foreign body, anything lodged behind, and they can be a source of infection later on. So that was my second part. The first part was elevation of the flap, removal of the, that tympanous sclerosis, keeping the flap back in position now. Now I'm elevating from behind. Now my second part is assessment of the ossicular chain. That is very important. And
Satish, sorry, a small comment. You can also use the flexible vein flow and actually pass it into the eustachian tube orifice
further, yes.
and flush.
Yes, you have a slightest doubt, you can do that.
Yeah.
See now what I'm doing?
Beautiful.
Just to show you the incus better. See this?
Yeah, very good.
Ashish, this my Karlsruhe's curate is now 15 years old.
Very loyal.
15 years old.
Important. Investing in the right instruments is the most important thing for a surgeon.
I have many a time shown, you can see on YouTube, in every surgery I mention about this.
In Satish surgery, we'll see it more in action.
Yes.
But this overhang removal, I think every otologist from the first case onward should learn, because this is really where the whole action is. And exposing, I call it the dharavi here. The incus is there, the stapes is there, the facial nerve is there.
This is your chorda tympani. And some edematous mucosa over it, because the mucous discharge were there. This one. Now, how to check the ossicular chain here, mobility? Now everything in view. Can you see when I elevate the malleus?
Yeah. Okay.
And this is, I had no doubt. So just to check is a part of game. And see this absolutely intact? If there is any doubt, mucosal continuity or anything, I would not think twice and do an ossiculoplasty at the same stage. Okay?
Most of the time we get
look for the round window reflex.
If you want to see, you can check. If you have doubts about the round, you can check the round window reflex. But why to? I have no doubts about it.
No, not in this case.
See, this is the round window here.
Yeah,
we'll show in other cases. We'll talk about it later.
Satish, most of the time
we get... Can you see the round window reflex?
Yeah.
Yes, very clear.
See now the round window?
Yeah.
Very clear. Okay?
Yes. Satish, most of the time we get a medialized handle of malleus attached to the promontory or very much. What is the protocol?
My protocol is I would never advise to cut the stump of the the tip of the malleus. If it is really bothersome, you can cut the tendon. That is, I would say, a better alternative than cutting the nipping the tip of the malleus, because that takes away, that results in hearing loss. It is See, now what I have done, I have reposited the flap back. Now we have explored the middle ear. See now from beginning, a same perforation. I have reposited the flap back. If I elevate, you will find the mucosal layer separate. See this?
Because there is one comment.
Very nice.
If there is a high jugular bulb, then this interlay technique will prevent the tear of the jugular bulb, because
you have to be more careful.
Yeah.
But that is good. Then interlay is much
good.
better.
Yes, interlay is much better. I'm saying this.
That secures.
Yes.
Now see, everything I have reposited. I have checked the eustachian tube, raised the flap, checked the ossicular chain. I have not harvested the graft, as I told you. We'll harvest the fresh graft. Now I want to check one more important thing, and that is whether my eustachian tube, this thing, middle ear mastoid hair cell system, is aerated down the eustachian tube. Now, indirectly, there are ways to predict. Indirectly means if you have a dry ear for long, you can assume that your aditus is patent. Then, but that may not be 100% true. We have seen in up to 8% of the cases where the ear had been dry for weeks, and yet we found the aditus blocked by thick mucosa, tympanous sclerosis, granulation, and other things. So now the second way is, see what I'm going to do. I'm going to check from behind. That is not mastectomy, that is not enterostomy, that is not keyhole. That is test. The moment I find the patency, I will stop.
Eyes gola.
To ensure that, eyes gola test. To ensure that my mastoid hair cells are patent, being aerated down the eustachian tube. Now, other way, nowadays, people can think of using telescope. You can use a 45-degree telescope from middle ear side, and you can see the editors per se. And you can pass your probe through the editors a little bit. What you can get a fairly good idea, but it's still not 100% sure, because many a time we have seen the editors being patent from anteriorly and being blocked from behind.
Yes, yes.
So why to take a chance? What we are striving from, the results which every technique is giving 90% or so, we are striving for close to 100%.
Correct.
That's why this grafting of the tympanic membrane, we are not going to take chance and do an interlay. We Eustachian and tube function test and examination of the Eustachian and tube intra-op, the middle ear ossicular chain system, and now this mastoid air cell system. And this is a simple test. Believe me, if it is patent, it will not take more than a minute.
Yeah.
But yes, if it is blocked, this is blocked, and if you don't open it, this would have been a disaster.
Yes, yes.
That
So
could
you might even
to the overall failure.
Yeah, so you might even do a complete cortical till the time you achieve patency, you mean to say?
No, I'm not going to do any cortical.
No, correct. Till the time.
Till the time.
The moment I get the patency, I will stop.
Yeah.
And see the area.
Cotton ball there. Watch the cotton ball there.
Correct.
The first
yeah, this is for Icegola test.
Icegola, yeah.
See now this point I will emphasize here. I have seen a lot of complications done by junior colleagues.
Yeah.
Yes.
Even facial palsy. The last case I demonstrated in the Udaipur conference was an iatrogenic facial palsy done during this maneuver. So why? That we need to know our trajectory of drilling to stay safer and above, to stay from the lateral semicircular canal below and facial. Now you're supposed to stay above, and I emphasize again and again in the cadaveric dissection, take the landmark of this temporal line. This is the posterior superior part of the canal. Stay superiorly along the temporal line, because the tegment plate is another few millimeters above the temporal line. If you have to go deeper, define the tegment plate better so that you can stay further up, so as to avoid staying below and injuring the vital structure. Like Ashish mentioned last time, if you are going deeper, you have to go more wider superficially. You are not going to
width before depth.
Yes, so you are not going to dig a well that way.
The first air cells are coming up.
Yeah.
Is that right?
Yeah. Yeah, see, I am defining my limit so that I don't damage anything. See, my all around the limits are very clear.
Yeah.
And moment I get the patency, I will stop. That I have already told you. I may have to go right to the editors to acquire the patency if I don't. See now?
Exactly. Yeah, we already
Can
got
you
it.
see the Icegola?
Yes.
Yeah.
Let me show you better. See this?
Yeah.
Yes.
So the cotton ball is getting blanched. All the water
See,
of the saline is getting sucked.
Because this air cell so laterally.
Yeah.
So laterally, I have not reached the antrum. See this?
Took him exactly 30 seconds.
That means my air cells are being aerated down the Eustachian tube. My editors is patent.
Correct.
I don't need to go further down. I told you this is not a procedure like mastectomy, cortical mastectomy, enterostomy, nothing.
Correct.
It is just a test.
Yeah.
Now we have 100% surety that my editors is patent.
Yes.
Rather than relying.
I have two situation-based questions.
People to not go beyond this drilling.
Yeah.
Because then you are disturbing the mucosal architecture.
Yes.
By further drilling and trying to look into the antrum, you are actually likely
Why to? It is not needed. That is not our
needed.
goal.
One, not needed.
A very
Two,
good
should
point.
avoid.
Now see, Ashish,
Yeah.
the patency should be freely patent. See this?
Yeah.
Yes,
True.
fantastic. Very nice.
Really? Yeah, they say that.
Satish, I have two situation-based questions. Can I ask?
Yes, please.
Yeah.
Feel free.
So first thing is now you are doing this case and you have had an X-ray mastoids done, which shows good ventilation, good aeration, pneumatized mastoid.
That doesn't show the present picture.
Yeah, but would you do?
See now the full patency. Keep on. See this?
Yes.
I am pouring water from this side and sucking from this side all the way. It is completely patent. Same thing we can do on this side as well. Either way. See this?
Yes. So this means you would do this in every case?
Yes. So how long did it take?
Yeah.
Less than a minute.
Except traumatic perforation, I think.
Except traumatic is different.
Yeah, because
the last traumatic non-healing.
As usual, there's a lot of debate on this.
Yes.
Always there's a lot of debate.
There are so many.
I think there are those two schools of thought.
Exactly. And
see,
more and more often we are now doing this.
Boss, for debate there is every issue, and now people love debates for the sake of debates. But I told you very clear, this is not cortical mastectomy.
True.
This is not enterostomy. This is a test to check on table. This is my 100% test on table that my editus is patent.
And this is truly logical.
Now, any test besides this is not 100%.
Yes.
Why to take a chance?
Yes.
See, now we have taken care of everything. The mastoid air cell system, eustachian tube, tympanic membrane, ossicular chain, as I mentioned in the beginning, this is middle ear cleft reconstruction.
Yes.
Now my last part, see, my bed is ready for grafting.
Yeah.
Everything inside?
Yeah.
Absolutely clear, ready for grafting?
Yes.
Now I will harvest the graft, and that will be bed-to-bed grafting.
If the editus is blocked, how far will you go?
Pardon?
If the editus is blocked,
then
how far you will go?
Yeah, I will go right to the level of the editus.
And widen that. Preserving the
widen, yes. I will go right to the editus. We see editus, we know, lateral to the lateral semicircular canal anteriorly, deep to the fossa incudis. I will go and widen the editus, remove any mucus plug, tympanosclerosis, granulation, fibrosis, anything. I will clear both the spaces, lateral and medial to the incus. See how the middle ear, the editus is being aerated through the incudal spaces, medial and lateral to the incus. So those spaces leading to the editus, I will clean. So I will clean from both sides then by thinning the canal wall from this side till anterior part of the editus, and from that side both the incudal spaces, and communicate completely until we get a free flow.
Correct.
And it doesn't mean cortical mastectomy. It doesn't mean cortical mastectomy.
It doesn't mean, and sometimes you have to
not at all.
Significantly.
I am again and again saying there is no term like cortical mastectomy or enterostomy I am doing.
Yes.
Now my last part of this surgery is the grafting.
Satish,
and we believe this fresh graft makes a difference in terms of a faster healing, better healing. See the graft?
Yeah, very well.
Yeah, very nice. So what
now,
you do
first of all,
malleus medial mucosa, you can say malleus mucosa.
Pardon?
What you just do for the suppose handle of malleus, we get you will take it out the mucosal part or just.
Yes, I have already, along with the. You see,
this is very important step. This vertical fibers for junior colleagues.
Yes. So malleus tip and around that the mucosa has to be elevated. That's why during the initial, freshening the margins, I elevated that excess layer and uncovered the malleus, if you remember. See now?
Yeah.
This is the true deep temporalis fascia. Can you see the underlying muscle through it?
Yes.
Very nice.
So once it comes to grafting, since this is going to be a free graft, it has to acquire vascularity. It is not vascularized graft. So the ideal material should have a minimal metabolic requirement.
Yeah.
Muscle or anything, they get necrose because of their high metabolic requirement. All the excess tissues I have removed and kept only deep temporalis fascia. See this?
Yes.
And you can see your muscles, your vessels through it. Very clear.
Yeah.
Now, raising this, I have to elevate this from the underlying muscle because I don't want to traumatize the muscle. See this, my needle?
Yeah.
And injecting some saline to lift it off the muscle. Why so? Because if we traumatize the muscle a lot of people complained of, because the muscle undergo fibrosis, scarring, a lot of people complained of pain behind the ear. Pain above the ear post-surgery, and we keep on ignoring that part. Sometimes label them psycho. So this part of the, here we have to exert little extra care to avoid
any muscle injury.
Injuring the muscle.
Means cutting should be without bleeding.
Yeah. See now, with experience, what we do now, we measure the required size of the graft on the bed. So I will not temper the graft at all.
Okay.
See this graft?
Yes.
Yes.
See my instrument through the graft.
Yes.
This is a very common surgery, the commonest of the otology surgery, bread and butter surgery of ENT. And in this time, we should not take any chance of giving a failure in tympanoplasty. So this is, all these things are, being taken care of to reach close to 100%. Though in science, nothing is 100%. See now the underlying muscle, mucosa, the vessels, everything.
Yeah.
Nothing damaged. The graft dimension, we have already seen what is required. See now?
Yes, very nice.
And I will elevate it and turn it upside down. The muscle, the area, the side of the graft facing the muscle would face the undersurface of the tympanic membrane. See this? Without damaging anything underlying. See this?
Yeah.
What a graft it is. See this?
Yes.
And I will turn it upside down and place it to the bed. See this? This is going to be bed-to-bed grafting. Ashish?
Centralize, please, centralize.
See, no bleeding from anywhere. Is Ashish there?
I think he's left.
So just reverting this means you keeping two surface on the side doesn't make a difference in outcome also.
Yeah, it looks. See, this is because of the surface tension effect.
Yeah.
The surface which was facing the muscle, if you oppose it, because this graft is going to stick by means of surface tension effect. I'll show it. See now?
Yeah.
Now my graft, placement is the simplest of all technique, because I have a bed.
Yes,
I have to lay it over the bed, and believe me, people who talk that handling this wet graft is difficult, fresh graft is difficult, believe me, simplest. Now, the reason I will tell you. The first part of my grafting is advancing. See this?
Yes.
It becomes difficult in a dry graft.
Yeah, dry graft sometimes becomes so stiff.
You have to wet it again to push it.
Yeah, it doesn't follow your commands many a times. See now?
Yeah.
The first part is advance as much as needed. Calculated advancement. Can you see?
Yes.
And spread it over the canal wall. Can you see again?
Yeah.
Every part of it. Anybody has any slightest doubt, feel free to interrupt me and ask. Don't think it is a simple surgery. You don't have to do anything more to it. We have to learn this. This is the commonest of all surgeries,
Yes.
See now, advancement.
Yeah.
Now my second part of grafting is replacing the flap back onto the graft. See how simple it is going to be.
Yes.
See this?
Zoom in.
Yeah. Now since I am going to manipulate anteriorly, see I have just advanced anteriorly. Now not done anything. Not tucking anything. And I have replaced, see this flap back. Can you see?
Yeah.
And this is the graft.
Yes.
See the fresh graft, the beauty. Looks like a vascularized graft. Can you see?
Yes.
And I will make this graft and the flap one unit. See this by means of surface tension. Can you see this?
Yes.
It sticks so well. See this? Now if I deposit it back, whatever manipulation I do anteriorly is not going to affect the graft at all. It is not going to displace from behind because it is stuck by means of surface tension so easily. See this?
Yeah.
That graft. That a dry graft will not. Now I will elevate the anterior part of the flap. See this?
Yes.
Yeah.
And whatever graft I have advanced anteriorly, I will lift it and place on the mucosa manually, so easily.
Yes.
Since we have a bed all around, what you need to do is You have to ensure that your graft comes onto the bed everywhere. See this?
Yeah.
See this? And now I will reposit the anterior flap back as well. See my anterior flap back into place?
Nice.
Very well. Very well.
Annulus to annulus. Yes.
Yeah, it gives the whole physiological contour immediately.
Yes.
Yeah.
See my middle ear space? We never put gel foam.
Yes.
See, space is well maintained.
Absolutely.
Yes. Because your flap is
It is maintaining all physiology what we are supposed to. The more you damage the physiology, more it is worsening the situation for long run. I believe
Maybe
me.
you can talk about persistent otorrhea following tympanoplasty. Of late, the cases have increased.
Yes. See now. See now. I will come to it, madam. The same point. See now. Let me. Now see.
Clear.
Can you see the graft?
Absolutely.
It looks like it is new vascularized.
Absolutely.
And what is there on the graft is a thin layer of flap and tissue. See this?
Yes.
This thin layer. See this? There is no question of mucosa anywhere coming onto the graft. Madam, you asked about the persistent otorrhea. The biggest cause of persistent otorrhea is the mucosalization.
Yes.
Now, I will check each and every corner whether this sandwich, I call it as a sandwich. What is sandwich? The mucosa in the medial most part. See the mucosa there?
Yeah.
Graft in between and the flap above.
Yes.
I now will check whether my sandwich is in order everywhere. See posterior superiorly?
Yeah.
See, this is going above the incus. Can you see?
Yes.
Well in place, posteriorly well in place, and posterior inferiorly also well in place. See this? I will repose it. I will check 360 degree. And this is, everything is holding because of the surface tension.
Yes.
You know? See now? In order? Now, let me elevate inferiorly. Inferiorly. See, your use of a suction is very, very important. A control suction is essential. Now see, this is the graft.
Yeah.
Yes.
What is there underneath the graft? That is mucosa. Can you see?
Yes.
Yes.
Mucosa, graft, and the flap. See everything in order?
Yeah.
Those who have any doubts that this technique leaves any mucosa above can see themselves. This technique, believe me, is the closest to the physiology of the ear. That's why we love it. And that's why you get the best result out of it.
Yeah, and this free anterior edge has to be well ensured that it is not curled. The free anterior edge.
Yes. Because the epithelium should advance.
Yeah, and it becomes, the whole area becomes loose because we have mobilized it from all around.
Yes, the epithelium should advance.
Correct. And in
See
fact,
now see my sandwich is in place and I'm literally pressing on it. These two layers to sit on the mucosa so nicely. See that?
Yes.
Now coming anteriorly, the same thing.
Do you think that the concept of that epithelium strip, that is vascular strip, has changed in this interlay?
That is the area, Satish, very important.
Yeah. See now, what is this area? Why it is important?
Yes.
This area bears the brunt of pressure change. You check in tube orifice.
Yes. That is the most
And see, this is my margin of perforation here. And see how beyond I have gone.
True.
I tucked my graft beyond, more than 2 millimeters beyond. See this?
Yes, exactly.
See this? Whatever the pressure change is there, it cannot affect. See this?
Yeah. In which situations you'll denude the handle of malleus completely?
Completely, if I have any single doubt of epithelialization or mucosalization beyond, and if it is too medialized, it is mucosalized more, you can do.
And then
No need to put any gel foam in any case. When you put gel foam in the middle ear.
Never. See, what we want, the Eustachian tube to function and aerate. I told you in the beginning the function of the Eustachian tube. Okay?
Yeah.
Now, by means of putting a gel foam in the immediate post-op period, you are creating a situation of the deliberate situation of negative middle ear pressure. That can affect the outcome.
Your experience with PRP in a small perforation, have you ever used?
PRP, I feel it is good. Small or large. We have tried even in some patients. See, after putting this graft, if I pour the PIP, I believe it will help, healing.
Yeah.
See now the mucosal epithelial margin everywhere.
Beautiful.
See your perforation margin.
Yes.
All around 2 layers. And see the cone of light anteroinferiorly.
Exactly.
Yes.
Here it is, because this is the most natural situation of a graft, which is interposed between the epithelium and the fibrous layer, like God has given us, epithelium and mucosal layer. We haven't disturbed anything. This is malleus, you can see.
Yeah.
We haven't disturbed anything, what God has given. No area left behind. See the mucosa to mucosa, the skin margin to margin. No area left behind. Yes, pardon, boss?
Yes, your graft is medial to malleus or lateral to malleus? Because there's
medial, always.
Yeah, it's medial, yeah.
Always. That is how it should take the malleus into it for its proper functioning.
And that is also the reason, Rajeev, the hearing results with this, even if the anterior angle blunts a bit,
that is the biggest problem with the only technique.
Yeah.
Yes.
Now, the next thing what I'm doing, see with this, such a secure placement of the graft all over the mucosa, all over the annulus, do you think this graft can medialize?
Not at all.
Even if you mechanically try to disturb it, it is all fixed all around by means of surface tension.
Absolutely.
It is not tugged at one place. It is tugged all around on a surface, not in a corner or anything. Many a times what happens if you do an underlay tympanoplasty for such a big perforation? What will happen? In the post-op, if anything negative middle ear pressure develops and your graft happens to fall in the middle ear, what is going to happen? A graft falling in the middle ear will get necrose.
Yes.
And the necrose tissue will turn invite infection. And then you believe the infection is a cause of
Satish, this is my only reservation against, cartilage tympanoplasty, because cartilage can never be molded. However thin you slice, it can never be molded along the entire. Of 360 degrees graft.
See,
there's so many questions.
I tell you, almost in last so many years, almost 50,000 cases have been done here.
Absolutely.
This is a high volume center, and this being one of the commonest surgery, and this is amazing.
Absolutely.
This is most natural, closest to the physiology. See now, see my inferior margin.
Yes.
Very nice, natural.
Yes. So now I am pushing my gel foam, soaked in the blood in the field. See this, I am taking the advantage of blood in the field.
Yeah.
Containing the fibrin, natural fibrin.
Yes.
No gel foam in the middle ear.
Your posterior canal wall, you just trim it out to make it more thin, or it's okay? This part.
No. Why too thin? See this, the middle ear space again. See this.
Yes.
Good space.
This is natural. You don't have to do anything to it. Absolutely natural. And now with this fresh graft and all healing margins all healing margin from all around, where this graft is going to serve as a scaffold. The rest of the two layers are going to heal over the graft, and the mucosa, now so well supported, is going to creep under the graft, and this will heal in no time. So this technique gives you the fastest of the healing of all. Now, if any other technique gives me advantage over it, I'll go for it. I am very open.
No, in fact, we are coming out with a paper, Satish. We've analyzed 738 cases.
Yeah, we have published this.
Yeah, so this is I think the only reason for a tympanoplasty to fail in type of perforation is a fault in technique. There is no other.
Yes.
I'm a firm believer that the patient's variables are actually. We've all operated in gross deviated septums to the same side with a good result, and sometimes you get a bad failure. So I think it's nothing but bad technique or improper technique, which is the reason for failure and nothing else. Patients' variables are
that has a
really
very strong impact. Biggest determinant.
Primary failure.
Yes.
That is for primary failure.
Primary failure.
Primary failure.
Not for secondary.
Antibiotic. Which antibiotic is there?
This is soaked in ciprofloxacin dexamethasone ear drops, the gel form. So that acts as an antibiotic, anti-inflammatory. See now, edge to edge. See this incision?
Yes. Satish, in cases where sometimes the anterior canal wall is so thin, and while elevating, we tear it, or there is a little raw area anteriorly. Anything different you need to do here?
Yeah, you can apply some little bit of the split skin.
Okay.
Or split thickness skin graft, whatever.
Yes, because in such situations, I just put a thin silastic from normal skin to near the drum, and just keep it for a few weeks and then remove it. It heals very well.
Yes, that's the secondary healing.
Secondary healing. Yeah.
Post-op, what's the protocol for antibiotics and anti-allergic? What is the protocol when you recommend to give ear drops in your cases?
Hello.
Yeah.
boss. Mic idhar la dena.
So your post-op protocols means when you ask to take the pack from the ear, what antibiotic, and you start any anti-allergic, how long you give the anti-allergic, any nasal drop post-operatively, just share all the.
Hello.
Yes, hello.
Yes, antibiotic, a broad spectrum for a few days, and nasal drops always. We always give decongestant.
Yes.
See, every management is centered around optimizing the use taken tube. Right from the assessment, right from intraoperative part, and now post-operative as well. So we give a very minimal dose of, betamethasone tablet for few days as an anti-inflammatory for the mucosa.
Yes.
And the use taken tube. And decongestant, obviously broad spectrum for few days, and we put a canal pack, canal ointment pack, and then we remove it after 7 to 10 days. And the gel form we don't disturb.
Yes.
If your gel form remains in place for 2 weeks, assume that everything is done. Perfect.
Yes.
Everything is taken up, and this is what I've demonstrated is our proposition, how we do this. Taking into care all the aspects of, failures, how you can avoid this. And a lot of people who have visited us, gone back and done hundreds and thousands of such procedures have got good results.
What about your other approaches when you recommend endural or perimetal or always in post-op approach?
Approach doesn't matter. That outer approach doesn't matter whether you go post-oral or endural, how you are used to it. I told you, Dr. A.B.R. Desai and Ashim, they always do mini endural. See, from the outer exposure, whatever exposure, you get good exposure for inside. It is the inside work which matters.
So many patients are asking about, please do this with laser. without any.
Charge them and do the usual.
There was this funny concept called as laser welding of the graft.
Yes.
So boss will comment on it.
See, in our science, a lot of people are doing some or other funny things to stand out different.
Exactly.
That is one aspect nowadays, to stand different from others. For no reason, for no logic, for nothing.
Yes. Absolutely.
No words for that.
Correct.
So our next case is ready. Our next case is a quick, we had a lot of requests about the sinus surgery again and again.
Yes,
So keep a quick overview, review what we had done earlier. We have already shown sinus surgery a couple of times.
Yeah.
So this is a unilateral FES. We have already discussed in detail, so we are not going to go in that much details. Yes, we can take questions all the time.
Yes.
And meantime, the other theater is getting ready for our next case of carcinoma tongue for a supraomoid neck dissection with a partial glossectomy.
Okay. So Satish, the take-home message of this tympanoplasty. What are the things?
Take-home message is, don't take it as mechanical. There is a lot of science behind this. This is not simple puncture repair.
Correct.
You have to look at the middle ear cleft as a whole.
Yes.
If you don't do that and try to find out other ways to, improve the results by bringing in, for the sake of standing different new techniques, it's not going to work.
Absolutely.
You have to go to the physiology. People, I don't know, but they have to understand it.
Correct. So in order to get from 99 to 100%, we have to do this.
Yeah,
there is anything. Yeah.
And you are using other than temporalis fascia? Any
Not really. Sometimes we have used the stragal perichondrium. Sometimes, but there's no harm in that. Is also a very good graft material.
Yeah.
Your views on cartilage tympanoplasty? Again?
Cartilage?
Yeah. Your views on cartilage tympanoplasty?
With this technique and this much of a graft material and with this much of the exposure, again I tell you, interposing a cartilage to give a thick membrane to prevent retraction, believe me, is a wrong concept.
But why so many people all over India? You get.
I told you, every
fill the
technique
middle
works.
ear with palisading of
Every technique works with over 90% results. I'm not saying anything wrong.
For those 10%.
For the betterment. So, if you use a cartilage nowadays, thin slice cartilage, people are doing with excellent results with same vibration like temporalis fascia. It depends how they are so used to and giving good results. It is good. I am not against it. But the kind of vibratory activity of the tympanic membrane nature is given, which is replaced by this fascia, is unmatchable.
Absolutely.
What is your protocol? Suppose patients comes to being operated 2-3 times by good surgeons, and all the nasopharynx, everything is fine. In spite of that, he's getting a recurrent perforation or failure of the surgery. And how you will manage that? What your protocol? What investigation you will ask for, and what will be your procedure?
Okay. I just like Sandeep Bose told, there's always the technical aspect involved in failure.
Right.
So like in this surgery, if you don't, I tell you number one by one, when you make the margins perfect, raw, if you leave somewhere the margin intact, it is not going to heal.
Yeah.
Graft, if you don't properly sandwich it all around, it cannot work. If by the time of separating into layers, if you leave the epithelium below, it is a disaster. If you don't check the patency properly, it may not work in long run. If the Eustachian tube functions are not evaluated before, it may not work. So everything what we have discussed is looking into the consideration, taking into consideration all those factors which otherwise can result into failure.
Absolutely.
So this technique takes care of all the lacuna disadvantages of any other technique. underlay, only.
We may have case. We may have next case next week. Yeah.
And beauty is maintains the physiological situation. This is closest to the physiology of what nature has given us.
Absolutely. And the biggest is successful and proper placement of the graft under vision, 360 degrees.
Yes.
is what is the key, because whatever failures we have analyzed of us or the surgeons who refer the cases or the failures to us, we've seen that it is the typical anterior or the antero superior under placement, not under good vision, is the key to failure.
And second reason for the discussion, for the sort of contradicting, a lot of people contradict various techniques.
Yes.
And those are the people who don't really have practiced all the techniques, do one thing and then propagate that without even looking into other techniques, whether they are good or not. So those who have any doubts about this interlay, I'm always open. Practice this. Practice this in few cases, see the result, and then come out with your own verdict. Rather than without doing anything and then contradicting, there is no issue in that kind of a discussion.
Absolutely. In fact, now more and more interlays being done for all size of perforations. You can even do it for anything. It just makes you feel more secure. No doubt about it.
What about your middle-ear tympanoclerosis we get during tympanoplasties, and what your protocol again?
For tympanoclerosis?
Yeah. We get
I was discussing with Ashish to keep a separate, session on tympanoclerosis. There are a lot of misconceptions. A lot of misconceptions about tympanoclerosis. A lot of concepts like tympanoclerosis cannot be, reconstructed to the level of good hearing. It can be. There are a lot of new theories about tympanoclerosis management, and we'll definitely keep a session on it. A dedicated session. Now, quickly about the next case.
Yes.
Are you getting the picture?
No.
Not yet.
No. We can only see you now.
Are you getting the scan?
No.
No.
Yes.
Yeah, now we got it.
Okay, so this is a classical case of unilateral pansinusitis. Can you see?
Yeah.
I'm not going in details of scan we have already done. I'm not going Yes, it's a three-dimensional, and you can see from most anterior to most posterior. That is the frontal sinus completely opacified. There is an incomplete septation. See this?
Yes.
Why I'm saying incomplete? As you go behind, this septa will disappear. See this?
Yes.
Yeah.
That is not a complete septa, and this is the drainage. This is the intersinus septal cell, which is draining. See this?
Yeah.
Yes, nice.
That is intersinus septal cell, the most anterior cell after the sinus. And then this is Agarneji cell. This is the middle turbinate.
Yeah.
Complete opacification, complete whiteout on this side, the middle turbinate here, which looks like not very strong, looks like atrophic, a little smaller than a complete blockage of the osteomeatal unit, and giving a classical whiteout, unilateral whiteout. Can you see?
Yes.
There is a halar cell, Satish.
This one?
Yeah.
Yes.
Yeah.
Good point. This is halar cell. See this? This flat halar cell. This is flat halar cell. And what it is contributing to? This is narrowing the axis of the maxillary sinus.
Yeah.
See this? So we will corroborate also this intraoperatively. And there is a septal deviation. See this? Spur. In case required, we'll correct it endoscopically as well. A lot of people wanted to see endoscopic septoplasty also. So we'll do here the role of correction is to improve the access, at the same time give a good access for the post-op irrigation and preventing adhesion, synechia. So we'll quickly go about this. We have already discussed a lot about the
Satish boss. Satish boss, there are a lot of questions which people have asked me. that precautions you are taking in this COVID era, not only for mastectomy, for all. I mean, you have told this in your previous sessions, but then they want to hear from you again.
Yes. So pre-operatively, right
They want you to
screen them outside the hospital, screen them with thorough history and everything, and then for that matter, besides the OPD of the theater, we always we are done 19, and in spite of being negative, because they were 100% reliable, like government advises the level 2 PPE.
Correct.
So that is what you can do.
And any tapes around your microscopes or something
same,
like that.
Same.
All
those the microscope.
Correct.
Satish is such a great academician in this RT-PCR threshold and other things.
Exactly.
You can imagine what application for COVID will be.
Absolutely.
Now, I know somebody just raised that stupid query about Satish and the COVID safety. Ultra safe.
Absolutely.
All his staff
And
is a man of a nth order.
Absolutely. I mean, I am sure that one who goes for 100% results will never compromise for even 1% safety.
I mean, the repeated swab that they take, it's incredible. His protocol.
Ashish, this was one of the reasons I got this, about what has been happening.
I'm just
over
contributing
the last
my bit
24 hours.
to the.
You never know who is affected and asymptomatic.
Absolutely. And one thing which we started doing, Satish, in addition to being thorax for all patients, because that can pick up about HRCT. Because 30% false negative RT-PCR and 30% false negative for
even earlier
can take us about 80%.
According to the guidelines, we were getting every patient HRCT thorax done.
Exactly.
Now, not for every patient, because government has withdrawn that guideline.
Yes.
Reached here. Okay. I'll join you back now. Just 5 minutes.
Earlier, we were getting every patient HRCT done.
Right.
Procalcitonin, ferritin, D-dimers, all these things done, which we are not now, because now the concept has totally changed. It is giving pneumonia. Every day is a new concept. We got not what it is.
Now it's cytokines down all of a sudden. So they're starting steroids early.
Now again, or where nothing works, steroid works. The same philosophy.
And ENT surgeons are always fond of steroids.
And nothing works.
Always fond of steroids.
So the case is ready, and very soon will be.
CT scan.
Pardon?
Sorry?
For Dr. Sandeep said we are doing CT thorax for all the cases for tympanoplasty also.
No, not really. For local cases, no.
Only
but
for
then,
GA.
For GA cases, as a screening protocol, our hospital has put
It is a very sensitive thing. Sometimes even RT-PCR may not detect. The CT scan detects the change.
We've had cases coming. We've had cases coming to the casualty with HRCT changes. Early ground glass opacity. But their RT-PCR came negative, and they turned positive a couple of days later. So,
and second thing is the baseline PO2.
Yes, that's most important.
That is again very sensitive.
Most important. And they are saying that there's a sudden drop in PO2 even in healthy individuals. They are fine till 4, 5 days of even getting positive.
That is happy hypoxia.
Happy hypoxia. So the most important now is oximetry.
And also there is no role of X-ray chest also.
No, X-ray chest has no role. So, I mean, Rajeev, that's why we got this up, because there's a lot of things, people are talking about operating, not operating, showing, demonstrating in the COVID era. So, how can we be safe?
पहली मीटिंग में डर निकाल दिया
और बेचैनी से भी।
हाथ थामा, दिल जीत लिया।
मेरा बर्थडे सेलिब्रेट किया, मेरे लिए बर्थडे केक लेकर के आए।
हर दिन जोक सुनाया।
उम्मीद दी,
हौसला दिया,
आंखानी रोशनी की, मौत के मुंह से खींच लाए,
आसमान से मिलवाया,
दोबारा घर से मिलवाए, माँ से,
माँ जैसा ख्याल रखा।
हेलो,
Thank you, doctor.
Hello.
Thank you, doctor.
Thank you.
Thank you for saving my life.
Thank you.
You're my hero.
Hello.
Yes, boss.
Sun Pharma, reaching people, touching lives.
पहली
मेरे फालतू
मीटिंग
बात
में
मत कर, चालू कर
डर निकाल दिया।
चालू कर, हटा दे।
और बेचैनी से भी।
हाथ थामा।
हेलो।
Yes, boss. We can hear you.
थोड़ा दूर करे उसको। प्योर है ना, प्योर। उसको ले ले यार, अंदर करो। छिपे ऐसे जल्दी उसको बाहर लगवा दे। सुन, उसको बाहर लगवा दे। हेलो।
Yes, boss.
Yes, boss.
हेलो। हेलो।
Yes, we can hear you.
Okay, madam. Are you getting any picture?
Yes,
Yeah,
yes, we can see the endoscopy picture.
Okay. Now you see, as I told you, this patient has a spur on this side.
Yes.
See this?
Yes, yeah,
And
it's
that is
from-
something quite significant.
Yes.
So first of all, I told everyone earlier, we have discussed about this concept of the sinus surgery earlier enough. If still anybody has any question, we can always take, so that we can limit our session and concentrate on more and more cases, more variety. So the first part here, what I'm doing is, under vision, I'm debriding the polyp without traumatizing too much of the normal mucosa. See this? This is all massive polyposis is. See this spur is quite significant. Can you see?
Yes, yes.
And this was, this patient, we did our preparation for last 3 days.
Yeah, we can actually see that not as good prepared as your
Yeah,
cases
but
are.
it will, by other measures, it will come back to the same level. I will show you. So what I'm using here is a marrow cell.
Yeah.
Yes.
And here now the biggest thing is the septum, which is a big issue.
Yeah.
And that has to be addressed. You cannot ignore this septum.
Yes.
This much of the deviation we cannot ignore.
Yes, yes.
So we will correct this deviation by means of as well as lateral to the cabinet. Is the picture good there?
Yeah,
Yes.
it's okay.
Yeah, it's good.
I'm opening more and more middle meatus. See, the beauty of marrow cell is you can open up the space well.
Yeah.
It swells up and gives good tamponade effect as well. So now, knife. What
You do septoplasty before means proper
yeah,
press,
here,
or you
if I don't do before,
There will be lacerations of the mucosa.
yeah, it will again and again.
Oh, great, yeah.
Incision I can make anywhere. I am making at the anterior end of the deviation. See this?
Yeah. You inject anything before? Like
No,
local
I
or
didn't
saline?
inject. I didn't inject at all.
Yeah. Or sometimes you inject saline also. Which
Sometimes. I didn't even inject the saline here.
this is suction resector, or I think
See, that is a plane on this side.
Yeah.
This is on the spur. You have to be little careful here.
Yes.
So we'll do something to remove the deviated portion only. Because here our goal of, the septoplasty is very clear, to get access.
Yes.
Access surgically and post-op, both.
Both.
More importantly, post-op, yeah.
Right. Now, this is the lower deviated portion, which is the major cause, not the upper one. See, I am not going to remove the entire cartilage strip.
Yeah.
It's a little bit out of context, but it is this cartilaginous spur that Mahadevia sir used to use and Vijayendra uses for ossiculoplasty.
Ossiculoplasty, yeah.
Yes.
But this dense, this is very different from the rest of the cartilage.
सबसे पतला है. Yes, they use the septal cartilage.
Yeah.
The spur of the septal cartilage, yeah. The cartilaginous spur. Yeah. It's very useful in very narrow and deep oval window niche.
Yeah.
Are you using a suction dissector? Dr. Satish, is it a suction dissector?
No, doesn't look like.
Yeah, because suction dissector works very well for endoscopic septoplasty. Yeah, if the assistant can hold the suction and lift the flap at the same time, it becomes easy for us to work with the other periosteal elevator. Simple.
It tends to be a little bulkier though, but yeah, I get your point.
Yeah, I wish there was a finer one too, but I think it gets blocked. So
videos paused from your end?
Even the voice.
Yeah, it's not coming through.
Wait. Dinesh? Okay. Yeah, maybe some light noise.
So I think we can just carry on about that the cartilage used in ossiculoplasty. Nishi ma'am, you do use that? Any experience?
You don't really get septal spur at the same time when you need the ossicle, and if you're preserved for a long time, then I feel that preserved ossicle is better than the preserved cartilage.
Yes.
Strength is not that much.
Because, both Dr. Mahadevia used to and Professor Vijayendra, they use a lot of septal cartilage.
But where do they get it from?
Preserved one.
No,
they are
preserved
getting from
preserved.
every patient means
They preserve it. They preserve it.
for, I think,
and they use a lot.
In fact, I am using since 5-6 years preserved cartilage, and at Touchwood it's working very well. Almost 6 years. 70% alcohol.
70% alcohol. Yeah, we use this homo incus from our acoustic patient. We use a couple of times. Not that we have loads of this, but then yes.
Or sometimes the tragus one works very well.
Yeah, generally tragal or concal also suffice in case you want to.
And how long you can preserve it? 6-month-old, 1-year-old, or there is no limit in 70% alcohol?
We have kept 3 bottles. So once the one is over 6 months, then we change it and then we go to the other one like that.
So 6 months is the limit when you discard.
6 months is the best time.
Yes.
And osteoplasty is again a very wide subject. There are so many issues are there. There are so many controversies there. So till date, that's your choice. Your choice, it's absolutely your choice. Which one is better? All are good, provided which case you are getting and how much is affording, how much you are affording in time and this thing.
Yeah, and the end result.
And where are you trained?
My question is that if this tympanoplasty, in this tympanoplasty, if there is incodostapital joint separation or lenticular process necrosis, then what should be the ossiculoplasty of choice?
Yes. So
again, various thoughts here.
Yeah, various thoughts.
Some people just insert something in between.
That is, I think, my personal experience, that is wrong. Because
Same here. Even I don't agree.
Yeah,
It's better that you remove the incus, superimpose the stapes head. That works very well. Type 3 stapedofex.
Absolutely. Because ultimately
That was the old thing we used to do, but all these newcomers are coming with new concepts. So I also feel that just augmenting this suprastructure of stapes works better.
Yes.
So nowadays, I think the bone cement is what we are using more and more. And Satish will show you actually, if possible. This is not any cement. There's a specific cement that can be used just to close a small gap.
Correct. That monomeric cement, no, Ashish, that monomeric cement, the green filament one. Yeah.
Dental people use a lot.
Yes,
some light
but there are two types, and I have made a mistake.
Yeah, Ashish, did you get the picture?
No, not yet. Yeah, now getting it.
Now getting. Yeah.
Now getting?
Yeah, getting.
Yes. Now
I was saying hello. I didn't know what happened.
Some light issue was there at your end.
Okay. Anyway, I removed that limited deviation. Can you see that?
Yes.
This is my entire flap intact. This is very, very limited septoplasty I have given. See this?
Yeah.
Chona. This part of the deviation, see behind, is still there.
Still there, yeah.
Still there, yes.
Full.
Come out actually.
And this is your, polyp.
Yeah.
See, this polyp was not visible earlier.
Yes, now it has become clear. And this is just a cartilaginous spur, or there is bone also into it?
Yeah, bone.
Then you can drill that also maybe.
Yeah. See this kind of polyp completely occupying. See this?
Yes.
Right up to the coena.
How would I remove without,
doing a
removal of that spur?
True.
Dr. Mangal Singh from not related to this thing, he's asking what is the earliest stage of doing tympanoplasty? Means because that question was asked by many people.
Earliest? What is earliest?
Age for going for the tympanoplasty.
Age.
Yeah.
Age is no bar, but yes, if the child has a good use second tube function, we have done in children like 5 years or so.
Yeah, even we have done.
Yeah, because bilateral conductive loss in children can affect their overall development.
Absolutely.
Professor Majumdar from Pondicherry, he's just commenting Dr. A.V.R. Desai and Satish both are great. I always say A.V.R. Desai is the only ENT scientist. He was the first. He was doing mechanical engineering at that time. Then he left and he joined medical like that.
Oh.
He was doing what?
I always say A.V.R. Desai is the only ENT scientist. Secret is he was doing mechanical engineering and in Mumbai.
Oh, really? We didn't know that.
And he left to engineering college and then joined medical at that time. Professor Majumdar, he's saying Professor Majumdar from Pondicherry.
This Sunday we have the event dedicated to A.B.R. Desai, sir.
Ashish,
We'll get his comments. I didn't know about his mechanical engineering, but yeah.
Ashish, A.B.R. sir?
Yeah.
Everybody know him as an otologist.
Yeah.
Before that,
yeah,
he was a cancer surgeon.
Yeah.
He did it. He did his FRCS in that from Edinburgh, and he used to do a lot of colorectal resections.
Yes, abdominoperineal resection.
Yeah, he did PG in general surgery.
Oh.
Before that, he was an engineer. That is one more point we have just. So,
now see our area of interest.
Yes.
This was all access. This was all access, nothing else.
Yes.
And now our area of interest has come in exposure. The field is good now.
Yes.
Yeah. Very good.
Now earlier we had no space to introduce our instrument even. See that? Now everything is clear. My flap is, see this. There is no raw area. This flap will cover this.
Yes.
And here I have done this limited in the sense whatever is required for my access per op and post op. It's not that I have to straighten the entire septum unnecessarily. That is not going to change my physiology or any result. See that?
Yeah.
So this is a very, very limited septoplasty. In the end, we will suture it. See? Like this. And there is hardly any raw area. Marrow cell. So now quickly, see, every sinus surgery is interesting. एक suture मार दे. We'll just put a suture.
बीच में नहीं आएगा.
Yeah. I could have done it from the opposite side as well.
Dr. Viren Gaisai is saying, why not horizontal incision on this spur? So it means that.
Yeah, he does variety of septoplasties.
Yeah, he's the master of.
Yeah, he does extracorporeal. He would take the entire septum out and replace it back.
You know the reason why he does that? Because he doesn't know how to do it like this. He needs to.
He's our master.
He's the master of the nose.
Rhinoplasty, yes.
Rhinoplasty guru.
But he doesn't know there is an inside of the nose. He's only on the outside.
I'll just put a suture. So this is all about the excess. You can do it your way, anyway. And just quickly now, next 10 minutes, we'll do FES. And this patient, you can imagine the kind of nasal obstruction he had.
So the relief he will get is going to be immense. Yeah.
How often you get unilateral polyposis like this one? Because it looks like a unilateral polyposis, not a AC polyposis.
Yeah.
So other side is
more with the fungus many a time.
The step that Satish is doing now of suturing the flap is important. Otherwise, your endoscope or the instrument keeps going in that plane. So it's best to once and for all get it out of your surgical space.
Absolutely.
You know, this is important at this step. We tend to do it at the end. It's best to get the suture there.
And so see, I will do one more thing in the end. This turbinate is pushed. This turbinate is pushed because of the polyps on both sides, making it unstable,
And this spur,
Yeah, every face is not same.
Yeah.
There has to be something. That's why the variety adds on to a lot of things. See this was pushed by the polyps from this side.
Yeah.
In such patients with massive disease, though I can remove the disease with pushing this turbinate here and stabilize it. I can do a bolderization. I can do a lot of maneuvers.
Yes.
See, the first maneuver I'm doing here is microfracturing.
Yeah.
Yes.
See this?
Yes.
It's a cracks in the bone. I can feel the cracks.
It's the tactile sensation that is directing
it. Yes. And that makes this turbinate, close to the septum so easily. This is microfracturing, and I can put a small marrow cell.
Up to what extent you go, suppose you are doing cleaning of the middle to the middle turbinate polyposis, just to avoid damage to the olfactory nerves.
Yeah. So olfactory fibers are above the level of the axilla.
Yeah.
So never go behind the level of the axilla above. That's what I mentioned during cadaver, during flaps as well.
Yes. Upper limit of Haddad's.
See, behind this level, above on either surface, the septal as well as the lateral wall contains olfactory fibers. See now, having done this microfracture and press with this marrow cell, it works. And this will keep my now entire turbinate throughout the surgery,
Idealized, yeah.
Yes, close to the septum. Yes. See this?
Yes.
Very easily. See now the access to the middle meatus now? Better? Now? Now see, this is my uncinate process.
Yes.
Yeah.
This is lateralized because of the massive polyposis.
Yes.
This is bulla, which is so pinched out. So atrophic it has become because of
pressure.
Polyposis, the pressure of the polyps. And everything is important in terms of avoiding complications, because as this uncinate goes lateralized, you can enter into the orbit so easily.
It goes closer to the orbit, yeah. So you have to be careful.
If you are not careful, give me other forceps.
So for the information of all, he's using 0 degree endoscope.
Right.
And
so far I'm using 0 degree.
yeah, there's so many queries were there. That's why I'm just.
I will show you when I change to 70 degree. Okay, boss? Now direct it inferiorly, medially.
The halar that he has opened actually.
Yeah. I will show you exactly how halar cell can make your life difficult. See, once your debrider is a mucosal saving tool, you know. That's the interior of the the maxillary sinus. And what I want to prevent is stripping.
Yeah, the posterior wall mucosa quite often gets stripped.
Yes. That is important to prevent, you know.
Yeah.
But Satish, what actually happens if it gets stripped? If it gets stripped and you put it back?
No, it's a raw area that will heal by secondary intention, man. Raw area healing by secondary intention is a disadvantage. You want a primary healing. See now?
Yes.
That looks like the wall of the halar. One of the wall of the halar. Now, anyway, just don't get distracted. This is just a middle meatal enterostomy.
Yeah.
That we have got.
Yeah.
Debrider. I can widen it little bit. See, everything is unusual in this case, you know. Kind of polyps.
What was his serum IgE?
IgE raised 700 something.
Oh.
Good for him. For this better result.
Yeah.
See now my lateral limit. That is orbit. Can you see?
Yeah.
Yes.
Now my one instrument will do the rest of the job. Debrider. I am taking away this upper part of the uncinate. Now I know my lateral limit. See, this is a red 40 debrider.
Yeah. The uncinate has almost become flush with lamina, actually.
Yes. Yeah, that is lamina. Can you see that?
Yeah.
That is lamina papricia. This is red 40. I'm just not changing anything to carry out it faster. That's the medial wall of the orbit. You can see.
Yeah.
And see, still I am with 0 degree. Now I will go to the axilla.
Yeah.
Axilla.
So how safe is this microfracture of middle terminate? Will you recommend for everyone, because there are so many questions?
It is simple.
What are the incidents of doing CSF, rhinorrhea while doing this?
No. It's a gentle maneuver to be done inferiorly.
Yes.
Not to the superior part. It is very, very safe. Ultra safe.
And ultra short steps at a time. So he didn't do it in one stroke. Yeah.
See now, my all lateral and medial corridor is defined.
Yes.
This is my terminate. This is my lamina. And I've opened up the entire avenue. This is my maxillary sinus as a, landmark. And now I will take 70 degree to finish up the frontal in no time.
Yeah.
The frontal was a straightforward situation we saw.
Yes.
Not very big.
We have one more case for FAS, actually, the frontal sinus today.
Yeah, that's a complication case. That's a very interesting case we have today. We'll take later. That female patient having isolated frontal sinusitis, which led to orbital cellulitis. And patient had been taking injectables for last 10 days by some ophthalmologist.
Okay.
Now I am with 70 degree now for everyone. Hello?
Yeah.
As you can see that, yes.
Now, that is our frontal sinus. It was a narrow opening.
Yeah.
Let me open it wider. Yeah, give me a wash. Give me a Merocel. I hope the picture is good.
Yeah,
Yes.
wonderful.
Yes, yes.
Wonderful.
Yeah, let me clean it, mop it, make it absolutely bloodless. Because this is the point which is important.
Yeah.
Yes, yes.
Take all landmarks in view again.
There was an
See,
interesting.
earlier, had we not done a septoplasty, we would not even
Yeah.
be
Yeah,
able to
very
enter
true.
inside the
Very true.
nose. There was
I
no
think
space.
handling 70 would have become extremely difficult.
Yes. And
With this
I
small
told
dog.
you I will do something to this turbinate
Yeah.
when we use it as a landmark first at the end so that it doesn't fall. At the same time, I want a good access for my medication to go inside post-op.
The two landmark people are just asking. One is regarding maxillary line. Again, please. Last time it was not.
I will.
And the landmark for the nasal account duct again.
Hello.
Yes, yes.
Frontal झालं की alpha.
Yeah.
That was the other cell going towards the midline.
Yes. That is your frontal sinus. I told you that how narrow the opening was.
Yes,
Because it was not a complete septation, incomplete. And that is your frontal sinus. That is a little bit of the supraorbital cell.
Supraorbital cell.
And now see the things are very clear.
Yes.
Yes, yes.
Give me divider there, no?
So just enumerate the points when we get the lateralized of the middle turbinate or synechia, how we can prevent it, because many times we see lateralized of the middle turbinate.
This turbinate I will address. Will not let turbinate ruin our surgery, you know?
Yeah, yeah.
Knowing the fact that this turbinate can ruin our surgery,
yes,
you cannot allow it to happen. See this mucosa lies small opening.
Yeah.
Yeah, very, very small.
But since it is mucosa lies, don't disturb it.
Yes.
I can show you on the CT scan again how small it was. That was evident. That is the upper part of the ground lamella going to the skull base.
Yes.
This is this one.
Yeah.
And since the cellulite is not much, you don't see even the artery very prominent, but
yeah,
it should be here.
Yes.
You can see glimpses, little bit.
Glimpse of it.
Yeah.
Can you see the recess and the frontal sinus both?
Very well.
The supraorbital recess, this is the frontal sinus.
Yes, yes.
Very clear?
Yes.
And this is the thick beak. I'll show on the CT scan later again. And this is the medial limit, the turbinate. And this is the lateral limit, the bulla. And that is the skull base behind. See, very clear?
Yeah, perfect.
Very good.
See the skull base. Leave mucosa lies as much as possible. Now I'll come back to 0 degree in next less than 5 minutes. We'll be through. As the next case is ready.
Next case is ready. Okay.
And since the mucosa is good, we are not going to do anything more to the frontal.
No, nothing.
Nothing.
Nothing is required.
Yeah.
See my mucosa lies area.
Yes.
See up.
Yes.
And this access will allow the secretion to go. What we want, the solution to go, not secretions. The steroid solution. The steroid. Now we'll take straight. See now for your orientation now back with 0 degree.
Yes.
I hope you are oriented.
Yeah, very much.
Very much. Yeah, so people wanted to see about the maxillary line and
yeah.
Pardon?
maxillary line and landmark for the nasolacrimal duct again.
Okay.
Times, but
maxillary line is what? The level of the roof of maxilla. See this? Or the orbital floor. See this? So at this point of time, when you think of going in the ground lamella, see this? I enter the ground lamella.
Yeah.
And take this line as a landmark. See this line as a landmark. नीचे कर section. Yeah. See this line as a landmark. I am going medially. Even the feel of the bone in this patient is different. This is superior turbinate.
Yes.
I have gone medial to the superior turbinate. I am going to remove this lower part of the superior turbinate. See this?
Yes.
Now at this line, see the maxillary line. See at this level, I have entered the sphenoid sinus.
Yeah.
Just flush to the septum.
Yeah.
Flush to the septum. The beauty is, stay flush to the septum, and now I will remove this ground lamella and rest of the cells.
Yeah.
No time. See, even the bony septation is little surprising in this patient. It looks like earlier it was involved in too much of inflammation.
Yeah.
That's the postsigmoidal skull base. And we are going to... Yeah. That's the postsigmoidal skull base.
Yes.
I told you at the end I will address this turbinate when its job is done. That is all skull base, you know.
Yes.
That is all skull base. Now you can flush all these cells along the lamina. Along the lamina.
Yeah.
Lamina is a great landmark.
Yeah.
That is my sinus. And until I stay anterior to the sinus, ostium, I am safe, you know. I am totally safe. See this, all these thick septa. The septa are characteristically, you know.
Yeah, it looks like a rarefied bone because of the chronic disease.
Yes.
Yeah.
It's not like everything is, you know, unusual in this patient. We have taken some pieces for the, you know, histopath as well.
Yeah.
Can we predict this on radiology? Why?
Not really. There was nothing, you know, a sort of...
Even the bony trabeculations were not seen too well.
In a plain CT scan, you cannot predict. Yeah. And for that matter, it is still benign disease, same sinusitis. Diagnosis is not different. See the frontal sinus now? Oh, it's
sphenoid, yeah.
Sphenoid sinus now.
Yes.
This is interior of the sphenoid. And this is skull base. This is the job done on this side.
Yes. What is the age of the patient?
Age is 35.
Okay, that's good.
See this?
Yeah.
Now what I will do to improve, I don't rely on this turbinate for that matter.
Yes.
Give me scissors. I will see this. I want this access to all my sinuses for the post-op. See that? So I will trim that, leaving the upper part intact.
Yeah.
Because this is not going to contribute to anything but problems.
Dr. Prakash Mukha is asking you trim the turbinate in all the cases or
not in massive mucosal disease like this.
Yeah.
Number one, when the irrigation is the main step post-op treatment, and we'll leave a part of it. It doesn't affect nowadays. It has been now suggested to remove.
Yes.
Ensure that your your topicals go adequately inside.
And what is your comment on the ithmo-terminal concept?
Yeah, new concept.
So this is like, your all sinuses.
Yeah.
See, the mucosa in the maxillary is good. Otherwise, see this little bit, edematous. It is not irreversibly damaged. See, you are not going to be after any edematous mucosa to remove.
Yeah.
It's all allow them to come back to normal. Find out. And see now, good irrigation, no bleeding.
Yes.
Every area is almost mucosalized.
Yeah.
See this? What we have left. And see above the frontal, this is the skull base, this is model skull base, posterior model skull base, and this is sphenoid sinus. And see now, when you use your 0° in the post-op, everything should be visible.
Yes.
That is the goal.
That's a good end point.
Yes.
From the coena to frontal in one go.
Yes. And you should be able to irrigate thoroughly.
Yes, absolutely.
See, we removed a lot of raw area by means of removing that part of the turbinate, which are unnecessarily, otherwise not very, stable. At the same time, now there is no hindrance for the solution to reach anywhere. See that?
Absolutely.
It is so open now. See this?
Yeah.
Yes.
And everything. See the maxillary sinus from inside.
Yeah, beautiful.
See all sinuses from inside. See the skull base. It is mucosalized. See this irrigation, and everything looks good.
Yeah.
So this was just to, every sinus surgery we find some or other thing different. So we'll keep posting different sinus cases with different anatomy. Very soon we are going to keep Lothrops. We are going to give extended Lothrops, type 3 cell, type 4 cell, all those scenarios which can complicate sometime. So it's a huge, variety of cases. Name is FES, but so much of variations. Okay.
So what is the earliest age, except the AFRS cases, you go for endoscopic surgery like for polyposis?
Disconnect. What is the earliest age of?
Doing the FAS for the polyposis cases, not AFRS.
See, in children, the polyposis bilateral is mainly because of either AC polyp, AFRS, on young children, even cystic fibrosis.
Yeah.
And all are surgical entities.
Yes.
All are surgical entities. Secondly, the non-polypoidal sinusitis, most of the time you can take care by means of, adenoidectomy only.
Yeah.
You don't need a regular FES for most of the non-polypoidal sinusitis in children.
I think in one of the webinars, we did some 8-9-year-old child, no? Extensive polyposis. 3-4 webinars back, we did one extensive polyposis in about an 8 or a 9-year child, right? With some altered anatomy.
AFRS case.
AFRS case, yeah.
What are the histopathological investigations that you order, Dr. Sandeep?
For routine histology, and in cases of, we do IG for all these patients pre-operatively. Otherwise, we don't ask for really microbiology or something like that. We just go in for proper histology.
And proper histology, I think, very important in these cases because to know the basement membrane thickening, IG level, eosinophil count, and fungal, so many things are there. Histopathology is very important part.
Yeah.
And we always, I think, in these cases, we always ask for histopathology in a format which was shown earlier also with the different parameters over there, so we can plan the treatment accordingly.
Entire post-op management depends on it.
And it's not
What does protocol contain? What does that histology protocol contain?
Is included starting from base membrane thickening, basic your SNL count on the, and second the whether it is inflammatory or it is polypoidal. So many things are there.
Yes. So, any question or do we go ahead? Do we go ahead with the next case? Yeah. So connect this, please. So next is a patient. Is a 40-year-old male. 40-year-old male with a non-healing ulcerative lesion on the right lateral margin of the tongue, which had been there for almost more than 2 months, and a punch biopsy revealed a moderately differentiated squamous cell carcinoma. That is all about that story of that case. And क्या वो बोल दिया? So this is a case malignancy. You know, the head neck oncology is a very, very integral part of the otolaryngology, and very interesting, very rewarding, and there is a lot of science involved in it. So, and this is one of my favorite subject. So, and I told in the beginning, one of my dear friend, Dr. Devendra Chokar, is going to join us.
Yes, yes.
Probably is in the process of joining.
Tata, I think.
To enlighten us. So, about this case, with a patient in a malignancy, the concepts are altogether different. You know, we have to understand the concept of pattern of spread of malignancy so that we can address accordingly to prevent the chances of recurrence. All know surgery, whatever treatment option we have, is nothing is 100%. We can't control the cancer biology. But according to the evidence-based medicine, what best we can do is something we are supposed to, and for that we need to understand the science behind it, the pattern of spread of these malignancies. So, is it joined?
Not yet.
Can't see him.
Yeah. So, this patient, once we have found that it's a malignancy in the lateral wall of the tongue, for that matter, all malignancies in head and neck at different subsites are different in terms of pattern of spread, different in terms of behavior, lymph node metastasis, distal metastasis, prognosis, survival, everything is different altogether. And squamous cell carcinoma being the predominant malignancy of the head and neck, and particularly oral cavity cancer, which are most prevalent in our country by means of habit of betel nut chewing and all those things. That is the commonest malignancy, and probably this is the commonest malignancy in the entire body, I would say.
Yes, yes.
Out of 100 cases of, cancers in the body, almost 50 are in head and neck. And out of them, the major chunk is oral cavity. And different subsites, Pucho, different subsites in the oral cavity are different in terms of their behavior, pattern of spread, their prognosis, survival, management, everything is different. So this particular patient who presented with a malignancy on the lateral margin of the tongue, we all know that in the tongue, lateral margin malignancies are more common. Devendra.
Hi, Satish.
Hi. Welcome.
Good evening. Good evening.
So, friends, we have a gentleman who is, I tell you, one of the most amazing head neck surgeon I have ever come across. Dr. Devendra Chokar with us. And Dr. Devendra Chokar presently is heading the head and neck oncology department at the prestigious Tata Memorial Center in Mumbai. So welcome.
Welcome, sir.
And thank you for making your time. Can you unmute your audio?
Yeah, and he is unmuted.
Yeah, I unmuted it now. Can you hear me now, Satish?
Yes, very well. So welcome, boss.
Thank
you. And about Devendra, about his academic excellence, there is innumerable work he has, I can say, for his publications, his academic excellence, his presentations, and so many things what he is involved in day and night. Besides that, he's a fantastic cricketer, you know, and we have been hosting a lot of matches between Jaipur and Tata Memorial Center, Mumbai, sometime in Jaipur, sometimes in Mumbai. And the entire team of consultants of Tata would come to Jaipur. We had a lot of series before. Every year, twice a year, we organize this, and there is a lot of fun involved. And Devendra, besides that, is a wonderful human being. He's a, he's a, he's a rare kind of a species, I would say, what a person he is. So
And are you having
I have
the
always learned a lot of things from him in head neck oncology. And still, every single minute detail, if I want, he's the person who would give. Because the concept in Tata, I have been to Tata Center for my training in 99, and I remember that golden period. So anybody who is interested in head neck oncology, Tata is like Mecca of oncology overall, and head neck is biggest department there. So boss, this patient,
Yes.
a 40-year-old male,
Yes, Satish.
had a 2 by 2.5 centimeter lesion on the lateral margin of the tongue.
Right.
Punch biopsy revealed as a moderately differentiated squamous cell carcinoma.
Okay.
On clinical examination, there are no neck nodes.
Right.
See, this crowd, what we are seeing today is all otolaryngology. And we are starting with this basic case. So for everyone, the cancers in the oral cavity or at different subsites in the head and neck behave differently. And we need to understand the pattern of spread of every particular subsite.
Yes.
An oral cavity has a high propensity to spread to the neck lymph nodes. We need to understand the pattern of spread to the lymph nodes for every subsite.
Right.
And for every subsite, there is a definite pattern of spread to the lymph node in terms of spreading to the first echelon lymph node first. And then once they are involved, it goes to the other lymph nodes.
Yes. Right.
So in the oral cavity, particularly the oral tongue, the lateral margin tongue, the first echelon lymph nodes are level 1, 2, 3.
Absolutely.
And if they are involved, then it goes to the other level, which is otherwise unlikely.
That's right.
So the workup, boss, our workup involves when it comes to tongue in terms of radiology is a good MRI.
Absolutely.
I think the Tata is the same policy of getting MRI done for tongue cases, no?
Absolutely
Because
the same.
what I believe, and the second thing, what we believe is to see ourselves MRI so we can plan our surgical resection accordingly. I will take you through certain MRI sequences which will give us amazing details in planning our surgery. So, like, what we want to know from MRI, the area of involvement. Are you getting the MRI picture?
Yeah, we can see it clearly.
So, this is a contrast MRI. You can see contrast axial MRI. I will show multiplanar and different sequences and the combination of sequences, what actually they are going to give us. So what we want is the extent of involvement, the thickness of the lesion or the depth of invasion, any involvement of the lingual lymph nodes, any involvement of the cervical lymph nodes, or any involvement of the adjoining spaces. And everything we can get from this MRI. So this is a contrast one. If I show you in combination with a T2 weighted sequence, which is our primary sequence we always get done. See, this is T2 weighted sequence, this one, and this is a contrast one. And this lesion being malignancy gives strong contrast enhancement. And you can see how it is involving the right lateral margin of the tongue. The base of tongue is spared. And in terms of dimensions, if I measure, this is, 3 centimeter by 2 centimeter. Can you see, boss?
Yes, yes.
Now, sometimes if you rely on the MRI, it overestimates. I tell you.
Absolutely. Yep.
Reason is the adjoining inflammation gives you overestimation because that enhances as well.
Yes.
How can we measure that, whether it is inflammation or actual tumor? Because the entire our surgical planning, not only planning, but reconstruction is centered on this about the site of defect. Because In tongue, we take a margin minimum 1 centimeter around. So we have to approximately gauge the size of defect so we can plan our reconstruction beforehand. In case we get a defect, like this case, we have planned a free fibula reconstruction as well. In case we get a defect bigger than 1/3 of the tongue.
Fibula or ALT?
ALT, sorry.
Yeah, yeah.
Not ALT, this thing, radial forearm.
Radial, yeah.
Oh,
Radial or ALT, yeah.
Yeah, so radial forearm we have planned. And I think you are following the same?
Yes, very much the same. So this lesion appears to be a thick lesion, Satish.
Yes.
It is infiltrative lesion. MRI, as you said, can overestimate, but it is okay if you overestimate. So MRI is a rough guide to your clinical judgment.
Yes.
You have to look at the MRI, and then intraoperatively, we need to palpate the tumor and then excise.
Yes.
The trick of doing a tongue is what appears on the mucosal may give you a false sense of impression, because you have to read your MRI carefully, because deeper in the muscles, the lesion can be more infiltrative. So as you start cutting the tongue, sometimes in the depth, sometimes you will feel the tumor, and this happens to the best of the surgeons. It's very difficult to get a margin in the tongue, especially in such a deep infiltrative tumor. So you must go not a centimeter, a centimeter and a half wide, because the muscle will contract, and finally your the specimen that you give to the pathologist, they will give you a close margin.
Enlighten.
So you need to be very careful when you're excising the tongue.
As you said, your palpation is the best guide. So
it's an adjunct to
MRI, not the best, intraoperatively.
Yes.
So you take a palpation as your margin, or 1 centimeter beyond palpation?
1 centimeter beyond that, 1.5 centimeter. So I put my finger, one edge touches the tumor, not touches the tumor, but is just about away from the tumor. And the other edge of my finger, I go a little beyond that and start cutting layer by layer. Once you cut the mucosa, little bit of muscle, palpate again. Sometimes the infiltration is deep in the muscle. So then you will have tumor which is beyond what you are cutting. So you need to go wider.
Okay, so that's a very good
information. Is to cut the muscle wide.
That's an amazing information, that we have to go actually 1 centimeter beyond the induration, I would say.
Yeah.
Now here, see the reality of induration and the margin on MRI. What you see on MRI. See, parallel to this, can you see this other sequence? What is it? This is pure bioimaging. This is diffusion weighted MRI.
Diffusion weighted, yeah.
What do we see for everyone in diffusion? We see the diffusion of water molecules in this magnetic field. MRI is magnetic field. So cancers being highly cellular will show least diffusion. Any inflammatory thing having a lot of water content will show more diffusion of the water molecules. So here, the area, if I see parallel to it, see this lesion on the tongue on this side. Can you see this here?
Yeah.
And see on this side the dimension of the lesion, where it is showing restriction. See the area where it is showing highest level of restriction. Can you see very clear?
Yeah.
It is smaller than what your MRI is showing enhancement. See what I'm trying to say?
Yes.
This area of diffusion restriction is much lesser than what the MRI is showing the area of enhancement. Because the region is all around, see the bright picture showing no restriction of diffusion, and that is all inflammation. So what we see on MRI is an enhancement. All around is more of inflammation also, which enhances as well. So it doesn't mean that what you see on MRI is entire tumor. All around is the inflammation as well, and if you have a diffusion weighted, you can pick up it well as well. And the same thing, that inflammation, when you palpate on induration, this inflammation also shows the induration. It is always good that we take 1 centimeter beyond the induration, because it's always we are staying on the safer side.
Yeah.
When it comes to margins. But this is a fact how MRI overestimates. Now the second thing what we see on MRI is any lingual lymph nodes. Can you see there are two varieties of lingual lymph nodes, the median and lateral. Median between two genioglossus. Let me show you where the genioglossus muscle is. See this. See the tongue. In the tongue, the biggest muscle, this biggest muscle is the genioglossus. And see, this tumor is involving this part. Completely this part of the tongue is involved, not entirely to the depth. This lower one is geniohyoid and this upper one is genioglossus. So there are two group of lymph nodes, the median and lateral lingual lymph nodes. Boss, do you by any means take into consideration those lingual lymph nodes? Because in tongue, we don't do, in continuity resection most of the time. The primary separate and the neck separate. And if there is any median or lateral lingual lymph node, can it lead to disease, say, overlooked?
So, Satish, what you're saying is wide excision of the tongue versus compartmental resection, if I may
through and through, pull through.
That's right. Not even pull through, but a compartmental completely taking.
Yes.
In the earlier days, even for a T1, T2 tongue, they used to tell us to do a hemiglossectomy. That means go to the median raphe, go all the way back, come into the floor mouth and resect the entire block of that tongue. It is no more done for a small T1, T2. But for such a big infiltrative lesion, if it is going into the floor mouth, then maybe you will have to do, your floor mouth is going to open up. So you're going to excise that entire, you're going to finish your neck, keep the specimen attached to the floor of the mouth. Don't resect that. And then come take your tongue and take the entire specimen as one. So that the entire lymph nodes in transit are whatever you call as lingual lymph nodes are excised along with the specimen.
Okay. Now, in the present context, when you advocate through and through, pull through surgery, so with primary and secondary all together en bloc.
Right. So pull through is a methodology when you can't access the posterior end. Intraorally, if it is difficult to assess or access the posterior end and difficult to cut on the posterior margin, then sometimes there are two methods. One is a mandibulotomy, which is quite morbid, and the second is the pull through. So you do a pull through, take your posterior cut and take it out. In this tumor, you will have to resect the floor of the mouth, and though it is not a pull through, but you can get the posterior margin here, but it will be a through and through defect of the tongue and the floor of the mouth.
Okay, so we don't want fistula and all those morbidities, so we don't do.
Yes.
So you'll have to open up the floor mouth and you'll have to reconstruct it with the ALT or a radial, depending on the defect.
Yes. That will require additional reconstruction.
In this case, I would tell the plastics to hold on. I would resect my tumor because I think this patient, if I'm not mistaken, would land up with almost the anterior two-third glossectomy. So I would tell my plastics to hold on. If the radial is big enough for that defect, they can go ahead. Otherwise, they may have to do an ALT.
So this will be a level 2 resection. More than 1/3 of the tongue is going to go, oral tongue. Obviously, the base tongue is not going to go. And with such resections, would you leave, primary closure or always with a flap?
No, this will always be reconstructed. This will be more than 1/3 of the tongue, always reconstructed.
Always reconstructed. So besides any free flap, because everywhere people are not having free flap facility, so you recommend any local flap?
Yeah, so you can do for such a big defect, you can do what is called the pectoralis major myofascial flap. So instead of the myocutaneous, you don't take the skin, you raise the skin flaps and just take the muscle with the fascia and you feed it in, and that gives good results.
And that will not be too bulky as well.
That doesn't tether the tongue and keeps the mobility of the residual tongue. So you can do a pectoralis major myofascial flap if you don't have a free flap available in your center.
Oh, super. And any regional flap like this, any experience with or you advocate the facial artery myomucosal flap or anything?
Yeah, but that's for a smaller defect, Satish. T1, T2, you can do a FAM flap, you can do a submental flap, the superaxclavicular flap that has been described, but those are for smaller defects, not for such large defects. You will have to put in soft tissue here to get, you need a soft tissue bulk to have functioning of the remaining tongue.
Yes. So now, going ahead, with this MRI, the next thing, after the lingual lymph nodes, we have seen, boss, couple of times, the median and the lateral lingual lymph nodes. We don't know whether they were positive or not only on the basis of MRI. But that is something gives us a suspicion to do a pull-through operation to do a compartmental clearance. Once you find a lingual lymph node.
In this case, you'll open the floor mouth and do a complete resection in this case. You'll open the floor mouth, you'll take in continuity with the next specimen. So all the lymph nodes between your primary and your neck are going to be excised.
Yes. So for everyone, these primary at the lateral margin of the tongue, they have a propensity to give lymph node metastasis quite high. Many of the patients have palpable lymph nodes. When palpable, the straightforward treatment is a comprehensive neck dissection. But many of such patients do not have clinically positive lymph nodes, but have high incidence of occult lymph node metastasis. And there was a great paper by you and Anil De Cruz, sir, in 2015, warranting in the New England Journal of Medicine. That was a landmark publication, I think, where it recommended neck dissection for every even T1 lesion of the oral cavity. Am I correct?
Right. That's right. Satish, the more important point in this case, which people should understand, is that the question that will come to their mind is, this lesion is almost touching the midline. You will have to go beyond the midline to resect this tumor. The question that you need to answer is, will you do the opposite neck? Doing the ipsilateral neck is a no-brainer.
It is approaching midline, but to my definition,
it's not crossing, but what will you do to the opposite neck?
Because
tongue has bilateral lymphatic spread.
Yes,
in large tumors.
Obviously, that's a very important concern. But I tell you, this MRI overestimates, and what I saw on the diffusion, what I showed you, this tumor is actually not going to the midline. That is a thick layer of inflammation over it. I can show it again.
Yeah.
And that is actually the tumor which is not going to the beyond the midline.
Yeah, that you'll come to know on table, Satish, when you're
on table. On table, we'll take a call. You're right. But yes, that's the important message from him. If the tumor goes beyond the midline, that is an indication for a contralateral, the bilateral neck dissection as well.
So, Satish, we also looked at all our tumors which were, ipsilateral, but, nearly touching midline or little short of midline. We looked at them and we wanted to answer the question whether to, we always have this doubt in our mind what to do with the opposite neck. So what we saw is that if the ipsilateral neck is N0, there is a very remote chance that the opposite neck is positive. So you don't need to do the opposite.
But if the ipsilateral is positive,
if the ipsilateral is positive, you have tumor which is going to midline, you've crossed the midline for resection, you have largest infiltrative tumor, it is safer to do the opposite neck.
So you mean
even
to
the
say...
CENT trial, which was the,
so that's a very important message.
Showed a 6% contralateral lymph node metastasis.
Yes, 6%. So you mean to say, and it should be a message to everyone from Master, any tumor having ipsilateral neck positive, clinically positive neck, reaching up to midline, we should include the contralateral neck, at least for sampling.
Yes.
Yeah, that's an important message. Now, the second thing, next, if we go, why we do neck dissection? There is always a dispute whether to address the neck or unnecessarily why to treat the neck. Because up to 15 to 20% have metastasis, but it has a significant impact on the overall survival. And that has been very obvious from that 2015 publication. That was a landmark one showing extreme difference in the overall survival. Now, there is something in between. There's a lot of people doing that sentinel node biopsy to improve your sensitivity, whether the neck is likely to have metastasis or not. I have no experience of doing a sentinel node, and I'm sure you are doing Tata. You are doing some study at Tata.
No, we were Satish. We did a small study to look at the sensitivity, specificity. That's all. We are not doing it as a routine. And many centers across the world are not doing it as a routine. In the US, you have Saman's paper. There's a recent paper which he said looking at ENT versus sentinel lymph node biopsy. It didn't, at 12 months, there was no difference in shoulder dysfunction. See, Satish, the importance of sentinel lymph node is in breast cancer, penile cancer, where doing the lymph node dissection is associated with tremendous morbidity.
Yes.
You do breast cancer axillary clearance, you get a bad lymphedema. Groin node dissection, bad edema of the leg. In neck, to advocate sentinel lymph node, you have to really show that a supraomoid is really that bad. And now with new evidence of selective neck dissection, if 2A is negative, you don't need to do 2B and 5. So your accessory nerve is absolutely okay. So really,
and I believe that people like you won't take into consideration that accessory. Having done thousands of neck dissection, I am sure you will never give accessory deformity.
No, but if you clear, 2B and 5, it's not because you injure the nerve, it's because of the vascular injury to the nerve that they can have dysfunction.
But traction improves over the period of time. I believe it doesn't leave any. Yes. So the sentinel node is no more in practice. So obviously, and you don't recommend for a routine use. What I believe
we don't, because it's expensive. You need serial step section. Frozen can't tell you.
And take a lot of time as well.
Sometimes it comes positive. You have to take the patient back. So it's second surgery again. So it's a procedure. It's not that easy to implement in clinical practice.
Okay, great. Now coming from the tongue, this was the primary. If I go below to the neck, the MRI gives you a best chance, best opportunity to find any metastasis there. And by means of certain characteristic, you can identify whether they are malignant or not. Like for example, if I go, this is axial section going from above downwards. See this?
Yes.
This is the, to orient you, this was the tongue. Now I am going down, 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 down. This is the submandibular gland coming. Can you see? On both sides?
Yes,
This is the floor of mouth.
Yeah,
That is the sublingual gland. That is the sublingual gland. This is the submandibular gland. This is mandible. And now behind is the carotid sheath. And if I go below, can you see this lymph node coming in the submandibular region?
Yeah.
Now this is, the MRI is one of the best investigation to characterize whether it could be malignant or not. And can you see the lymph node? So well capsulated. No heterogeneous echo texture. So USG sometimes it's better to define a lymph node whether it could be malignant or not by looking at the hilum and extracapsular spread and all those things. But MRI is more sensitive in terms of detecting the extracapsular spread, even the architecture of the lymph node, and even at the same time, you can add on the diffusion weighted to see whether it is a lymph node. Boss, by means of MRI, if you suspect a positive node, would you still go ahead with a supraomoid and then if turns out to be positive, convert to a MND, or by default will do MND?
So Satish, I would go clinically. If I have frozen section, I'll do frozen section. But if I clinically feel that there is level 2 is grossly positive, on MRI positive, and clinically when I open the neck and I see that level 2 is positive, looks positive, I will go ahead and clear level 4 and level 5.
But with such a node, which is likely to be positive, looks like positive, wouldn't you go with a USG guided FNSE or something pre-op?
I wouldn't. If you have it, you can do it, but it's not necessary.
Why I'm asking? Why I'm asking? If suppose on one side, if we are suspicious of a lymph node and do a USG guided FNSE, which is a very simple investigation, and prove pre-op that it is malignant.
Right.
Now having a positive node, clinically positive node, won't we go straight away with the MND rather than doing a supraomoid, waiting for the frozen and then converting to a MND?
Yeah, you could do that. But if you have frozen section, then you don't need to add FNSE. But that point taken, you could do that.
Yeah, that is the luxury you have in Tata all the time, frozen section.
No, but even clinically, if you feel 2 is positive, it's safer. If you don't have frozen section, don't get worried. And if you've not done an FNSE, also don't get worried. If MRI is telling you it's positive, clinically when you open the neck, you see a hard rounded node which looks positive, safer to do level 4 at 5 than not do it.
Yes.
That's the message.
So what we have seen is the level 2 lymph node. If you go below level 3, 4, everything is clear. Now, what does it mean? It has a clinical correlation. Number one, like Dr. Devendra said, the frozen section is of utmost importance. And here at our center, we are also fortunate to have frozen section all the time with a good pathology backup. Why? Why MRI is important here? For the tongue as well. In tongue, we consider level 1, 2, 3 as our initial lymph nodes or first external lymph node. In certain cases, we assume or we have seen the skip metastasis at level 4. So whether to address sometime level 4 or not during SOSD, you can take additional help of MRI as well. Here in MRI, I can see level 4. This is level 4 at the level of the cricoid, below the cricoid. And this is absolutely clear with no trace of lymph node on MRI. Why to go and look for a possible skip metastasis? This is something which can additionally help you. Number 2, for the audience, what we are targeting, what is the concept of the selective and comprehensive neck dissection? See, in the neck, the anterolateral part of the neck, the lymph nodes are scattered everywhere in the muscular and the vascular aponeurotic fascia between the muscular surfaces and the neurovascular structures. Though they are very close to these structures, but they don't invade them. And still, if you remove this entire envelope intact, containing this fibrofatty tissue and lymph node, still it is a radical clearance in spite of preserving all those structures. These lymph nodes and all these things may be very close to neurovascular structure, but they don't invade unless there is extracapsular spread. So that's why that is the concept of selective and the comprehensive neck dissection. So idea of selective neck is there is a predictable pathway of spread. So tongue has a predictable pathway to level 1 to 3. And if there is positive node in 1 to 3, then there are chances of lymph node spread further to level 4 and 5. And that's what we follow in our strategy. We have planned for this case a supraomoid neck dissection. We'll send for frozen. If it turns out to be positive, any lymph node will then convert to proper MND. That is our plan.
Perfect. Perfect plan.
Anything different what you do?
No, absolutely perfect.
What is the role of
That's
PET
what we'll
scan
do.
in these cases?
PET scan for such T1, T2 lesions, I don't think gives any additional benefit. And we never get it done. Boss, you? Anytime?
No, we don't. No, we don't get it done unless we are suspecting distant metastasis. So if it's a very large lesion, T4, bad T3, bad nodes,
Or multiple level nodes. Multiple level
nodes where we suspect that this patient may have distant metastasis. Then if you're doing a CT for the primary, we get a CT chest done. But if you're doing an MRI, either you can get a CT chest or you can get a PET scan done. So not necessary to do a PET scan. You can get away with the CT chest because maximum metastases are usually in the neck, are usually in the lung.
Yes.
Okay. So for that
Dr.
matter,
Devendra, can you please explain about the opposite side neck once more? I mean, when
the idea what he was saying is, ideally, if the lesion is approaching the midline, we should think of addressing the opposite neck as well.
Okay.
So what they have studied and what is his inference is, if on the same side there is already a clinically positive node, it is always better to address the opposite neck at the same time, because the chances of spread to the opposite neck are high if you have a ipsilateral clinically positive node.
Correct. So
Am I correct?
In this case, you would contemplate doing it.
That's right.
Okay.
That's right. Yeah.
So this was about the workup part in brief. So plan is obvious. We'll first address the neck supraomoid dissection level 1 to 3, and I will show intraoperatively what is level 1 divided into level 1A, 1B, 2A, 2B, and 3. And the concept about 2B, Dr. Devendra.
Yes.
You address in all oral cavity or specifically tongue cancer, all cancers level 2B or not?
No, so we have a publication by Gauri who's looked at level of lymph nodes being involved. 2A gives you a good indication of whether 2B and 5 needs to be done. So if your 2A is negative, you're not going to get metastasis in 2B, even if it is
in tongue also.
No, you don't. The incidence is extremely low. So if you have 2A which is negative,
as compared to the other oral cavity sites, tongue has the highest incidence of 2B.
It is, but if it has to go to the metastasis, 2A will be definitely positive. If it has gone to 2B.
Yeah. It cannot be 2B positive
very
without 2A.
To be isolated. Very, very unlikely. I'd be surprised.
Yes. So you can take a call on the basis of frozen section, do 2A. And if 2A is positive, then you can take a call of doing a 2B. Otherwise, you can leave it. And the idea behind is, leaving behind is to protect the spinal accessory.
Less traction on the spinal.
Less traction.
And
so
then
in this
you
case,
would look at even level 5 in this case, if 2A comes positive.
We won't do level 5. If
you
2 is negative, 3 is negative. If the neck is negative, then we won't do level 5. No.
Okay.
So anybody, any questions so far? Paramita and Dr. Devendra is with us. Anybody has any doubts in mind? The master is here.
Yes.
So you will send frozen section from the resected specimen or from the surgical defect?
No, frozen biopsy.
Frozen
on the margin, you mean to ask?
Yes.
So I think your question was related to margin.
Yes, margin.
So margin is to be taken from a specimen or from the defect. Specimen. Specimen.
Okay.
Yeah. Specimen.
Always from a specimen.
That's right.
So do we go ahead with the surgical part?
Yes.
Okay. So in few
Carry
minutes.
on, Satish. Thank you so much. I love the interaction. I will join in after some time. Yeah.
Wonderful interaction.
Yeah,
Wonderful.
Great knowledge, Dr. Devendra. Yes.
Sharing your
Good
valuable
information.
time.
Yes.
And I
Bye,
think there are so many queries regarding previous 2 cases and regarding this discussion. The people can do previous surgery recordings as well as today's recording afterwards, so they can clear their doubts regarding the discussion.
Yeah, we can discuss during surgical part.
Surgical also.
Sure.
Thank you, boss.
Thank you, Satish. Bye,
Thank you. Bye.
Baba.
There are so many queries about the histopathology, role of histopathology in allergic FRS, role of immunoglobulin. When the recordings are there, they suppose any doubt. There's so many questions are there. That's why they can go to the previous recordings on the YouTube, and they can clear any doubt because everything been explained in detail. Whatever it is possible.
Yes.
So you do head and neck, Dr. Sandeep?
By choice, no. Because by choice, no.
Because ENT, that is the biggest thing. Most of the ENT.
No, you know what happened is, it all depends upon where you actually get trained. To be very frank.
Yeah, that is training.
You inherit what your bosses have been doing. So
But I
although
think
we had a robust head and neck consultant in Dr. Borwani used to do a lot, and Dr. Ashok Mehta at Nanavati.
Well, most of the ENTs just they do benign lesions of the head and neck, like thyroid, parotid.
Yes.
For malignancy, I think there's some revisions are there. I think that's why we kept this case, for at least some doubts can be clear, and how to do the basic dissection. And he will try to explain all the neck dissection in his presentation discussion right now. At least just to take out some fear from their mind regarding the malignancy of the head and neck.
Yes.
It is the must thing, and very few ENTs are doing.
But again, I think the trend has started coming where the youngsters have again started doing, lot head and neck again.
So many.
Yes.
With choice, by choice, they're doing the
by choice. Yeah. There people are going and getting trained in head and neck, especially.
Yes.
Yeah, and what about you, Nishi ma'am?
My team does everything, not me. I would just
exactly.
Simple supervision.
She's a very good team actually.
But we do everything is done at our place. Commandos, pectoralis.
Correct. Yeah, that's what
juniors do enthusiastically 9-hour surgery, 8 hours.
Hello.
Yes, boss. We're with you.
Yes, boss. Are you getting the picture?
Yeah. The neck.
Yes. So this is a right-sided lesion. And as I told you, let me show you the tongue as well. Can you see this lesion on the tongue?
Yeah, very big.
The same lesion. The dimensions we have seen, a little behind the tip you can see. And this is around 2 by 3 centimeter as you have seen on the MRI. Now this is the right side neck. And our plan is very clear. We'll do a sampling. We'll do a level 1, 2, 3. And then we'll send for frozen section, and if it turns out to be positive, then we'll convert to level 4 and 5. Okay? Because the pattern of spread is predictable. Those patients who do not have spread to the level 1, 2, 3 and turns out to be positive on frozen are unlikely to have at level 4 or 5. Though in up to 2 to 3% of the patients, you have a incidence of skip metastasis to level 4 from tongue. That means the frozen negative for the supraomoid specimen, level 1 to 3 negative, and a level 4 was a lymph node and you have missed. So, but that is too low an incidence, and with the MRI, with the help of MRI, you can take the help of MRI and rule out any lymph node at level 4. If MRI shows lymph node at level 4, may or may not be positive, showing any signs of positive, but at least then you can include the level 4. That is extended supraomoid.
Yes.
Here, for better demonstration, this is the outside picture.
Yeah.
Better demonstration, I would like to show with a microscope. The microscope, the picture will be, little magnified to a smaller area, but I will keep orienting you so that you don't get disoriented, but you'll get amazing close-up picture of each and every structure.
So Kumar Raja is asking, what is the down staging of the tumor? Can you please elaborate about synchronous primary?
What?
Down staging of the tumor.
Means
down staging of tumor, what?
And
about preoperative chemo or NACT before, that's what he's asking.
Yes. Preoperative protocol in these cases.
Preoperative protocol. There is no question of, no point in doing all those down staging with a anterior chemo or anything in these patients. These are straight away surgical candidates for the primary treatment is surgery, followed by, on the basis of the histopathology, and the clinical parameters, depth of invasion in tongue. The depth of invasion is a major parameter.
Yeah.
You have to take a call of adjuvant therapy post-operatively. There are certain high-risk parameters by means of which you can advocate radiation later on.
So suppose this case was having means infiltration opposite side of the tongue, then what would your approach? Means you would go same thing, your total glossectomy, what?
Bilateral?
Yeah.
See, the total glossectomy is required when the base tongue is also involved.
Yes.
If the opposite side oral tongue is involved, you would do an extended resection. See, idea is to take a margin at least 1 centimeter beyond. Now this incision, I am purposely taking a bigger incision for demonstration here.
Yeah.
So that I can show each and every anatomy properly.
Yes.
The idea is to show you anatomy. Okay?
Yeah.
And Satish, the tongue was mobile, no, in this patient?
Yeah, very well. So now you may be getting the larger picture.
Yes.
Because I am now seeing through the microscope.
Yeah, picture is good.
Very good clarity.
Yeah, the microscope will give. That's why I'm using microscope to give you the best picture. Yeah. See now, this is your level of the sternomastoid.
Yeah.
And what you see here, we have done is divided the platysma. Can you see?
Yeah.
In neck, all flaps are made deep to platysma, subplatysmal, because platysma add on to the strength to the flap, add on to the vascularity, and this subplatysmal plane is relatively avascular. See this?
Yeah.
Yeah, that's true.
Anybody has any point of time, any smallest doubt, please come forward. See, I'm dividing the platysma.
Yeah.
Yes.
This picture, so clarity, would not come with by any other way of demonstration except the microscope.
Agreed. Yes.
What trick over?
So you do all the head and neck dissection with microscope?
Yes, I have a habit of using microscope because it gives you best, visualization. See the platysma I am cutting?
Yes. Yeah, you can see.
Now with this same incision, I could do the SOSD completely.
Yeah.
But I am taking it beyond so that I can show you. Okay?
Yes.
Yeah.
This is all subplatysmal. See everything. And now you see hugging the platysma. See the undersurface of the platysma?
Yeah, we can see.
Okay, now. See, hugging the platysma.
Yeah.
I will go up toward the mandible. So there are various levels of lymph node, as I mentioned. Level 1, 2, 3. So for the audience, for the beginners, what is level 1, what is level 2, what is 3? As I said, in the anterior lateral part of the neck, the various groups of lymph nodes are enveloped in the muscular fascia and the vascular aponeurosis. So that fascia, this part of the neck we see from the clavicle to the mandible is divided into various groups of levels. So level 1 is again divided into two, level 1A and 1B. So level 1A is between the two anterior bellies of digastric.
Yes.
For orientation, everyone, this is superior, this is inferior. Superior means towards the mandible. The mandible is here.
Yes.
Okay?
Yes.
This is inferior, this is the inferior. This is posterior, this is the sternomastoid. This is crossed by the external jugular vein.
Yeah.
And that is anterior towards the midline, towards the chin. Okay?
When you recommend tracheostomy in these cases?
Not really. Why tracheostomy?
Airway
is not. If you are doing a total glossectomy kind of a thing,
then you can
lead to airway compromise. Yes. See, my upper limit is the clavicle. Okay.
Yeah.
So here, the important thing is to stay See how to use the cautery. I'm using like a spray.
Yeah.
Hugging the platysma, completely hugging the platysma. Can you see?
Yeah, very good.
So that I don't go in the deeper area. In the deeper area at the angle of mandible here would be the marginal mandibular nerve. If you go one level deeper, you can directly injure the nerve.
Yes, yes.
So stay hugging the platysma. Can you see this?
Yes.
Yeah, very clear.
See this? Very clear. And I can see this point. This is gonian. This is gonian. I have shown you earlier in the dissection also the importance of gonian. The marginal mandibular branch is most of the time seen in the 1 centimeter vicinity of the gonian. Okay? If
Yeah,
you
incision is starting.
you can directly injure the nerve.
You were telling us about level 1, 2, 3.
See, what I am saying, let me show you.
Yeah, very clear.
See, this is the point of gonian for everyone.
Yeah, yes.
Okay? If I open up the facial plane at this point of time, dissection also for everyone. Of gonian, the marginal mandibular branch is most of the.
It's echo. It's echoing.
Somebody has started, I
Yeah, I
think.
think
Can you see the nerve? Okay, no.
Yeah, yeah, yeah.
Yes, we can see it.
अरे इतना मत खींच यार पकड़.
अब दिख रही है.
See the nerve there below. Let me show you. उठा.
So what were your landmark for the incision actually? Because from which place to what are
Yeah, it's a mid cervical incision. And see the nerve. See the nerve.
Yes.
Everybody, can you see the marginal mandibular branch?
Yeah, very, very clear, very clearly.
See, this is gonian. Right at the gonian, the nerve is seen. Could you see?
Yes, yes, very clear.
So here in this, supramoid dissection as well, as our upper limit is going to be the lower border of the mandible, at this point of time, this nerve running in the vicinity of the mandible, lower border, we must see and separate this nerve by means of positive identification to prevent morbidity, because this nerve carries injury to this nerve carries a significant morbidity.
Hello,
Yes.
Satish.
Our
boss.
Rajeev Kapila is also joined.
Hey, Rajeev.
Hi, good evening, boss.
He does lots of head and neck surgery.
Yeah.
Boss, at this point, I would like this maneuver many people follow, Hayes Martin maneuver.
Yeah, but
Yeah,
that is indirect, Rajeev.
Okay, boss.
That is indirect. What is Hayes Martin maneuver? That the veins at this level are running below the deep to the nerve. See the veins?
Yeah.
Yes.
What is
yes.
Hayes Martin? Find the vein below and invert it up. So
Okay.
automatically to stay away from the nerves. But
Alright.
Rajeev, the course of the nerves are so variable. If you use such indirect maneuvers, you can sometimes injure the nerve. See now, what can be better than this direct identification and separation?
Yeah, best.
See the full course of the nerve. Can you see?
Wonderful. Yeah.
Absolutely, boss.
Can you see or not?
Yes, it's very clear.
Now, having seen this full course, see, every time I'll keep this nerve in reference so that I will never damage it. See, there are various ways, in science, direct, indirect. It is up to you what you follow. But this is our proposition. Sijas.
Boss, also this is the better way because in that the perifacial lymphatics are lifted along with
Yeah,
the
that is coming. That is a significant impact.
Yeah.
Because in up to 8 to 10% of the cases, there are perifacial, or we call them perivascular lymphatics. And if you ignore them, could be a biggest. It could be a disaster.
Yes, boss.
It's a cause of relapse.
We make a fine recurrence later on.
See now the nerve very clear all the way.
Absolutely.
I hope it is seen there.
Very well.
Yes, yes.
Very clear. And this is the level of the mandible. See the gonian.
Yeah.
This is the gonian, and see where the nerve goes. What a point it is. This muscle there is a masseter. Okay. Now from this gonian, from this point, 27 millimeter anterior is the facial vessels, Let me show you some landmarks.
27
millimeter. Millimeter, dear, not centimeter.
Yeah, 27 millimeters.
Now see the facial artery. Facial artery and the vein, which is the most superficial part where you can see them.
Yeah, right, boss.
Can you see?
Yes, boss. So that is posterior facial vein, right?
Yeah, move karna. Yes, see the facial vessels. See this? And this is right. If you take by any means, this is Gonian. This is exactly around 27 millimeters from here. So that is the amazing, landmark as well. Now, at this point, when you are doing SOSD, like what you were mentioning, the perivascular nodes, take
Boss,
care.
if in any case the platysma is involved, can we still preserve the skin of the patient? Or we have to sacrifice us?
You don't have to think twice, resect it.
Okay. Even the skin.
No question of, what something is involved and leaving behind.
Okay.
See, once you're operating, see this lymph node?
Yeah.
Yes.
Though it looks,
benign,
objective, but still I will take. See, this is the beauty when you see the nerve.
Yeah, otherwise we can definitely leave this node behind.
Or in the microscope. That microscope advantage is also there.
Microscope is something I have n number of regions to enumerate. See the lower border of the mandible now? Can you see here?
Yeah, very good.
Very clear?
Very clear.
Rajeev does a lot of head and neck work. Rajeev, your inputs are important for everyone.
Sure, boss.
He's becoming a perfect ear surgeon now. He's doing all the surgery. His Calvez, plant.
Rajeev.
Yes, boss.
Your number of Hada?
No, boss.
Mahendra Hada is one in SMS also. He does a lot of head and neck work.
Yeah, I know him, sir. He was my just immediate junior.
Just for your reference, I'm taking this facial artery here. Now, what I'm trying to show here is, we'll take the facial artery below as well.
Yes.
Normally, when we do the benign surgery, when we do the benign, the submandibular gland resection, we preserve the facial artery. But here in malignancy, looking at the perivascular node, I never take a chance. See this?
Right, boss. So this can be also an important branch if we have to do a free facial,
Yeah, that is a submental artery.
Yeah.
I will show in one of the webinars, coming webinars, Rajeev, we'll be doing on a benign head and neck lesions. And there we'll keep the submandibular gland resection also. And then I will show you how to preserve this facial artery, submental artery, the submental artery base flap and all. See the lower border of the mandible all the way?
Yeah.
Yeah, clear.
I hope you are oriented.
Anterior. This is anterior.
Hello?
Yeah, we all are oriented. Just.
I am going anterior. Now the reason I could do this without enlarging this incision as well, normally. But here I am showing this for the sake of demonstration so that nobody can miss anything. See now. See now for everyone, this is the midline, the submental region. And see, this is the level of the lower border of the mandible. This is the marginal mandibular branch for everyone.
Yes.
We have ligated the facial vessel. This is the submandibular gland.
Yes.
This is mandible, and just below the mandible is the submandibular gland. Clear?
Yes.
And behind this is the sternomastoid, which is going towards the occipital region.
Yeah.
See that? I hope it is clear.
Very clear.
Absolutely.
See, this is the most basic thing in the head and neck oncology. What I am doing today, this kind of a dissection. Anybody has any doubts, please come forward. Now, I can do my neck dissections starting from level 2A, 2B, 3, 4, or I can do starting from level 1. Where do I start from? Whatever you say. Do I start from level 1?
Level 1A, yeah, boss.
Okay. So level 1A and B for everyone. Level 1A is between the two bellies of the digastric, two anterior bellies of the digastric, and the base of the triangle is hyoid bone. Clear? I hope picture is oriented.
Yes.
Very much.
Clear, boss.
Okay. Okay, now see the opposite anterior belly of digastric. So, today the cautery I am using is the Martin, you know.
Best for head and neck.
Yeah, Valley Lab, Martin, these are best.
Very good one. Yeah.
See, this is the anterior belly of the opposite anterior belly of digastric.
Yes.
This is the same side anterior belly of digastric. Can you see?
Yeah.
And in between these two, all this fascia along with fibrofatty tissue is supposed to contain the lymphatics. And this is the primary echelon area for the tongue. You know, more the lesion coming toward the tip of the tongue is yes, more the lesion coming toward the tip of the tongue, more are the chances of having metastasis in this level 1A. You know, see this?
Yes.
Rajeev, let me know if you do anything differently.
No, boss. Absolutely same.
I hope the picture is clear.
Absolutely clear.
Why I am doing under microscope here, I know the picture is smaller.
Yeah.
But this is the best way for giving a,
what are
close-up
Rajeev,
view. Close-up view.
What are Rajiv's thoughts on opposite side neck dissection, Rajeev, in your CA tongue?
If it is crossing the midline, sir, then we need to do opposite side.
Yes.
Yeah. This is T2 lesion, boss. I missed the radiology part, I think.
Pardon?
This is T2 lesion. I missed
Yeah, T2. T2 lesion coming close to midline.
Yeah.
But what I believe, the lesion which is coming close to midline is inflammatory.
Yeah.
So Satish, many people are asking regarding the level of this lymph nodes.
Yeah. So I am going to tell you every time when I go to a level, I have already told this is level 1A, staying between the two bellies of the digastric, and this is hyoid bone here.
Yeah. So,
Okay.
boss, you remove these levels piecemeal, or you mean the continuity like we used to do?
Mostly continuity.
Okay.
See this? I have elevated from level 1A. Can you see?
Yes.
Yeah.
See, it is a matter of traction and counter traction. The moment my assistant loses the counter traction, I am into muscle.
Professor Mazumdar is asking, there's so many questions from his side regarding any history of repeated viral ulcer in this case.
No.
Any poor nutrition?
No, sir. He was a tobacco chewer.
Yeah, that is the biggest.
Now, see, this is the anterior belly of digastric on this side. Okay?
Yeah.
Yeah, quickly. See, we have a habit of going faster.
Yeah.
Remember, boss, last time in Agra?
1 hour, 10 minutes, commando.
Now see the tendon of the digastric coming into the picture.
Yes.
See this?
Very clear.
And what is this muscle now?
This is mylohyoid, boss.
Yeah, that is mylohyoid, and this is the plexus of vessel sometime here.
Yeah.
Which contributes to bleeding,
Bleeding a lot at this level.
And now we are reaching the free edge of the mylohyoid. See this?
Yes. Professor Mazumdar is again asking, why not?
See, this is the free posterior edge of the mylohyoid. Can you see this?
Yes.
Yes.
Sir is asking, why not a mandibular swing with reconstruction in this case, Professor Mazumdar?
Why? What? Mandibular?
A swing with reconstruction in this case.
Swing?
Yeah.
For what? There is no need of swing, sir. This tongue lesion is very well approachable, intraoral.
Yeah, because it is limited actually, not to.
Yeah. No need of swing. Now, see, The anatomy, more and more anatomy coming into picture. This is entry valley of digestive opposite side.
Yes.
Same side.
Beautiful.
The mandible, lower edge. This is the strap muscles coming into picture. This is the hyoid bone here. See this?
Yeah. Yes.
And this is the tendon of the digestic. You see more and more.
Yes.
Beautiful.
See the facial planes. And now the important anatomy of the submandibular region. Because now we are removing the submandibular gland. Now there is a lot of discussion, controversy regarding removal of the submandibular gland. Because submandibular gland, unlike parotid gland, doesn't contain any intraglandular lymph nodes.
Yeah.
Why to remove it?
Yeah.
Mostly, there is a straight away, indication for the removal of the submandibular is when the floor of mouth is involved, and there could be incontinuity involvement of the submandibular gland. Many a time, publication have shown involvement of the gland through the Wharton's duct, tumor spread to the Wharton's duct.
Yeah.
And sometimes there are lymphatics on the submandibular gland on the surface, which, if you try to preserve the gland, may leave the lymphatics, and that could be a problem.
True.
It is always better to take this. Yeah.
Boss, I always wonder, if we remove submandibular gland, why don't we remove sublingual gland?
Sublingual gland is in the floor of mouth, and sublingual gland is removed in the floor of mouth malignancies. This is nowhere close to the sublingual gland. What is the concern here with the sublingual?
No, so my concern is the lymphatics are coming from above downwards, no? So if we are removing submandibular gland, so why aren't we not removing? It always comes in my question. I haven't got any answer yet. Why don't we remove sublingual gland?
This sublingual or submandibular gland, they do not contain lymphatics at all.
Yeah.
No point. There is no lymphatics at all they contain. See now the clearance?
Yeah. Excellent.
Now the loop. Give me a loop. Now, see, this is the posterior edge of the mylohyoid. See the amazing anatomy here.
Yeah, beautiful.
If I retract this mylohyoid back, this is the submandibular triangle area.
Yes.
See now, lot of things you will find in this region. See this? Now, if I open up. See now, I am in the bed of the submandibular gland.
Yeah.
See this? Can you see the hypoglossal nerve, number one?
Clear, absolutely clear.
Very clear.
See, isko chhodna. This muscle is the mylohyoid. Okay?
Yeah.
Now, I'll retract this. And the underlying muscle here, this muscle is hyoglossus.
Yeah.
Submandibular gland lies on hyoglossus muscle.
Yes. Right.
And now see another nerve above.
Lingual, yeah, boss.
Can you see?
Yes.
This lingual we saw in the endoscopic, dissection. Coming as a branch from mandibular.
Yes.
See this?
Yeah.
And from this lingual, it gives a postganglionic fiber. See this postganglionic?
Yes.
Which I am taking away. See this?
Yeah.
Yes, boss.
Postganglionic fibers to the submandibular gland. Okay?
Yes.
See, I have taken away. To segregate from the artery. And see what is there in between these two. The lingual above here. अरे यार ये क्या करता है तू? क्यों खींचा उसको यार? Shit. Don't do that. Yeah, okay. Now, see the उसको कर थोड़ा सा retract कर retract. See the lingual nerve above.
Yeah, beautiful.
And the hypoglossal below. And
Yeah.
see what is there in between.
Yeah, that's duct.
That is the duct.
Yeah.
Okay.
Clear, boss. Absolutely.
Centralize, please. Centralize.
Yes.
No, it's okay.
Yeah, boss. Thank you. Keep orienting, huh?
Yeah. Wonderful.
I have a habit of using cautery everywhere, boss. Please. Now, see why I was scolding my assistant here, not to traumatize these veins.
Yeah.
They contribute to a lot of oozing, and if you damage the, traumatize the vena committents along the hypoglossal, see this? They contribute a lot. This venous bleeding is unnecessarily frustrating, See now, this is hyoglossus muscle.
Yes.
Yes.
Yes. See now, the field is good.
Wonderful.
Very clear.
So this is hyoglossus. And now see what artery is this?
Facial?
Yes. See this?
Centralized, out of track.
Yeah. See this artery?
Yeah, very clear now.
So it is pedicled on facial now, artery now.
Yes. Completely. See now? Yes. Laga.
In normal submandibular, you preserve this artery, I think, most of the time.
In normal benign submandibular gland
You preserve it.
section, I preserve this. See now, this is level 1B complete. Level 1B is what? Between the two bellies of digastric. Can you see now? छोड़ दे इसको आपके लेके बैठा है हटा अरे ये वेसल देखिए कुछ चलो cautery cautery see where it damaged the vena committents no
Yeah.
we don't want that अरे नहीं बड़ा नहीं हटा हटा
Hypoglossal is just down.
Yeah, the hypoglossal is there below. So hypoglossal, lingual, marginal mandibular. Three nerves we have seen. Okay?
Yeah.
And the next nerve we'll preserve is the spinal accessory.
Yes.
See, this area of the neck is so fascinating. See this anatomy? So clear?
Yes.
Bloodless so
Beautiful.
far? Now coming to the, yes, good, thank you. See, not a drop of blood. Now, coming to the, this is the area out of the submandibular triangle now, you can see. So, between the submandibular triangle is level 1B.
1B.
So, now we are out of 1B, okay?
Yes, boss.
And behind is level 2. Level 2 is from skull base to the level of the hyoid bone. And it is divided into 2A and 2B by the
Spinal accessory now.
spinal accessory now. See, this is the digastric.
Yeah.
This is a good,
So,
good
boss,
point.
when you will be doing 2B here also?
Yes.
Better too.
For tongue, I really, I know what Devendra is saying is the protocol. That's a very standard protocol. You can follow that. If 2A is involved, then go for 2B.
2B.
And that's a standard protocol. But in other oral malignancy,
But boss, in most of the centers, no frozen section facility.
see this JD node. Can you see this?
Big one.
Though it looks reactive. See this JD node?
Yeah,
Boss.
I showed you that time on the MRI.
MRI was seen well. Yeah.
Loop laga. Yeah. So, idea is what he was saying is correct. The 2B will be involved once there is 2A involvement. Without 2A involvement, you will not find 2B.
So, but if we don't have a frozen section facility, boss, then what should be the criteria to do 2B?
That is essential. Now see, this is our sternomastoid.
Yeah.
I'll open up the sheath. यहाँ से पकड़. I will open up the sheath over the muscle. Can you see this? थोड़ा कम करना. Cautery कम करो थोड़ा यार. See, we have to enter into this space.
Just anterior to sternocleidomastoid.
Yes. And here, can you see these vessels?
Yes.
Yeah, boss.
These vessels many a times are a good guide for
Spinal accessory, boss.
spinal accessory. One of the vein is described by Devendra himself.
Do you, boss, look for the twitch here? Ask the anesthetist to not to give muscle relaxants at this point?
Not really. See this. This is the tendon of the muscle. Can you see this?
Yeah.
That is again a very good guide. You know, this tendon.
Yes.
Okay.
Yes. Between the tendon, can you see this artery?
Yeah.
These are muscular branches from occipital artery to the sternomastoid. See this?
Yes.
And above, very commonly you see, it looks like this one, the vein. Looking at these vessels, see this vessel?
Yeah.
And I am in the vicinity of give me sternomastoid. Can you see the vein now? Can you see this vein now?
Yeah.
This is Choker's vein. If Devendra is online, he must be
Chokers.
Devendra Choker, who described this and published in 2002.
What exactly it is?
See this vein?
Yeah.
Immediately deep to this vein. See this? What is there?
We can see the nerve. Beautiful, boss.
Oh, good.
Thank you, Devendra.
Yeah.
Good landmark.
So we are so thankful to Devendra. See what a landmark?
Yeah, chokers.
I didn't do anything to identify this nerve. It is the Devendra who described this vein, and I call it as a Choker's vein.
No, it is officially chokers vein, or you call it?
No.
I don't know how it is called. But I can call it. I can call it because I know who described.
Okay.
But Kapila.
Yeah, boss.
What an amazing landmark.
Amazing landmark, boss. And this is also important because if you injure this and inadvertently try to catch it,
yes, the
you
bleeding,
can injure the spinal
bleeding management will injure.
Yeah, right.
If Devendra is watching, I request it to come online and throw some light on it.
No, he's not. No, he's not there. Whenever he joins, we just ask him this question.
Yes. See this? So we have to go. See our posterior limit of this, level 2. The anterior limit is obviously the carotid sheath. The posterior limit is the posterior border of this muscle. Okay? So we are on the under. We are, see, I told you this concept of compartments is because of this fascia sheath enveloping the muscles. This superficial fascia, superficial part of the deep cervical fascia envelop this muscle from laterally, okay? And medially, the deep part of the deep fascia, what is that? Prevertebral fascia.
Yeah.
In between these, what is this all? This is all lymphatics. Contained in the fibrofatty tissue. Okay?
Yes.
So for those who want to know what is level 2B, they can see me where I am working.
Yeah.
Agreed?
So it is superior to the spinal accessory nerve.
Yes. See this? I am lateral to this nerve. I am cutting all the way. Lifting the tissue and cutting so that I stay away from nerve. This nerve, majority of the time it comes lateral. Isko ko retract.
Lateral to IJV.
See the digastric.
Yeah.
See this digastric I have retracted. See the IJV. See how this nerve is crossing the IJV.
Yes.
Laterally. Yeah.
Anybody has any doubts about the anatomy, please. Now, all this lymphatic tissue above this nerve, this is level 2B. And
Boss,
what
if suppose the nerve is engulfed by the node or the tumor here, and you have to sacrifice the nerve, can we re-anastomose it with like a cable?
Yes, you can. See, first of all, how this the concept of neck dissection selective. See this now. My superior limit, see the underlying muscle is the deeper limit.
Yeah, boss. Yeah.
Upper limit is the skull base.
Yes.
See, all this fibrofatty tissue I'm bringing. Now, other disadvantage here is you have to be careful. Some of the branch of the occipital artery coming from, deep to this digastric may get injured.
Yeah, right, boss.
Chhod de. See my level 2B clearance?
Yeah.
Yes.
कर इधर. Yes. और कर. अबे यहाँ लगा. Rajeev, clear?
Absolutely clear, boss. So is that the sternocleidomastoid only, na, boss? That is
what?
So,
Retracting.
Yeah, this muscle is
This is sternocleidomastoid.
Yeah.
And what you see there in the floor? Anybody?
That is
this is splenius capitis.
splenius capitis. Yeah,
And
boss.
here would come the levator scapulae.
Levator scapulae, yeah, boss.
See the nodes? See this?
Yes.
Yeah, boss.
There are 5 to 7 nodes in this region. Okay?
Yeah, boss. So, boss, no important structure actually in level 2B, other than nodes which we can damage once we have identified the spinal accessory, because it is a crowded area, and
then only you can define this target triangle. See this? See this? This.
Yeah. Very clear.
यूं कर इसको ना थोड़ा सा उधर लूप थोड़ा सा. See, the biggest problem is with this dissection is the traction needed on the nerve.
Yeah, because this is a very, very crowded area. We have to give a lot of traction.
You must be getting a bigger picture because of the microscope I'm using here.
Yes.
But a beautiful picture.
Pardon?
But a beautiful picture.
Yeah, I believe
so
this.
Beautiful. Yeah,
the microscope, the kind of illumination and the magnification you get with the microscope. See this? This is levator scapulae.
Yeah, very well.
That's what splenius capitis. Levator scapulae.
Yeah.
Okay. Now this dissection specimen I can deliver
under the
nerve to the 2A. Anterior is 2A. रुक जा ओए जल्दी मत कर.
So what is the best nerve to do the cable grafting? To do greater auricular?
Greater auricular.
Okay, boss. Okay.
See now the relationship here. Chhodna. This nerve is 1 centimeter above the nerve point, where all the cutaneous nerves emerge. The posterior border of the sternomastoid, the 4 cutaneous group of nerves emerge: transverse cervical, supraclavicular, the greater auricular, lesser occipital. Okay? This is 1 centimeter above that this nerve is going to go behind. That is another landmark. See, for spinal accessory, there are many landmarks for the, oncologist. Number 1 is see where it emerges out. See this. Where it emerges out, the first landmark is the transverse process of the cervical vertebra. I can feel it for cervical.
Yes.
The nerve is behind that. Okay. Second landmark is that vein. I showed you, Choker's vein.
Yes.
Devendra's vein. Third landmark, इसको इधर से निकाल. प्यार से. कुश्ती मत लड़. Third landmark is the nerve point. See this?
Yeah.
Third landmark is the nerve point here. The nerve is 1 centimeter above the nerve point. And fourth landmark is where it pierces the anterior border of the trapezius.
Yes.
That is 5 centimeter above the clavicle. See, this passes through the thickness of the muscle to run superficially in the posterior triangle. What is posterior triangle? This is the posterior border of the sternomastoid, and here is the anterior border of trapezius. So this now comes here and run very, very superficial in the posterior triangle to enter the anterior border of trapezius. That is 5 centimeter above. So this is one landmark. Second landmark is nerve point. Third is Devendra's vein, and fourth is this occipit, this transfer process.
C1.
Okay?
Yes,
Yeah,
yes.
boss.
I hope it is clear.
Absolutely clear.
Now, as the name implies, this is supraomohyoid dissection.
Yeah.
What does it mean? We have to stay above the omohyoid.
Yeah.
Okay? Hello?
Yes, boss. So we will identify the superior value of omohyoid.
Yes. So above the omohyoid remains the lower limit of the level 3.
Yeah,
And if you have a doubt any time, need to go to level 4, you just retract the omohyoid or sacrifice it.
Yes, yes. Joint, I saw you.
Yes. So that you can go and do even level 4 dissection. Now this omohyoid is an amazing anatomy. See this. If you ask anybody what is the medial limit of your dissection, it is strap muscle. Which strap muscle? Omohyoid. Omohyoid is the surgical limit. See, this is omohyoid.
Yeah, boss.
See this, Chona? This is omohyoid. See that?
Yeah.
So all these strap muscles are supplied by ANSA. You know, the ANSA take the C1 fibers and joins the hypoglossal, C2 and C3 through the hypoglossal. They supply to the. Now, see my limit posteriorly. I will enlarge this posteriorly till the posterior border of the muscle. See like this?
Yes.
Okay? And what is the limit there? Where the cervical nerves emerge. See this? That is going to be my posterior limit. See this?
Yes, boss.
Come kar do cautery. See, I am giving a counter traction. Come kar de. See this counter traction? See the posterior border of this muscle. Can you see this? Can you see the cervical nerves emerging?
Yes, we can just having a
Can you
glimpse
see this?
of white. Yeah, boss.
Can you see this? See 2, 3, 4 emerging from here.
Multiple bundle of nerves.
Multiple cervical nerves.
Yeah, boss.
Can you make out?
Yes, boss.
This is the posterior border of the muscle. So now my next goal is to go into this plane. See this? See, all this tissue lateral to the, the deep fascia.
Prevertebral fascia.
Yeah. So all these cervical nerves, see, you have to preserve. See this?
Yeah. Boss, what is the concept of sentinel lymph node? I have.
Let me discuss. I told you, Devendra spoke about it. Sentinel lymph node is, let me tell you in brief. See, what we are striving for, which patients have a possibility of occult metastasis and which do not have. Okay?
Yeah, right, boss.
Now, how to identify? So, sentinel node is identification of the first echelon lymph nodes by means of scintigraphy. So, in that, the technetium is injected around the tumor, primary tumor.
Okay, boss.
Technetium is injected around the primary tumor. See the posterior level. And
Yes,
what I am
yes.
going above the prevertebral fascia. I am taking all these lymphatics. See this?
Yes.
Yes, yes.
See the prevertebral fascia behind and see the nerves behind.
Yes.
See the cervical nerves. Here. See the cervical nerves here, which I am preserving. Okay. So you inject the technetium around the tumor, primary tumor. Okay. And then by means of gamma camera, you see where it is going to the lymphatics.
Right.
So this way, the first echelon lymphatics, if they are involved, will pick up, will be picked up. See the traction and counter traction. Could you see?
Yes, yes.
Everybody, anybody has any doubts, please.
We are over the carotid sheath now, boss.
Yeah, reaching towards the carotid sheath.
Yeah.
See now, this level is absolutely getting cleared.
Yeah, boss.
The preservation of the fascia, as well as, traction. So, you're okay. Yeah, utha. Yes. See, this is my digastric. Oh, sorry, omoid.
Yes.
See this omoid?
Yeah.
And this is my limit,
Supraomohyoid.
Yes. Neck dissection is something I love because this gives you, what an anatomy. See now, the jugular vein and the sheath over it.
Yes.
Carotid. See all the thing.
Yeah.
Yes.
I'm pushing toward the jugular. Right up to the level of the
prevertebral fascia.
Yeah. Yes. Utha.
Yeah.
See this. See this use of cautery.
Yeah.
Very, very elegant you have to be here. So as not to damage anything.
Yes, sir.
See how the fascia planes open up.
Yes.
And see all the cervical nerves. All this plexus is intact.
Yeah.
Could you see?
Yes,
Very well.
yes, absolutely, boss.
And this is now the carotid sheath.
Yeah, boss. Boss, just orient again to all the viewers again where we are.
Yes.
Yeah.
Yes, yes. Again
Sir,
and again.
you
I
can
will.
also show us where is the nerve point again?
No point. Okay. You remember that then dissection I showed how the greater auricular is arising and coming?
Yes, sir.
Macri's point.
Now
Macri's
point is at the posterior border of the sternomastoid, at the junction of upper 1/3 and 2/3, the four nerves arise. Supraclavicular, transverse cervical, greater auricular and lesser occipital. So the respective areas. And this sternomastoid, this spinal accessory is 1 centimeter above the, point of entry here in the sternomastoid is 1 centimeter above the nerve point. Now see, what is there?
Carotid.
Yeah. See this?
Yeah.
Because see this. Retract. I am onto the carotid sheath now.
Yeah, boss.
Yes, yes.
I am showing 1 by 1 point clear so that you don't forget.
Yeah.
See now. That is your digastric. Retract the digastric, no man. Yes. See this?
Yes.
This is all fascia which I am elevating, which is lateral to the carotid sheath.
Yes, sir.
Give me. Yes. You look. See, you have to be careful here. You're right.
Yeah.
See, this is jugular.
Yeah, yeah.
Yes, yes.
Absolutely.
And I will tell you the simplest way to get away from this region. Yes.
Sir, Professor, hello?
Yes.
The Professor Nishi Songkhya from Jaipur is asking, when will you decide to go for an extended supra-omohyoid neck dissection for?
Yes. In tongue lesions.
Okay.
In tongue lesions, when you are suspecting level 4 metastasis on the basis of MRI or a T4 lesion, T3, T4 lesion of the tongue. In that situation, yes. In that situation, it is better to, because the chances of skip metastasis are there in the tongue.
Okay, okay.
See, this is your this is digestic, jugular. Now give me knife. I will use my knife here. See, this is what? Ansa.
Yes, sir.
Okay. And that posteriorly is vagus, right, boss?
Yes, that is vagus.
Yeah.
What I'm trying to separate is this.
You're separating the fatty lymphatic tissue from the internal jugular.
Yeah, I like the knife here.
Yeah.
So you are at a very crucial point now.
Yeah.
But still, I like the knife here. Knife takes you in the right, plane without any issues. See this?
Yes.
The jugular getting free.
Beautiful, boss.
Non-tooth. See now, below is the carotid here because the jugular is pulled. This is carotid here.
Yeah.
Once I free the jugular, it will come back in place. There is a tributary here.
Yeah, we can see that, yes.
See, all this tissue you can take like this. A knife is a great tool here, believe me. See this?
Yeah, boss. Beautiful. So that is the facial vein, boss, no?
Yeah, you use Kapila sometime knife here?
Boss, I try to use dissect for the hemostat first.
डर लगता है.
Yeah.
No, the knife is the best tool here, I tell you. See now, slowly we'll be away from the carotid sheath.
Yeah.
In no time now. There are a few tributaries that we have to clamp now. See, this is one. Take.
Yes.
Clamp. Udhar bhi. You can use a clip also.
Yeah.
पहले इसको लेना इधर एक बार में एक ले या scissors. अरे क्या करता है यार कैसे लगाया तूने टाई इसको लगा टाई fast यार don't waste time. So we'll be through in next 5-10 minutes for everyone.
Yeah.
Take questions meantime. Paramita.
Yes, sir.
वो कहाँ गया उधर का एंड
Satish, comments about the use of harmonic, especially in thyroid.
Good. I love it. It's good tool. It is saves time as well.
Yeah.
It is quite safe as it works on the ultrasonic principle. It's good tool. Yes.
So can you again demonstrate after you're done the Lassel's triangle and the landmarks to ligate the lingual artery?
For the
landmarks to ligate the lingual artery, and also
why to ligate the lingual artery for that matter? See now the carotid artery. Can you see?
Yes. Very clear.
See this arising. What is this? Superior thyroid.
Yeah.
See this, the carotid?
Yes, yes.
We can see the carotid bifurcation and.
Yeah, Paramita, I didn't get your question. Why to ligate the lingual artery? For that
It is
matter?
an old question actually. It was asked some time back.
No, but I've seen a lot of people temporarily ligating the lingual and then going for the tongue.
Yes, that.
See now, our entire area. See now, level 2B was here, 2A here, along with this, and level 3 here. Completely out. That is the posterior border of the sternomastoid, and these are the cervical nerves which we have preserved. So we have preserved earlier 3 nerves: marginal mandibular, lingual, hypoglossal. This time here, the accessory, cervical nerve, and here is the vagus. And all the brachial plexus are all here below, which is not here. The phrenic nerve, brachial plexus, all below. Now, finally, this is the specimen.
Yeah, boss. So, boss, you have removed it in continuity. So, how will you mark the specimen now?
Yeah, I will unturn it. I've already separated level 1A and 1B.
Okay.
You have to reorient it, mark it,
yeah, boss,
and then send for that. That is important for the pathologist.
Right.
Yes.
Now, this is, the facial vein joining here. I hope this concept of neck dissection is, I know we will do more and more later, but I hope you understood this fact. How to go about.
Yes, sir.
So it's a matter of patience, अरे यार क्या कर रहा है? लगा ये बेकार artery.
So, boss, when you are doing level 4 on left side, how do you identify chyle duct, boss?
Yeah, see, as you go deeper,
yeah, boss.
Here the microscope again scores,
Okay.
With the microscope, this question doesn't exist, you can see. But there is so much of variation, So you have to be careful.
It is very difficult, the mostly because the patients are fasting, the duct is collapsed.
It is transparent.
Yeah, it is transparent, it is collapsed. So even if it is injured, we don't we may not come to know about it that it has been injured. So
yes,
how do you take into that when you are doing?
I will show in next of the dissections. I will show level 4 completely. How to avoid going in the depth. Now see, this is hypoglossal.
Yeah, boss. Yeah.
See that?
Yes.
That is hypoglossal. That is a vein here. The hypoglossal will go deeper in the digastric triangle. And wait. See, have patience and separate in the facial layer. Now, catch this.
This is, I think.
Hata. Gada hai. See, some people may be thinking that I'm not ligating too much. Now see the various levels again. Level 1A, can you see here?
Yes.
Anterior belly of digastric opposite side, this side.
Yes,
and this is hyoid bone as a base.
Right.
Level 1B, between the anterior and posterior belly of the digastric. With this is the hypoglossal nerve here, and the lingual is above there.
Yeah,
and the duct we have ligated. And see all the way our marginal mandibular.
Yeah, boss.
Once you preserve and push it up, you don't need to look at it. Okay?
Yes, sir.
Then level 2. See, I'm a hardcore. This is my favorite subject, oncology, head neck. And I love neck dissection like anything. I want you to, because I want more and more ENTs to go into this subject. You can understand it easily. See now, this is accessory.
Yeah,
this is level 2B. This is levator and this is splenius capitis. This is jugular. This is your carotid fork, the internal and external. This is, crossed by hypoglossal. Can you see?
Yeah, boss.
And this is your omohyoid. And this is how it crosses to the cover to make it level 3 up to here, lower border of the cricoid. And this is how posteriorly you can go up to the posterior border of the muscle where these nerves are coming from and preserving these cutaneous nerve at this level, staying in the prevertebral fascia plane. See this?
Yes.
Yeah,
This
wonderful.
is about, the supraomoid neck dissection. Now quickly, we'll take a turn. We'll change to, the tongue part.
Yes, yes.
Sir, what is the true meaning of skip metastasis?
Pardon?
What is the true meaning of skip metastasis?
Skip metastasis. So, like I said, every site has a predictable pattern of metastasis. First to the first echelon lymph nodes, and then once the metastasis goes to first echelon lymph node, then it goes further to the other nodes.
Yes.
For the oral cavity, tongue, the first echelon are level 1, 2, 3.
Yes.
Okay?
Yes.
And if there is a node at 1, 2, 3, metastasis is 1, 2, 3 positive, then only the metastasis to the other area happen to occur. Okay?
Yes, sir.
So, but in skip metastasis situation, that happens in up to 5 to 7% situation.
Okay.
It's variable in different series.
Okay.
So, there is no metastasis to level 1, 2, 3, and there is direct metastasis to level 4.
Yeah. It is common in tongue, boss. Right?
Normally, your protocol is to cover the first echelon in the neck dissection, like this supramoid neck dissection. We did level 1 to 3, and we have sent this for frozen. If any of these turns out to be positive at any level, we'll wait for the frozen and convert to a,
Level 4,
comprehensive level 4 and 5. So this is how you have to take a call.
Okay.
But if directly level 1, 2, 3 negative and a level 4 positive, that is a skip metastasis.
Okay.
That is unfortunate. Now see. Can you see the primary?
Yes.
Centralized, yes, centralized.
See now.
Centralized. Now it's okay.
Yeah.
Now see, this is 2 centimeter lesion, 2.5. And when we got this MRI done, we started this antibiotic as well, because this inflammation, MRI always overshoots, shows more than what the tumor is.
Yeah, boss.
So now, like Dr. Devendra said, we have to have at least 1 centimeter margin. The reason is the pathological margin should be 5 millimeter. But why 1 centimeter we take? Because this tissue retracts.
Okay.
Tissue retracts. So clinically, we should take 1 centimeter, and I can feel the,
Boss, how do you decide for that you will be able to close primary, or you will need some graft?
So the protocol is, there are variety of people described it differently. So if see, this is the median reference, suppose here.
All right, boss. Yeah.
If only 1/3 of the tongue of one side is gone, you can suture it, primary closure.
Okay.
Without affecting the function much.
Okay.
But if more than 1/3 of the tongue is gone, between 1/3 and 1/2, again you can take a call.
Okay.
But if more than 1/2, obviously you have to reconstruct it.
All right.
There are various ways. Ideal is, because you don't need a bulk here much. Little bit of the bulk, lining. So ideally we prefer it as a, radial forearm.
Yeah.
See, now you can keep palpating all the time.
Yeah.
Keep palpating and stay away from the area of induration. See the normal area of the tongue?
Yes.
I am not ligated lingual, don't worry. But still. See this? Clear margin? Away?
Yes, yes.
Dear boss, yeah.
Microscope gives you another
Yeah,
opportunity.
ultimate.
See the normal tissue, how it retracts.
Yeah.
See this?
Yes.
See the normal tissue.
Yes.
Yeah, centralize.
See the normal tissue. See how it looks like normal tissue. You can differentiate very well. And I'm all the time taking the help of my palpation. Like Devendra said, you know, see, we had amazing inputs from Devendra today.
Ultimate. Wonderful.
And that man is so down to earth. Anytime you can call him, he is always helping to everyone. Always. It is his basic nature, you know.
When you ask to these patients to go for chemo radiation after 10 days,
Pardon?
For radiation, when you send them these patients for radiation, how much time?
My criteria for radiation is depending upon the histology. Clinically, if this depth of invasion is more than 10 mm, you know, I will send for radiation, whether the frozen turns out to be negative or positive. Number one. Now the second criteria is histological. Histologically, same the depth of invasion, then any lymph node positive on the neck dissection is an indication for radiation. Presence of lymph node reduces significantly the overall outcome. That is the single most important determinant.
Yes.
Then on histology, if there is perineural invasion, lymphovascular invasion, you know, differentiation if it is poorly differentiated, extracapsular spread in the lymph nodes, all these are, you know, things warranting the. See now, feeling.
Yes.
Romita, you can take question meantime.
Yes, sir.
Boss,
What is the role of neck dissection in TB lymphadenitis?
TB lymphadenitis is what?
What is the role of neck dissection in tuberculosis lymphadenitis?
No. The role of surgery or anything you do is limited to the diagnosis. TB is a medical disease. Why do neck dissection? Whatever intervention in TB is required is either if there is an abscess or second is to prove your diagnosis. It is normal tongue, how it looks.
Yes.
It's supple.
Boss, how do we take the margin regarding the depth? Was like the outside margins we can take 1 centimeter, but how do we decide how much deep we have to do?
Yeah, deep is palpation. That's what Devendra is saying.
Yeah.
Palpation. See, I am palpating all the time.
Yes.
My finger is there all the time. You know, see this, what I am doing with this.
Yeah, boss.
I am palpating. This is my deeper margin and I am still 1 centimeter deeper. My single tool, man of the match throughout is cautery.
Yeah.
Only instrument in my hand all the time.
And boss, suppose if on histopath your depth is very close to your margin, but the margins are safe, but the tumor is very close. So
Close to what?
Go for, if the tumor is very close in the depth, but still the margins are clear. But
Close to duct?
very like 1 mm or 2 mm difference to the disease.
Rajeev, close to what?
Close to your tumor, the depth, in the depth. On histopathology.
Okay, depth.
On histopathology, let us suppose there is 2 millimeter.
Okay, your frozen says that you are in depth, you are close.
Yeah, boss, yeah.
So once you are waiting for the frozen and it shows you are close, come back and remove more than required again, three-dimensionally.
Right.
Okay?
Yeah, boss.
Or if you don't know and find on the permanent section, then obviously the CTRT.
Yeah.
But you can revise at the same time intraoperatively.
Okay, yeah, boss.
Yes. So, Dr. Puskaraj,
see, this is the dorsal, a deep lingual artery.
Yes.
Deep branch.
Yes, sir. So, what is field cancerization?
Field cancerization.
Yes, sir. Dr. Pushkaraj from Mumbai is asking.
Yeah, because of the etiology, like mostly happens in, the etiology of the paranasal sinus cancer is industrial exposure.
Yes, sir.
Nickel industries and that exposure leads to field cancerization. And sometimes you have to take into consideration the entire field for, definitive treatment. See now my lesion all around, you can see.
Yeah.
See that?
Yeah,
I will
yeah.
take it all around and send for frozen. Catch कर और बांध इसको. No, I can see here.
So what's the plan for reconstruction over here? Yes, you will.
लगा catch. Yes. That's a deep lingual.
Yes.
So now we have two options. Best is the free flap. Or let's see if it is possible. Otherwise, you can do a local flap, facial artery myomucosal flap. That's a simple, but it requires 2 stages. I'll tell you the outline.
Cheek flat, boss.
That is what the same. That is same.
Okay, boss.
That is myomucosal facial artery based flap. See
Okay.
now. So now. See this. Or otherwise you can suture like this. That's it. So this primary closure.
Yes, sir.
Even primary closure will work over here, I think.
Yeah, it can work. It can work. Many a time it works. See this?
Yeah.
Now I have a good. See now the deeper margin, everything is taken care of.
Yes.
See this muscle, everything normal. I can feel it. Very supple,
Yeah.
Yeah, boss.
So you take into consideration clinical, your palpation, your MRI, and you're finally frozen into consideration.
So Dr. Palanyapan is asking, you've said it once, can you repeat once again that why do you prefer knife and not diathermy over the carotid sheath?
Yeah, you're more precise. You stay right deep to the carotid sheath.
Okay.
That plane was so amazing,
Yes.
You have a better control over it. That's a sharp dissection.
Yes.
And more than that, I'm used to it. Like I asked Kapila, why not? Because there is a fear. Fear of lacerating the carotid or, jugular if you're not very sharp about it. So now finally, we'll wait for the frozen. A plastic surgeon will take a call. Okay?
Yes, sir.
And the
Wonderful.
meantime, we can take question. Other next case is ready. That is a hemithyroidectomy. My associate has already raised the flap. And then next case after that is a carotid body tumor. And a very interesting complication of the frontal sinus, which has given cellulitis.
Okay.
Hello.
Yes?
Yeah.
So any question regarding neck dissection?
Yeah, Satish boss, if sometimes the node is so adherent to the carotid adventitia, so how do we take a decide to dissect or how do you?
Yes, that's a very important question, Rajeev. I mentioned in the beginning.
Yeah.
See why we removed all these, lymphatics contained in the facial sheath. Facial sheath and vascular aponeurosis all the way. Hello?
Yeah, boss. Yeah, boss. Yeah.
Yeah. In spite of being in close proximity to the vital structures, it doesn't invade, even if it is malignant nodes. Only if there is extracapsular spread. Got my point?
Yes.
So if there is extracapsular spread, then only non-lymphatic structures will be involved. Then only. So if you say like adherent to the carotid, jugular, any nerve, spinal accessory, sternomastoid, anything, it will happen only when there is extracapsular spread.
Yeah, boss.
This extracapsular spread is one of the most significant factor in terms of prognosis.
Can we see you also?
Huh?
Can we see you also?
Pardon?
You're not
see you, I
seeing.
said. We can hear you, but we can't see you.
Yeah. Can you start this? camera. So this extracapsular spread, let me.
अच्छा absorb होता है.
Just a minute. So even in the recent, AJCC 8th classification, 8th revision of the classification, the recent one, this extracapsular spread is taken into consideration as one of the most significant factor from the prognostic point of view. Any lymph node, whatever size it is, if it has an extracapsular spread, it is N3B.
Yeah. Okay.
See how significant it is. It has been taken into consideration in the recent AJCC 8th staging as one of the most significant factor. Number two, same in the oral cavity. In the AJCC classification, they have taken into consideration this tumor depth. Depth of invasion is a significant factor. Depth of invasion, thickness and invasion are little different terms. We have to understand. So depth of invasion is more than 5 millimeter, more than 10 millimeter or 10 millimeter or more. They are defined as a stage 1, 2, 3, whatsoever the superficial size is. T1, T2, 2 centimeter, 4. If I have a lesion less than 2 centimeter, but the depth of invasion is 15 millimeter, it is stage 3.
3, yeah, boss.
And similarly, this extracapsular spread is something, I believe, why even a T1 lesion of the oral cavity requires an elective neck dissection. When the incidence of occult metastasis is around 20%, 25, whatever, even in the smallest lesion, I would advocate neck dissection because it gives us an opportunity for pathological sampling.
Yeah.
Suppose we don't do elective neck dissection and irradiate.
Yeah.
We don't have histological evidence of anything in the neck.
Yeah, boss.
It has been proven that lymph nodes, even having size less than 1 centimeter, they've been observed to have an extracapsular spread. So if those less than 1 centimeter not picked up by any modality preoperatively, yet having extracapsular spread, and we have not subjected the patient to elective neck dissection, that is a disaster. Because if we know that as an extracapsular spread, we can accordingly advocate the adjuvant therapies, which otherwise you don't know and you don't subject to.
Yeah, boss.
That's why all patients should be subjected for elective neck dissection.
So in this case, boss, if all the nodes are negative and all the margins are free, this patient won't be subjected to radiotherapy.
No, I will observe.
Right.
Now, only one exception.
How long
only
you
one
observe,
exception.
boss, and
Rajeev,
how? Yeah.
Only one exception I have already told. If my depth of primary thickness is more than 10 millimeter, depth of invasion,
right,
still I will subject him to radiation therapy.
Okay.
In spite of having node negative.
No nodes.
So can a cobblator be used instead of?
Yes, nowadays the cobblator probe has come.
Yeah.
It is very good.
Head and neck wand.
Yes, head and neck wand is very good, but the cost is again a limit. Every time you have to use a new wand. And see, being so used to cautery, I don't need any equipment in head and neck. Only good cautery.
Actually, yeah.
That's it.
So you did it so beautifully. You don't need harmonic. You don't need boss. A liga shot in your hands.
No.
The
It
cautery
is
works best.
You see, all people are doing the same way. You see Devendra doing, anybody, Prathamesh and all those guys doing. Amazing.
What about primary closure? There are a few questions on primary closure. What do you think about primary closure of tongue margins? And
Yeah, still this can be, closable, primary closable.
Yeah, boss. Regarding, because tongue is a very muscular structure.
Yes.
So many a times, if the suturing is not proper, the sutures give way. So what special things we need to do, and what Vicryl you use? You use Vicryl in this case, and which one?
Vicryl or PDS. Give way is a big problem in tongue, and once it gives way, it looks so bad.
It looks so bad, yeah. Absolutely.
So best is use the facial artery myomucosal flap from the buccal mucosa, and put it and release it after 3 weeks. The entire area will be covered.
Yeah.
okay.
So, are we doing this myocutaneous flap in this?
Not really. Let's see.
Okay, boss.
I think we'll close it.
Okay, boss.
And how would the speech be in this case? In case we do a primary closure, the speech?
Yeah, it may affect a little bit, but not much. Because anyway, we have not gone to the base tongue.
Yeah.
We have not gone beyond the middle line. It was not required.
Correct.
And it was a good amount of tongue remaining, which will rotate, and in long run, it doesn't affect much.
Okay.
If major amount of the tongue, oral tongue was resected, then it's a big issue.
Yeah, then I think radial is the
And
best
we would
answer.
use ALT or something, anterolateral thigh flap.
Okay, so I don't think so there are any more questions. I think you've explained everything very nicely.
Okay, then we...
Dr. Satish,
yes?
can I ask you a question? After you finished the first case, Bibu sent me one question and she wanted to know about reverse interlay from the first case.
Okay.
She said if you could describe it again. So.
Okay. So what we did in this classical interlay, we raised 360 degree from below, and our flap was, remaining at the level of the malleus intact. Okay. Now suppose we have a perforation centered superiorly, towards the superior margin. We cannot get a good, space to go beyond to place the graft superiorly. Then what we can do, we can elevate reverse and make it inferiorly based. Then we'll raise the flap like we raised inferiorly through the inferior canal wall and anteriorly. I would go through the superior canal wall and would raise and remove the sleeve over the malleus and all and place it inferiorly based.
Okay.
Then I would place my graft from here. Then it would be totally secure for the superior perforation all around. That is reverse interlay.
Okay.
So the next case is a thyroid one. And after that, the carotid body is ready. Next is a carotid body. Very interesting one. Last time that didn't warrant section anastomosis. It's good for the patient. And this one is little bigger than the previous one. And according to the imaging features, I hope we should be able to do it without anastomosis, but you never know before you open.
In last carotid body tumor, you said something about placing a stent intraoperatively, and
yes.
Yeah. So you can you explain that again?
Simple. Suppose when I open this tumor, expose this, and I find that the carotid is difficult to separate, internal carotid.
Yeah.
And if I try to, it will, lacerate.
Yeah.
And you plan for a resection anastomosis. What I will do? Then the entire surgery, resection, how long will it take? Go above, put a bulldog to the internal carotid above, one bulldog to the common carotid, take a scissors and resect along with the tumor. That's it. 2 minutes job. Okay? But we cannot until we reconstruct. Now this area has to be reconstructed. We'll reconstruct with the saphenous vein. And it may take time. You cannot hold the perfusion, brain perfusion, because it cannot be, brain can get, ischemia in 5 to 10 minutes time if the circulation is not good. Not good.
Yeah.
80% of the time the circulation is good, even 85%.
Yeah.
You can't take a chance. So what do? We do that time. We put a carotid stent is like a straw. You saw? We use a straw. That is a metallic shunt.
Okay.
Metallic shunt, like a straw, little bigger to the size of the carotid. So one end we pass into the common carotid, one end in the internal carotid, and we tighten it all around with umbilical tape.
Okay. Above and below.
Above and below. So between the vessel wall and the shunt, there will be no bleeding coming out.
Okay. Yeah.
So now once the flow is going on,
we have time to reconstruct.
You have ample of time. You reconstruct tomorrow. So then what you can do, you make the tube around the shunt. Above and below, you put all sutures, except 1/4 area where you have to remove the tube.
Okay.
Correct.
Once 3/4 suturing is done on both sides,
yeah,
put a bulldog again, remove the shunt, And that in 5 minutes time, you can do that 1/4 suturing.
Okay.
That is much better than suturing all the way without a shunt.
So another question, boss. Do you do angiographic balloon occlusion test? When you do this test in carotid body tumors?
Yes, ideally it should be done. Number one. Secondly, if you have a tumor warranting a carotid resection pre-operatively by all imaging and means,
yes, sir.
Must get done. Number two, like we get carotid angiogram, CT angiogram, MR angiogram. I'll show this today's patient MR angiogram.
Yeah.
If you find adequate collaterals, with both anterior and posterior circulating veins, very good.
Okay.
And you can take a chance because ultimately you are reconstructing at the same time.
Okay.
The problem is when you have no facility for reconstruction. So do we go ahead with the next case? Yeah. So it is 8:45. We'll finish that faster. Thyroid, hemithyroid. We'll discuss the surgical part. Rest we'll discuss sometime in the next week or so. We are keeping a webinar on benign head and neck lesions only.
Okay.
That will include submandibular, parotid, thyroid, preauricular sinus, branchial fistula, thyroglossal, hemangioma, lymphangioma, all
Do
those.
we have a
XYZ.
ranula in the list, boss? Plunging ranula in the list?
We'll keep that also. All those benign head and neck lesions. Then we'll discuss in detail. So this and immediately will be carotid body ready.
Satish, one question. Satish?
Yes.
One question from Dr. Ravi from Muscat, Oman.
Yes,
suppose on this is in a specimen margins are free about 1 centimeter, but dysplasia is there are 2.5 millimeter from the margin.
Yes.
Then will you advocate radiotherapy?
See, that is again a question mark. Sometimes, in the margin, you may be having a free of cancer, but maybe dysplastic, maybe carcinoma in situ, maybe oral submucous fibrosis. So that is not a normal mucosa or normal margin around. Then it's a difficult call. You have to take according to the local factors that time. With dysplasia, and if that dysplasia is resectable all the way without adding on to morbidity, you can. Carcinoma in situ, obviously you have to consider it a positive margin.
Yes.
Oral submucous fibrosis, that you can leave, and that is a positive sign having submucous fibrosis. Because of the submucous fibrosis, the lymphatics are already clogged because of the fibrosis, and those have a least chance of lymphatic metastasis.
But most of these
dysplasia is one thing we have to take a call. That's a valid question, whether to include it into margin or not.
One question.
Sir, you have already told us about the trismus. Can you just say what other approaches there'll be for the patient of trismus? What will you do, sir? Doctor?
Most of these cases come with trismus actually. Most of these patients are coming with trismus.
You can divide the trismus.
Okay.
You can divide the fibrosis with a laser or something.
Okay.
And
for that matter, we do a lot of cases, primary cases of trismus, not without malignancy, at grade 3 or 4 trismus. And what we have realized now, the best thing is, after explaining the patient if he is willing to have external scar, bilateral complete fibrosis resection, you can open up completely.
And anything to the coronoid process?
Bilateral nasolabial flap.
Anything to the coronoid process?
Huh?
Anything to the
coronoid with coronoidectomy.
Okay.
So in tongue CA, boss, when will you do pull-through approach?
That's what I was asking Devendra. So if you ask me, my indication is for T3, T4 lesions always.
Okay.
For T1, T2 lesions, if my MRI shows any lingual lymph node,
okay,
median or lateral, I would go for pull-through.
Okay.
Because otherwise you may leave the disease in the intervening area.
Yeah.
That is lymphatic tract.
Yeah. Okay, boss.
And sir, can you just tell us once again about the facial artery myomucosal flap?
Yes. So what is that? The buccal mucosa. See, the facial artery runs like this.
Yes.
From 1 centimeter from the angle of mouth. and goes up. So here in the buccal mucosa behind, based on this artery, we can take the mucosa and the underlying buccinator muscle, base posterior, inferiorly or superiorly, wherever you are, taking your flap. The entire buccal mucosa, leaving 1 centimeter from the angle up to the parotid duct orifice.
Okay.
The entire thing you can take and rotate to the tongue. The only thing is this is required to be released after 3-4 weeks.
Okay. Okay.
But it is good. You can do a primary closure of that part of it, and it works very well.
What are your follow protocols when you ask for any radiological investigation, PET scan or CT, whatever you
see for this lesion? We don't need anything. Yes, if suppose everything turns out to be negative, we'll do nothing. We'll just monitor, or if anything warrants, we can get an ultrasound done. Now, if it turns out to be positive, this will be subjected to radiation after the comprehensive neck dissection, complete radiation as well. And after 3 months of completion of radiation is the time of imaging. After 3 months.
Yes.
For advanced cases, suspecting distal metastasis and all, you can get a PET scan done. Otherwise, for the areas, you can even get a good MRI with diffusion weighted imaging. Can work.
Okay.
You can take for thyroid now because.
Yes, sir. I think we can move
Okay.
on.
Confirm कर गया?
Rajeev, do you have any imaging protocol post-op for oral cavity lesions?
No, sir. I prefer to do ultrasound neck most of the time rather than any CT or MRI. So if there is some lymph node enlargement or something, that is picked up best by the ultrasound.
I think we have in Agra is PET scan sometimes because most of these people they just afraid of metastasis that we go for PET scan. Otherwise, the ultrasound is the best.
PET scan has become a fashion.
Yeah.
Fashion now. That's
Yes.
so many people ask for this, and
It's not 100% reliable though.
Absolutely, and the amount of radiation, you're subjected.
Still, ultrasound is I think the best.
Yeah, absolutely. For the neck, I think ultrasound is still good enough. A good ultrasound. Rajeev, any idea about the history of this patient, the thyroid?
No, I don't have any history.
Oh, actually, I missed Dr. Prakash Munka's question. He was asking, do you always do neck first and then the tongue?
Hello?
Yeah.
Yes, Ramita, can you repeat the question?
Dr.
Whether you always do the neck dissection first and then
asking, do you always do the neck first and then the tongue, or first the tongue and then the neck? And if
Yes, sir. Convey my regards to sir. Always neck first.
And why?
Always address the secondaries rather than doing primaries and possibility of disseminating the lesion. This has been earlier thought, which has been believed. So it's always a practice to address the secondaries first.
so, sir, can you tell us about this patient?
Okay, this is a middle-aged lady. See, are you getting the picture?
Yeah.
Hello?
Yes.
Yeah.
Zoom out little bit.
Little zoom out, yeah.
Yeah, my associate has already raised the flap.
Beautifully raised.
So this is a middle-aged lady who presented with neck swelling on the right side in the thyroid region. Our investigation protocol for such patients is first to know the hormonal status, euthyroid, then subject to ultrasonography first. I believe a lot in ultrasonography for many reasons. Ultrasonography is one investigation which not only gives you the full idea about the lesion, characteristics of the lesion, but to certain extent, quite reliably, if your sonologist is good, it can differentiate into benign and malignant, lesions. Why we are operating on all these thyroid swelling? either they are malignant or suspicious of malignancy or indeterminate or something for a final diagnosis. If it is benign, no need. So there are certain characteristics on sonography by means of which you can have a fairly good idea there could be malignant, like microcalcification, extracapsular spread, loss of echogenicity, vascularity, so many things. And then once you have a sonography in hand, then you subject for FNAC, because FNAC is the only investigation which can give you, the cellular characteristics, what exactly it is. But having a prior sonography gives you an opportunity for a, sonography directed FNAC, because certain areas, like if you have a solid cystic lesion on sonography, it is better to do a sono-guided FNAC from the solid area rather than a blind FNAC from cystic area. It is of no use. So prior sonography directs you, dictates you to take a aspirate from a proper site. Okay? So this is a sequence, and according to the, the popular Bethesda classification, categorized into various categories, 6 categories, you have to take a call. If it is non-diagnostic, you have to repeat it. Repeat it, sono-guided. If it is again negative, and you are highly suspicious clinically, either observe or operate. Benign, observe. Indeterminate cytology, again, looking into clinical characteristics, nowadays molecular cytology, molecular and other things. You have to take a call whether it could be malignant, otherwise do a hemithyroidectomy and take it on the final histopathology, frozen and other things. Same is suspicious of follicular neoplasm. Then suspicious for malignancy, you have to operate. Malignancy, you have to operate. And malignancy thyroid is a different subject, to discuss. 3 days. It's a complete science in its own. There are variety of malignancies in thyroid from differentiation point of view, from well differentiated to poorly to undifferentiated. Like papillary and follicular are well differentiated, having extremely good prognosis. Thyroid is one malignancy. This organ gives malignancy, amazing in the terms. At one end of the spectrum are well differentiated cancer, papillary and follicular, having the prognosis where the prognosis is measured in terms of decades. So good a prognosis in follicular and papillary. And secondly, they are avid to radioiodine, so that can take care of even the distant metastasis. On the other end of the spectrum, the most undifferentiated or anaplastic carcinomas, they are most lethal in the body. Once diagnosed, anaplastic carcinoma is rare to see surviving a year after the diagnosis. It's so lethal, one of the most lethal in the body. So thyroid is amazing, and in between and poorly differentiated. Then other is the C-cell medullary carcinoma. So thyroid cancer is a different subject and very interesting and very important for the ENT as well, because they have extremely good prognosis. Okay.
Any role of nuclear thyroid scan as a preoperative?
Not really. To rule out hot nodule, because hot nodules are unlikely to have malignancy, you can avoid surgery. But looking at the euthyroid status, you can take a call.
Correct.
Very rarely required. So to orient you for this patient we have planned, this is suspicious of a follicular neoplasm. So what we have planned, hemithyroidectomy. She's a 40-year-old, didn't have opportunity to get molecular test and other tests. There are so many things to further, clinically, molecular, another way, radiologically, to characterize whether it can harbor malignancy or not. Otherwise, do a hemithyroidectomy and take a call. Okay? In follicular neoplasm, even the frozen doesn't help much.
Yes.
You are very lucky then, because frozen needs the evidence of vascular and capsular invasion, and frozen requires, few cuts only to give a fast report, few cuts, and that may not pick up that. So this is superior, this is inferior, this is right side where I am standing away here. Is that clear?
Do you believe?
Yeah.
Yes, sir. Do you believe in subtotal thyroidectomy? Total thyroidectomy is what is subtotal thyroidectomy? Many people are asking.
I know only two thyroidectomies, hemi or total.
Hemi total, yes.
Yes, I don't know other thyroidectomies at all. And subtotal thyroidectomy, near total thyroidectomy, rightly said by someone, are done by subtotal and near total surgeons.
Boss, a few days back, I did a thyroid case. It was a huge retrosternal thyroid.
Yeah.
But the interesting thing was the retrosternal part was totally separate from the normal thyroid above. So that was a very tempting case to leave the normal thyroid. So, but I following your principle, I removed
was
both
that
the
thyroid
normal
only? Was that thyroid only histologically?
Yeah, so I have sent for the eyes, but it was connected to the normal thyroid tissue.
Connected,
but,
no?
Yeah, it was connected, but the normal lobes were normal above, but it was huge retrosternal thyroid below.
Must be benign.
Yeah, it was benign. So in those cases, can we preserve the normal thyroid above?
Pardon?
So can we do a variation by not dissecting the normal thyroid tissue?
Yeah, if it is benign, see, the retrosternal indication for surgery in retrosternal is different.
Yeah.
There is Mars effect or something like that.
Yeah, the patient was having respiratory distress from lying down.
Yeah. And if it is pure benign, you may not be so radical about the primary thyroid.
Yeah.
See now what I'm doing. I'm utilizing the entire incision, My primary incision was from, see, this is always, you can say, tailor-made. It's not about the size of the incision, which is fixed for everyone. But by and large, this is not very big. So one anterior border of the sternomastoid to another. It is a bigger one. I don't mind increasing the incision. I believe in, exposure. Now, what I've done in the midline, see this. This is midline refen. I need to find out. So how can I separated the tissue first, Uta? See that?
Yes.
And now I am opening the fascia. See this by lifting it. Can you see this?
Yes.
The fascia is dying to be cut.
It's a nice midline desiccation is seen.
મારી તો મીટિંગ ચાલુ જ થઈને મેં પેલું વર્ચ્યુઅલ કાઢી નાખું પણ મારો ફેસ નથી દેખાતો એવું કેમ હશે વર્ચ્યુઅલ દેખાતું પણ મારો ફેસ નહીં દેખાતો તો
Who is talking?
Sometimes we get one side, right, suppose right or left thyroid we have, and we have to get a proper cosmetic incision to get a post-operative. What is the incision protocol? Which, because after surgery we get unequal stitch marks over there. So how we can prevent it?
How I didn't get. Can you repeat, boss? Sorry,
Suppose that the thyroid lesion on the right side, and to get a proper cosmetic incision on the equal side, because if there was a prominence, we never get difficult to get a proper lined incision.
Always try to make the incision in the neck crease. That leaves the minimum, cosmetic morbidity. That is the best way. Now see, I have separated some muscle. Can you see midline? Which is this sternohyoid? Very important muscle I mentioned during the facial nerve course. Sternohyoid as a flap. Sternohyoid as a flap for the lower lip angle. That is pedicled. Sternohyoid as a free flap for the zygomaticus major. You remember? So this the most anterior muscle in the midline. See that?
Yes.
This is sternohyoid. Okay? Step muscle. And deep to the sternohyoid, can you see another muscle?
Yes.
That is fan-like, this one. That is what?
Sternothyroid.
Sternothyroid. Both are supplied by ANSA, See, this neck surgery is all about, obviously, decision-making and everything is important in malignancy and all that. Anatomy.
Yes.
It's not difficult at all, believe me. I wish a lot of people who have seen neck dissection to start that, as a lot of ENTs are, not very interested, keen to do head and neck. But we can do better. We know microscopic work. We have an edge. And it is very rewarding. And, as far as difficulty concerned, learning curve is concerned, is minimum as compared to the endoscopic and microscopic surgery.
Yeah, and the anatomy is fairly predictable.
Yes.
Most
that is from Surat. We have one more great ENT surgeon, Dr. Venus Patel. I think she does lots of thyroid.
Oh, great.
Venus, you are there? Unmute yourself.
Yeah, I'm here. Thanks.
Is he with us?
Yeah. Good evening, sir.
Good evening. Nice to have you. See now what I'm doing, I'm utilizing the incision, full incision. What I'm going to show you is the simplest way to approach for the hemithyroidectomy, and the same is for the total as well, if you complete on the other side. So what I'm showing is here is the midline.
Yeah.
It is, that is sternothyroid muscle draped on the gland.
Yes.
The gland is immediately deep to this muscle.
Yes.
See that? Very clear?
Yeah.
I hope it is clear.
Yeah, very clear.
This is what I believe in utilization of the entire surgical field, Once you've opened.
You have some external extension.
Pardon?
Agnish Patel from Mumbai is asking, would you do total thyroidectomy in case of huge MNG non-risk?
Yes. Yes. Who is asking?
Dr. Agnish Patel from Mumbai.
Yes. For the huge multinodular goiters, yes. Total thyroidectomy, many a times. So, see, why I'm saying no subtotal, near total. Let me tell you. It's not that I don't want to do it. The biggest concern of revision surgery in a situation like you have done a subtotal, near total, to go back to the field and remove the remaining thyroid, you can imagine how difficult it would be. And why subtotal and near total are being done? To save the parathyroid, to save the recurrent laryngeal nerve, all that. And with that, if you have to go back to the operating field to complete it once it turns out to be malignancy, then whatever is the situation, there is high possibility of injuring everything you have left behind. So, total thyroidectomy, and total thyroidectomy. Hemithyroidectomy for a limited size lesion, even if it is malignant, whether a small lesion, can be justified. Very, very rare to find such lesion. Now see, I am separating this deeper muscle. Can you see this?
Yeah.
See this, what I am doing now. That is a very important maneuver. I want to go in my lateral paratracheal gutter. Utha ek side se pakad. Ek side se. See this?
Yes.
With my finger keeping them apart, I wish to enter into the lateral avascular paratracheal gutter. See that? Can you see?
Yeah, very well.
What an avascular field. See this?
Yes.
See this? And that is where my all neurovascular structures are likely to be. I can easily identify them. See, this is the key to identify the further structures. If you are in the right plane, see what is there in this plane? That is inferior thyroid artery, so prominent.
Yeah.
So if you are in the right plane, see now I will show you, by means of finding this vessel, by means of finding this vessel, you can find other structures further. So I will take you our proposition of identification of the critical structure. What I believe in thyroid surgery, I have seen a lot of people, general surgeons, doing thyroid like, clamp and cut. Clamp and cut. That is something you can't even think of. That is not science, I would say. You have to do a proper work. So in case, even if it turns out to be malignancy, you don't have to go back. See, this is my plane of the great vessels. Can you see this?
Yeah.
Can you see the carotid artery and the jugular here?
Yes. Yes.
That is the plane of great vessels. I will show that. Open up and show. And here laterally, I am opening the tissue more and more inferiorly. See this?
Yes.
This is very important to go inferiorly. I will tell you the reason behind that. Inferiorly is the safest point to identify.
Thyroid is going into retroesternal area.
Pardon?
If it is going into retroesternal area, what a protocol? What precaution you will take, and what retroesternal extension of the thyroid?
Yeah. So you have to open. Sometimes all retroesternal extension. See, this was not an inferior thyroid artery. What was that?
Thyroid. Middle thyroid.
Vein. Why I am saying so? Anything which is crossing the artery laterally cannot be a artery. That is a vein. इसको clamp kar. That is middle thyroid vein because it is so lateral to the artery. I'll tell you where the inferior thyroid artery is going to come. Yes. Inferior thyroid is a branch of thyrocervical trunk, which is a branch of subclavian and comes from below deep to the carotid artery. You are asking about certain structures, like you asked about the, that trunk, thoracic trunk, chyle trunk. All these are deeper structures and you have to be very careful when you go deeper. So deep to the carotid is an important area, the vertebral artery, the sympathetics. See now, can you see the vessel?
Yeah. Yes. Very well.
That is. Why that? Let me tell you the reason. I will tell you the reason where it is coming from. It is coming from deep to carotid. That is the feature. Yes. Now, first, let me show you the deep vessels, the carotid and the jugular, so as to orient you. See this?
Centralize a bit. Yeah.
Yes. Just a minute. Just rukna. Good?
Yeah, perfect.
Can you see the internal jugular here?
Yes.
This one?
Yeah.
And can you see the common carotid here?
Yeah.
See both the vessels?
Yes.
Now, let me show you by opening the carotid sheath here, something. Just for the sake of demonstration. See this vein? See this again lateral to the carotid?
Yeah.
This is vein. See, this is carotid artery. Very clear?
Yes.
And my vessel, see this, just a minute. It is coming from deep to carotid artery, and this is the first structure I intend to see in this paratracheal groove. Or the paratracheal gutter, avascular area. See this? This is carotid?
Yes.
So in our practice, in our webinars, some or other way, maybe ear, nose or throat, whatever, we have to play with the carotid everywhere. Non-tooth. Now see this vessel coming from deep to carotid. Can you see?
Yes.
Very clear or not?
Very clear.
See this vessel.
Yeah.
That is coming from the thyrocervical trunk. That is inferior thyroid artery. Okay?
Yes, sir.
And this is going horizontally towards the thyroid lobe. Now, why I intend to see this as a first structure for many reasons. I intend to see for many reasons to identify the other structures. And at the same time, I don't want to divide it so laterally, you know. So laterally. Can you see the other now below?
Yeah, beautiful.
This has a very close, intimate relationship with the recurrent laryngeal nerve.
Yeah.
You know, sometimes the nerve crosses the artery, sometimes the artery crosses the nerve. Sometimes the nerve passes through the branches of artery, sometimes the artery passes through the branches of the nerve. See this?
Yes.
And these are the branches of the nerve. Can you see here 2 branches?
Yes.
Now, identifying this vessel takes you easily to the recurrent laryngeal nerve, number 1. I hope the picture is good.
Very good.
Very good.
So you have seen the nerves. See both the nerves, the branches of the recurrent. Can you see?
Yes.
Do I increase the magnification? See that? Very clear?
Yeah, very clear.
Clearly see.
Now, it is so easy to identify the nerve here now. Okay? This way. And the reason I'm, I'm able to identify so easily is the microscope again. Because I'm doing microscopic.
Yes.
I can see Dr. Venus Patel joining us. Welcome, madam. Can you unmute?
Thank you, sir.
Welcome. So now, how to identify in case you don't see the nerve here? Okay? Simplest way. I refer to a triangle. See, here is the trachea in the midline.
Yes.
Here is the carotid converging below.
Yeah.
And this triangle is completed by this inferior thyroid above. This is Lore's triangle.
Yes.
You know the great Lore who's written the Lore and Medina Atlas.
Yeah.
One of the Bible of head and neck, surgical oncology. Head and neck surgery. Lore's Atlas. Now see why I always, I separated this strap muscles from below additionally. Why?
Yes.
Because we always intend to see this nerve in the lower part of the neck. Why? 2 reasons. In the lower part of the neck, it is always in a single trunk. Can you see this?
Yeah. Very well. Beautiful.
If I don't see in the lower part and identify somewhere above, suppose had I identified one of the branch, I would have ignored the other one and could have injured any time. So if you identify in the lower neck, it is always in a single trunk and there is no chance of injuring any of the branch. You can follow it to whatever number of branches above. See this very clear?
Very nice. Beautiful.
See now how it is branching.
Right.
See this?
Yes.
That is the recurrent laryngeal. Now, the second advantage of identifying the lower part of the neck is sometimes it is non-recurrent. And you never know. Because every time you don't have a CT scan of the thorax. Because in certain situation of the abnormal position of the subclavian artery, where this nerve wings around on the right side, if subclavian is anomalous, this nerve is going to be anomalous. So in cases where the subclavian is not in the position and going behind the esophagus, this nerve, rather than coming from below like this would come likely directly like this, non-recurrent. And since we don't respect any nerve in the horizontal plane like this, if you don't know, you can easily injure. While I was separating the fascia, I could have injured that.
Can you again explain the subclavian artery and relation of the...
Okay. Let me tell you. This recurrent laryngeal nerve, why it is non-recurrent? It arises from the vagus in the thorax and then comes back in the neck. Okay? On the left side, it wings around the arch of aorta and come back. It is a longer intrathoracic course.
Yes.
It is given off quite lower in the thorax.
Yes.
On the right side, it wings around in the upper part of the thorax, around the subclavian.
Yes.
So in cases where the subclavian artery is anomalous, the subclavian artery is not in the position and it passes many a time behind the esophagus to give rise to dysphagia. We call it a dysphagia lusoria.
Okay.
And then there is no recurrent laryngeal nerve. Then the vagus nerve gives this nerve in the upper part of the neck only and gives directly. Then this nerve would course right from here to here like this horizontally.
So aberrant subclavian artery is always associated with non-recurrent laryngeal.
Yes, and that is in very small percentage of cases, and that too on the right side, because on the left side wings around arch of aorta.
Yeah.
Yes.
So in cases where there is aberrant, aberrant course of the subclavian, and you never know, you don't have a, if you have a CT thorax, you can pick up, and we don't get in every case. So what you can do, identify, look for this recurrent laryngeal nerve in the lower part of the neck. If you don't find here, be suspicious of a non-recurrent and start respecting anything coming from above horizontally. What's my point?
Yeah, very important point.
Number two, so two advantages of identifying this nerve in the lower part of the neck. One is you find in a single trunk. And number two, you can avoid injuring in case there is a non-recurrent laryngeal nerve. Clear?
Yes.
Now, we have found this, artery, inferior thyroid, and we have found this recurrent laryngeal nerve. Now, the most important part of the surgery, as far as preservation is concerned in the thyroid, is the preservation of the parathyroid.
Parathyroid, yeah.
Because the morbidity of the parathyroid injury, is n number of times higher than the morbidity of the thyroid cancer itself. If you happen to give in a total thyroidectomy a complete permanent hypocalcemia, it's a disaster. That makes the patient life literally crippled, with complete permanent hypocalcemia. So we have to do every possible thing to preserve the parathyroids.
Yes.
And that is why I strongly advocate the microscope in thyroid. The reason is identification of parathyroid is so difficult otherwise. They are so tiny glands, a few millimeters in size, and the color is variable. They are found in, submerged by the fat all around, and it is their position is so variable. They are not constant in location, always. So how to identify them? The best way to identify parathyroid, you ask me, is identifying the vessel going from the inferior thyroid to the parathyroid gland. Now, wherever it will be, the vessel will track us to the parathyroid. And that is the most certain way of identifying parathyroids in the most difficult condition. So, number one, this vessel gives branch to the parathyroid, inferior thyroid. We never advocate ligating the vessel as a trunk laterally. To ligate it laterally in the main trunk, before it gives branches, it will devascularize the parathyroid. Then preservation of the parathyroid is of no value. Devascularized parathyroid doesn't serve any purpose. So it is not the preservation, it is the preservation with vascularity which is more important. What's my point?
Yes.
Rajeev slept?
Yes, sir. Very much there, boss.
Sir,
Very much there.
Prakash Sharma is watching your surgery, is asking.
Who?
Dr. Man Prakash Sharma.
Oh, convey my regards to sir.
So he's asking what percent you have seen non-recurrent.
Yeah, less than 1%. My practice, I have seen only few numbers, 4 or 5 cases so far.
Okay.
The literature is divided, but I have not seen much. You must have seen more. He's more experienced for many years. But I have not seen much. 4 or 5 cases total so far.
And then you advise CT scan and like pre-op, had you done CT scan in those patients?
No, in every case is not, no advisable. And thyroid, we generally try to avoid getting CT scan unless it is warranted, like a retrosternal lesion or, going behind the airway or invading the airway, invading the great vessel, something like that. Otherwise, we don't advocate, because when you give iodinated contrast and it turns out to be malignancy, then to start the radioiodine is delayed because of the iodine you have already given. What's my point?
Yeah.
Yes.
Now see, The commonest location of the inferior parathyroid, I tell you, commonest, though their location is so variable. Why I am saying so? The inferior parathyroid arising from the fourth branchial arch, they go and descend below, and their commonest location of the final position where the descent is physiological descent stop. Commonest location is anterior to the plane of the recurrent laryngeal nerve and below the level of the inferior thyroid artery. That is commonest. It may be anywhere. Sometimes the descent is not stopped and you will find in the mediastinum. Sometime in the thymus below. Sometime in the gland itself. So it's difficult to track. Sometimes you have to start a search for it. And secondly, it is embedded in a fat tissue. So in order to identify it, what we propose, the best is see the vessel arising from the... Can you see the vessel arising from the inferior thyroid?
Yes, yes.
Can you see the inferior thyroid artery here?
Yeah.
Can you see the vessel arising from it?
Yes, we can.
And see this fat pad. Can you see this fat pad?
Yeah.
This is anterior to the plane of the recurrent, and see, this is my parathyroid. See this?
Yes.
See this caramel colored? Beautiful. See this parathyroid?
Very, very nice.
And see my vessel where it is going to. Let me show you. Can you see everyone? Everyone see the parathyroid. This is the inferior parathyroid. Can you see here?
Yeah, boss. Beautiful.
Embedded. See this inferior parathyroid now very clear.
Yeah.
Yes, very clear.
There should be no doubt about it. Okay? And this is embedded in the fat pad. Sometimes it is difficult to distinguish between a fat and a parathyroid because as the person becomes more and more elderly, this loses its brown color and becomes more and more yellowish.
Yes.
Difficult to distinguish from muscle. Sometimes there are nodes in this region in malignancy because this is paratracheal region and difficult to distinguish between a lymph node and the parathyroid. Sometimes it is difficult to distinguish from the thyroid gland itself. So the best is follow the vessel. See this vessel?
Yeah.
Amazing. And this is going to the parathyroid. This will take us right to the parathyroid. So amazing.
Yeah.
Number one, that is the beauty of microscope. You can't see a naked eye. So, rightfully the parathyroid. So,
it's a very big, huge vessel, was huge vessel for.
Yeah, so it is. Sometimes it is very tiny.
Yeah.
We are fortunate that we got a good size vessel. But in any given situation, don't do any sort of handling with a parathyroid much because this vessel may go in spasm and this may get devascularized. And once you find, keep an eye. If it gets devascularized, it turns into jet black color.
Yeah.
Okay.
So, boss, if it devascularizes, why don't we place it in the sternocleidomastoid? Why we always prefer in the forearm?
Yes, I tell you the reason.
Yeah.
Once it is devascularized and you have found it, first of all, you have to confirm it is parathyroid, not by clinical judgment now. Because now you are transplanting.
Yeah.
So you have to do a frozen section, that is must. Confirm a sliver of it, send for the frozen. If it turns out to be parathyroid, mince it into smallest of the pieces you can. Smallest submillimetric pieces. And then like a fluid, it can make like a fluid. And then inject in the forearm because anywhere in the neck, if you insert and this patient develops any recurrence later on, and in long term, what may happen, you never know. Any patient requires radiation therapy or something later on. Why to jeopardize the parathyroid? Take it away from the area of interest of the neck,
Okay.
So we inject in the brachioradialis muscle in the forearm. That is good. You can easily identify and put a,
But otherwise, it will function well in sternocleidomastoid also.
Yeah, it will function anywhere in the muscle.
Yeah.
There are lots of studies done where the transplanted parathyroid started functioning in 3 to 4 weeks' time.
Okay.
They do work.
Centralize, please.
Yeah. Now see, this was the branch given off there.
Yes.
Okay. And there is another branch given off there. See this superior. Can you see this?
Yes.
Centralize, please. Centralize.
Can you see for the superior one, the tiny branch? Can you see here?
Yeah, now it's
Yes, we can
Yes or
see.
not?
Yes, yes.
It's clearly seen, sir.
Yeah. So having seen both the branch given off by this artery, you can take this artery distal to the branches given off and ligate it. That is so close to the gland. Okay?
Yeah.
Not proximally. Otherwise, you can devascularize them easily.
So Deepak Altipur also joined us.
Who?
Deepak sir.
Arey sir, pranam. Sir, welcome.
I am your thyroid student, Satish.
Arey sir.
You taught me whatever thyroid I do today, I owe it to you.
Arey sir, it's not like that. You are amazing.
On record, you are the only person who gave me your own patients and taught me on them in my life.
That was a pleasure for me, and you have done so well on them.
No.
I am so happy.
You have revolutionized the concept of thyroid surgery. Yes. All the
Yeah. Absolutely.
and so many things been
Absolutely.
We are following these steps to find out.
Yes.
Even general surgeons now are following Satish Boss concept.
Yes.
Off the record, they feel.
Yeah, I agree in that. Many of the general surgeons now know Dr. Satish Jain now.
Yeah.
No, and thanks to Satish, in my hospital, general surgeons hardly do any thyroids. We do everything.
Arey sir, your hospital, I always, miss. I had such a great time at your center, always. I think after my OT, I have done maximum cases in your theater.
Yeah. And amazing cases. Yeah.
How many till now?
Now, we have identified the inferior thyroid. See this?
Yes.
Inferior parathyroid, the next structure to identify the superior parathyroid. Superior parathyroid is more predictable than inferior one, by and large. Their descent is stopped most often. See, let me clear this to the capsule. See this. What I am trying to find out, this is the trachea, where it becomes the cricoid cartilage, the cricotracheal junction. See what I am feeling?
Yes.
Broadening of the trachea.
Yes.
Okay? And behind that junction is this, this recurrent laryngeal now passes to the larynx.
Yes.
Okay? So, behind the cricotracheal junction, this most of the time the superior parathyroid, see now I am separating it away from my specimen.
Yeah.
See this. This superior parathyroid here lies at the cricotracheal junction behind the plane of the recurrent laryngeal now. This inferior parathyroid lies anterior to the plane of recurrent laryngeal now. And the superior parathyroid lies behind the plane of the recurrent laryngeal now. See this. See, this is the recurrent laryngeal now, and behind the plane, embedded in this fat pad. Can you see this fat pad?
Yeah.
And why to disturb it unnecessarily? I can see my vessel going to it. See this. So this is how you can identify the superior parathyroid as well in that region. Once you have identified the parathyroids, then the last thing before I resect the specimen is the preservation of the external branch.
Yes, that's your signature step.
Yeah.
I have already told during the facial course that we use ANSA in case you need a neuroreferee to the recurrent laryngeal nerve, which is involved by the cancer or injured iatrogenically.
Yes.
So ANSA hypoglossai in the same field. See, ANSA is here. That is the carotid sheath. Okay? You can do a non-selective reinnervation of the recurrent now to keep the
Zuckerberg.
This is the Zucker-Candle's tubercle.
Yes.
See this. Leave it. See, this is Zucker-Candle's tubercle. Can you see?
Yeah.
This is the extra tongue of tissue under which the recurrent laryngeal now passes. See this.
Right.
Yes.
Why to take into consideration certain landmarks, though, which themselves are not very clear. We don't take into consideration this. See, literature, you will find everything. You have to choose what best can offer you the reliability. Now, having separated this everything, now my last critical thing to identify, which people consider difficult, I'll tell you the way out. is the identification and preservation of the external branch. You know, if you remember during the dissection, I showed the superior laryngeal nerve.
Yes.
Which goes towards the larynx and divides the thyroid membrane into external and internal branch. The external branch goes along the superior thyroid pedicle. Superior thyroid pedicle. This is superior thyroid pedicle entering into the gland. And just before entering the gland, it turns medially to enter into the cricothyroid. Okay? In the internal laryngeal nerve, this is external. The internal goes inside the thyroid membrane to supply the supraglottic larynx. So this external nerve is very important now. Many a times surgeon injure this and patient may not appreciate because, but if you injure it in a professional voice user, his career is gone. Because this is a tensor muscle of the cord, which is important to raise the pitch of the voice. And in a professional voice user, this is a very important muscle now.
Yeah.
So for anybody, we need to preserve it. Now see what I'm doing. I am pulling this thyroid gland towards me, same side. What I need to see, the upper pole of the gland. See this upper pole?
Yeah.
See the superior thyroid pedicle? See this superior thyroid pedicle? I told you this nerve runs along the superior thyroid pedicle, and just before these vessels enter into the thyroid, just before it takes a medial turn to supply the cricothyroid. Okay? So I am looking for that point. See now? By opening this triangle, this is Joll's triangle. Now, having seen this, identified, I am opening the roof of the triangle by means of separating these strap muscles. See this?
Yeah.
Sometimes it is so difficult. I have seen the nerve. One of the very respectable Brazilian surgeon who has described the classification of this nerve. Remember?
Yeah, boss.
That Brazilian surgeon had described the classification of the course of this nerve. See now, I have seen the nerve. I will show you. And this is unfavorable, I tell you. Can you see this now, slender now?
Yeah.
Can you see this? Going horizontally, this one.
Yeah.
This is leaving. See, let me show you the course superior to it, where it is coming from. See this now coming?
Yeah,
Too slender.
Very clear, boss. Very clear.
Yeah.
Now see, it is coming from above. Like
very close to the...
Yes, see this now?
Yeah.
See, very clear?
Yeah, boss.
So what that Professor Sarnia from Brazil, what he has described, this nerve, mop kar. See, we have to be careful. Any bleeding in the vicinity can ruin everything. If the nerve leaves the thyroid, upper pole of the thyroid 1 centimeter above, this is type 1. See this? If it leaves the upper pole of the thyroid, within 1 centimeter is 2A. If it leaves the thyroid below the level of the upper pole, it is difficult to identify and preserve. That is 2B. And you never know what kind of situation you have. So you have to expose this triangle. Can you see this Joll's triangle now? The airway in the midline, this thing, vessels laterally. And see this now? Very clear for everyone?
Yes.
Clear or not?
Clear, boss.
Yes.
Absolutely clear, boss.
So this is called Joll's triangle. Deepak sir has shown many a times. Once he was doing thyroid, he said, I've done very good. Because, sir, show me the external, and he showed me. I was so amazed that time. That was in the beginning. So anybody follow this principle, believe me, this is the simplest and the best way of identity. Now, having seen this now, I will take the upper pole. Can you see this now?
Yes.
Earlier traditional teaching was When you divide the upper pole, stay close to the upper pole. You never know where the nerve is going. That was blind. And it was all your luck how the configuration the nerve was, whether it was preserved or not. So
some surgeons they prefer to stay close to the gland and don't always identify the nerve.
Yeah. Always identify is a different thing. Staying close always is a different thing. So always identify and then see now what I'm doing. I'm looking at the nerve and under vision I'm dividing the upper pole, staying away from the nerve. There's no question of staying close or beyond. It is under vision now. My nerve is here. See this? Take it.
Making an angle of 135 degrees.
Yes.
No?
Yes. Between the recurrent, great sir.
Yes. You are talking.
Between the recurrent and the external laryngeal nerve, you will find an angle roughly 135 degrees. We have observed.
Yes.
Now see. Let me reduce the magnification. Our carotid body tumor is ready, is already induced, and we are going to be through in next 5 minutes. See this. See this. This is our nerve. See that again.
Yes.
And now, divide quick. Yes. Now we are going to separate this, quickly. We have some inferior thyroid veins or something, and we'll separate.
Satish, one question.
Yes, please, sir.
Are there any indications for robotic thyroid today, or you feel it's not indicated? There are limited indications.
Limited indications, sir. First of all, robotic thyroid cannot give this kind of exposure.
Yes.
This kind of dexterity and confidence in preservation of the structures, and not so versatile. Initially, the indications were for smaller thyroid nodules less than 3 centimeter. Why are you operating?
Yes.
So, yes, but the science is picking up because see why robotic and this. The only difference is the scar.
Okay.
For the scar, you are doing a lot of things at the expense of endangering a lot of important structures. I'm not against it, but we have to justify the indication.
And Satish boss, your take on lateral corridor approach for thyroid surgery?
Yeah, a lot of people do this. Yeah, you see Prathamesh doing a lot of times. Very good. Once over the period of time you get used to it. What I believe still, this thing, it is easiest to learn. Very, very practical.
What about the Zucker canal tubercle?
I had shown you. Let me show you again. This was Zucker canal tubercle. So Zucker canal tubercle is an extension of the gland at the upper part, deep to which runs the recurrent laryngeal nerve. So this was described earlier as one of the landmarks to identify the recurrent laryngeal nerve.
But I think, Satish.
Yes, sir.
I think the hallmark of a great thyroid surgeon is consistently preserving the parathyroid and consistently identifying the external laryngeal and preserving it.
Yeah, but out of them, the parathyroid is most important, sir.
Yes. I think these two steps, because recurrent, a lot of them do identify. Inferior thyroid,
much easier to identify.
For me, if you ask me, the two signature steps which I like whenever you do the dissection, one is the way you consistently identify the inferior and superior parathyroid, especially the inferior and that small vessel going towards it. And second is this external laryngeal nerve. I don't remember even a single time when you could not trace it or locate it. Amazing,
Yeah, you're right, sir.
Yeah, which is why I call you the phenomenon.
Me? What I have done?
In 1975, they used to call Amitabh Bachchan the same.
He is the Amitabh Bachchan, that is true.
Now, where I'm ligating this, the inferior thyroid now. See now, closest to the gland, after it has given all the branches. Can you see?
Yeah.
That is the site where you have to ligate the inferior thyroid.
Correct.
See that?
Yes.
The full course after it has given all the branches, you know. Now this is the pretracheal fascia. This is Zucker candle now.
Yes.
And see now this is pretracheal and this is out.
Yes.
Now the carotid body is waiting and then one complication of Hess.
Yeah. And the way you taught me those two planes and using the fingers in those two planes.
Yeah.
That was
made the thyroid surgery
yes. That's a good paratracheal gutter kit.
That directly takes you to the right area, you know. It's such an important step in the
we've seen people insinuating a finger all around the capsule and delivering it, but this is 1,000 times better.
Yes, yes.
It is enucleation. That is not.
What will you do if you perforate the trachea by mistake?
If you happen to perforate the trachea, yes. Suppose you happen to perforate the trachea over here. I tell you the best thing. Best thing is when you close, because you cannot ensure an airtight closure by any means, even if you try to. The best is when you close the flaps and everything, leave at one place like you have given a tracheostomy. Okay? And open it to heal by secondary intention like you leave the tracheostomy to close. This way it will not give emphysema. The concern is emphysema.
Yes.
Now see at the other end, see the entire gland and the isthmus. This is loboisthmectomy, which is classically known as a hemithyroidectomy.
Yes.
And see me, this is a complete operation in itself. Even if this patient turns out to be a cancer, I don't need to go back to the right side at all.
Okay.
Okay?
Especially in
frozen section
papillary.
has advantages. Frozen section, number one, it can pick up a primary as a malignancy if it is. If you have any nodes in the central compartment and you send and turn out to be positive, that is an indication for a lateral compartment dissection. Level 2, 3, 4, 5. So frozen is important. Yes, sir.
So this is hemithyroid, the approach in papillary, medullary, as well as this one?
No.
Follicular?
No,
only
that is not complete. If it turns out to be malignancy, then you have to convert to a completion.
Okay.
How effective is the nerve?
For any thyroid, if it is malignancy, the final answer is total thyroidectomy. You remove entire tissue along with the lymph nodes so that you can monitor with a marker like thyroglobulin.
Yeah.
Okay. And you can administer radioiodine because that will not be competitively inhibited by any iodine picking tissue.
Yes.
So total thyroidectomy is the answer. Now, when you have a nodule on one side and pre-op, you don't have a diagnosis of a malignancy. And you do a hemithyroidectomy, then obviously, if it turns out to be a malignancy, assume it as a malignancy before. Had you been having that diagnosis before, you would recommend a total thyroidectomy.
Yes.
So now do a total thyroidectomy. That is completion now.
Okay.
That's why hemi done on one side is a complete procedure. You don't need to go back to that side neck.
Okay.
How effective is the nerve is cut over here?
Really use for ligation. You only give for
Pardon?
Dr. Rajeev from Guwahati is asking, what is the suture material that you use?
Over here, Vicryl. Okay. Disconnect.
And, he's also asking
Pardon?
Any idea of using fluorescence and identifying?
I can't hear you. Some voice is interfering.
Who is there?
Somebody is talking with the mic open. Hello, now Paramita.
Yes, sir. Dr. S.P. Fukan from Guwahati is also asking, any idea of using fluorescence?
See, somebody is talking with the mic open. You can't hear you.
I don't know who.
Can you ask everybody to mute Yes, now you can ask. Dr. Fukan is asking something. Yes.
He's asking any idea of using fluorescence in identifying blood supply of parathyroid?
Yes, yeah, that is, some people have published. I tell you, a lot of people have published various ways to make the parathyroid prominent. What my point?
Yes, sir.
Like, fluorescein is one of them. A lot of people use methylene blue for the blue discoloration of the parathyroid. Some people use nanocarbon particles to discolor the parathyroids. Many ways. But those things, safety of those is not established yet and as a routine protocol. But that is good. Even we are looking for something which can make the parathyroid prominent and make the surgeon's life easy. And the patient's life as well. So that is good. So fluorescein is one of them. Then nanocarbon particles and we have used methylene blue earlier. You can give IV methylene blue 1 hour before surgery.
Yes, it was a
And
very.
when you open up, the parathyroid will be distinctly purple colored and you can easily find. But the issue is, though it is very, very safe, it makes the patient blue colored, cyanos like. And that is so frightening in the post-op when you have a patient looking like cyanosed. So you don't feel like doing that.
Used to do a long time back. It was very effective.
So you can do it, but why to do with so much of thing which is frightening you?
Suppose this nerve is cut during surgery. How effective is the suturing?
Very good. It will retain the tone of the muscle.
Okay.
May or may not bring it to the normal, but it works very well if you do immediately.
We should do at the same spot. Okay.
Yeah, sometimes you don't get the upper stump. Then what you do, you go below the nerve was going up towards the thyroid, towards the larynx.
Yeah.
After the visible course you have seen, it runs below the underneath the inferior constrictor for another 1.5 centimeter. So cut the inferior constrictor and get 1.5 centimeter length of the upper trunk, upper stump, and then you can anastomose.
Okay. And so what about temporary hypoparathyroidism? In how many percentage of cases have you seen?
Temporary is very common. Temporary can happen in any total thyroidectomy. That is common. But permanent is less than 1%.
Okay.
Temporary can happen.
So Dr. Arshad Imam is asking how we proceed technique if the inferior thyroid artery is absent.
Paramita, somebody has kept the mic open. Paramita, somebody has kept the mic open. We can't hear you. See people on Zoom. Please keep your mic mute if you're not talking. Hello.
So you can hear me now?
Yes. See who is talking in the background. I don't know.
Dinesh, I think you can keep.
Hello.
Dinesh, can you keep the other mics mute? इधर कर दे ये ऑन कर दो ना.
Now it's okay. Now you carry on. Ask question now. Hello,
sir, you can hear me now?
Now it's okay.
Satish sir?
Rambabu is mute now. Unmute Rambabu. Yeah. Unmute Rambabu and unmute.
Hello.
Yeah, now it's okay.
Yeah, can you hear me now?
We can hear you. No problem.
So now, what was the question?
Dr. Arshad is asking, how do we proceed with this technique? How do we proceed if the inferior thyroid artery is absent? As literature says,
if inferior thyroid artery is absent.
Yeah.
Yeah, in very rare situation, it can be aberrant, absent, branch, anything can happen.
Okay. Doctor.
But then, still you follow the lower neck for the identification of the recurrent laryngeal now, and still you can go in to identify the parathyroid. All company. Chai. Yes. Are you getting any picture? Ye lagao na.
No. Any specific tips for parathyroid adenoma?
Parathyroid adenoma is a different thing. Maybe primary, secondary, and for that matter, parathyroidectomy is the answer. That's a simple procedure you can do under local anesthesia.
Local, yeah. True.
Are you getting the picture now?
Yes, we are.
Yes.
Sir, how to manage post-operative bleeding post-thyroid surgery?
Post-thyroid surgery, you see the major bleeding can happen if your ligature slips of the superior or inferior thyroid artery or the vein. So either use clip, good ligature, and if it happens to slip, you have to immediately explore it. It can be a disaster because these are huge vessels.
You recommend to put drain in all the cases?
Corrugated for a day or two. So are you getting the picture?
Sir, negative suction drain, you don't prefer to use that?
Negative suction we avoid unless we do a neck dissection along, or we do a huge thyroid. With this small hemithyroid, no point in using negative suction. Corrugated will be good enough.
Okay, so Dr. Ashim Banerjee from Kolkata is asking dose of IV methylene blue in pre-operative period.
What?
Dose of IV methylene blue.
5 milligram per kg.
Okay.
It's very safe. You can try. But be prepared for the blue discoloration of the patient. So are you getting the image?
Yeah, we're getting the MRI, yes.
Can you see what it is? So obvious as a diagnosis between the external and internal carotid. And you see, let me show you 3D. Yeah.
And
this is the MR angiogram picture showing this tumor. Can you see this tumor?
Yeah.
And if I reconstruct, see this tumor. So this is the tumor where, and these are the vessels. If I show all these vessels from below, this is a common carotid. This is dividing into the internal carotid here. Now with my cursor, see with my cursor, follow the internal carotid up. This is internal carotid up. See the internal carotid up. And this is internal carotid where it is going into the temporal bone. Can you see this?
Yes.
I will show in the CT angio better. So this is the tumor basically. And we discussed in the previous case of carotid body tumor in detail about a lot of, the aspects needs to be known about from imaging side. The CT angiogram side, the vessels supplying it, the involvement of the internal carotid per se, and the distance of the upper, the top of the tumor from the skull base. This is one of the most important factor. See here, this is skull base and this is the top of the tumor. Can you see? Let me give you exact, just a minute. The distance. Where is the length? Yes. Length. Can you see 4.5, 4.4? Hello?
Yes.
Roughly 4.4 centimeter from the top of the tumor to the skull base. Can you see?
Yes.
So that gives you a fairly good idea that you will be able to remove it from below.
Yes.
Hopefully without the need of any mandibular division, any vertical ramus osteotomy or mandibulotomy or anything. Number one. Number two, quickly, our case is ready. We discussed last time in detail the radiology part. What I will show here is quickly the vascularity. As I told you last time, the internal carotid rarely gives a major branch to this. Mostly it is the branches are given off by the external carotid, and that is how sometimes you have to take the external carotid, ligate it and rotate the specimen to get it delivered.
Yes.
Last time we didn't have to do all that and we could preserve both the vessels. Now let's see this time. Let me see this, see now.
Same one,
See now.
Yes.
See now, this is the let me show you this resolution. This is the common carotid. Can you see? Can you see this common carotid?
Yeah.
Keep an eye on it where my cursor is. Now the tumor is starting and it is dividing into, see now the external and internal. Can you see?
Yeah.
The internal is here and now see it is completely surrounded by the tumor.
Yeah.
See very clear?
Yes.
And see this external, after given up, it is giving so many branches to the tumor. Can you see this, all these?
Yeah.
All these branches are given by the external. N number of branches, see, again and again, going all inside the tumor. See this, external, and then finally, this is giving occipital and other branches. And finally, this is occipital, this posterior auricular, this is occipital. And finally, this external is going behind the mandible to divide into superficial temporal, and this is maxillary. Maxillary going to the pterygopalatine fossa. See this?
Yeah.
And this is internal carotid. See this? Now, if I go up, internal carotid enters the temporal bone, horizontal petrous. This is, cavernous sinus. And now here it in the intracranial segment divided into middle cerebral and anterior cerebral, both anterior cerebral making the ACOM, and behind the posterior cerebral giving posterior communicating, forming the circle of Wells. Very well developed circle of Wells.
Yes.
Can you see very clear?
Yeah, very well.
Very well developed circle of Wells. That is a good kind of relief to the surgeon, and in case, you have to divide it. Though we have a planned reconstruction today, and again our vascular surgeon is here with us.
Great. And I think getting a good height, having a good space above the tumor is important for the reconstruction also.
Yes, you need a good stump.
Good stump.
To reconstruct, to suture. And the things which are at risk are the vagus nerve in the carotid sheath, hypoglossal nerve crossing lateral to it. Last time I showed the hypoglossal and the ANSA preserved, and the external carotid as well. Let's see this side how invasive this time this tumor is, because you never know, unless you explore, you can't comment on it. Sometimes it is so invasive to the wall, so frustrating it is, and you have to take a call of resection. So any question before we go?
The internal carotid is not so much surrounded by tumor. This much is when uncle.
This one is, see this, how it is surrounded by.
Totally surrounded.
See now. See this?
Yes.
And totally. This is bigger than the last time,
Almost double.
This is quite big than the last time.
Satish boss, have you ever encountered secretory carotid body tumor also?
Yes. Treatment is same. There are pre, per-op and post-op protocol you have to follow. Keeping the catecholamines secretion in view. Rest is same. Very rare. Less than 4% of the head and neck paragangliomas are secreting. And that's why the genetics is important. Though in India it is not practical to get genetic studies done. Every patient. Otherwise, if you get the succinate dehydrogenase mutations, there are certain mutations prone to multiple tumors like SDS-D, certain mutation like SDS-B, predisposes to malignant tumors. So, if there is genetic component predisposes to multiple tumors, secretory tumors, all those behavior, and you can get to know if you have a genetic studies done.
And we used to read about carotid sinus syncopal syndrome.
If you do bilateral.
Okay.
Because you take away the inhibition and sometimes those patients become, hypertensive.
Okay.
Particularly suppose this patient had been having both sides. I would operate on one side today, the smaller one, preserve the carotid, and everything goes well. The next week I could do the other side. But the only thing is, when you do the second side, that can happen, that situation of hypertension, unregulated hypertension.
Okay, boss.
Okay, let's go.
Yeah.
Microscope.
How we prevent the spasm, carotid spasm during surgery?
Anupam, induce the frontal sinus case. Induce the frontal sinus case. Ayo.
Hello?
Any questions related
Sir,
to any of the surgeries done so far?
sir, I have a question. Hello?
You ask.
Sir, do you prefer preoperative embolization of large tumors?
Yes, that is one of the strategies for any vascular tumor for that matter. That is not for this only. For any vascular tumor, it is always a concern. Bleeding is always a concern. And one of the easiest way which fascinates the surgeon is the embolization, So here again, I told you, like, varioscope, chalu karna. So I told you, this is principally supplied by branches of external carotid. So we'll tackle them. Once we are doing open surgery, we'll control them. Let's see. Intraoperatively rather than wasting time, energy and money for embolization. See, it is the fear of the surgeon, fear of bleeding, which makes them, think of all these alternatives. So, can you see the picture?
Yeah.
Microscopic again?
Yes.
So, I love to do all these open surgeries under microscope.
Fear of carotid only.
Pardon?
Fear of carotid artery only.
Hopes that will preserve it,
yes,
remove the tumor, and in case required to reconstruct, we'll reconstruct it. Okay. For that matter, my initial incision, I'll take a little longer incision for the better demonstration. So the same incision like mid cervical, a little longer because I may have to this time go above by means of dividing not only digastric but the styloid complex and all to go high up. Okay?
Focus. Just focus it.
So this is our skin incision. Let me quickly raise the flap. उधर दूसरे में क्या Yeah. Are you getting the picture, sir?
Yeah.
Getting it, but just centralize, please, because right now it's on the.
See, this is subplatismal. This is external jugular.
Yeah.
Here I will divide this. Can you see this now here?
Yeah, maybe a little zoom out will get more field.
I told you that day that now 1 centimeter above the vein. Can you see this?
Yeah.
Greater auricular.
Greater auricular, yeah. Any specific anesthesia instructions for these tumors, the anesthetist?
Yeah, the same one. Only thing is prepare for the possible, with handling bradycardia and all that.
Yeah, all those catecholamine changes.
Yes. And we keep pepeverin ready.
Yeah, for the spasm.
Guru, pepeverin, keep ready. Xylocan, pepeverin for spasms,
Yes.
That is the anterior border of the stenomastoid.
Yeah.
We saw in the, just before in the SOSD.
Yes.
अरे पकड़ना यार भाई डिले मत चलो pardon. See, this is the tumor here, going to be here. Yes. I'll open up below to see the main, common carotid. Look up. See, this part I'm going faster, huh? Don't bear with me. Flap raising and all. I can palpate my tumor.
Sunday, what is the final plan? How many cases we have booked? 3 cases?
Pardon?
For Sunday, just describe our Sunday program.
Sunday, minimum 3 cases and minimum 100 situations we are going to discuss, minimum. Believe me, this is going to be a huge program. The step is, and with masters like Hashim and, Ashish, this program we had planned on the 5th of April, in Mumbai. And because of this COVID situation could not happen, the same kind of a program we are doing on Sunday. So minimum 3 cases with a lot of discussion on various aspects of autosclerosis and stapes surgery. Can you see the area of interest now? Hello?
Yes.
Yeah, we can.
This is the anterior border of the stenomastoid.
Yes.
Clean cut. This is just a lymph node, Hello?
Yeah.
This is level 2 lymph node, nothing else.
What are the indications of doing this carotid? When you advise to go for surgery, what are these?
That's the carotid body tumor is a surgical indication straight away. Now, except certain situation in elderly and, other inoperable situation or difficult, because if you allow it to grow further, it will make your life difficult later on with removal. So, see, this is a lymph node, I told you. And see the tumors coming under vision now. Tumor is here. Can you see?
Yeah.
This is a big vein coming onto that joining the, the internal jugular here.
Yeah.
Bipolar. Funny. Let me know if I go out of the field or if the picture is not good. So far, is good. How the picture was?
Very good.
We got a compliment this morning from Dr. Sethi from Singapore. For the picture quality, he was so happy. And we are grateful to Mr. Dinesh, who has put in amazing efforts for this transmission.
One person working behind you is the Sandeep Naidu. He is, I think, the
Naidu is our most important team member,
Yes.
Most committed, devoted, hardworking.
And extremely enthusiastic.
Yes, yes. He always wants to learn more and more. See this, the tumor is here. And see, this is one of the branch joining the
jugular.
IJV.
Yeah, big one.
So we have to reflect after dividing this so that we can go into the tumor surface. That is the common carotid here below. See that?
Yeah.
So this is common facial. Cut. So today was our theme was on neck dissection. We had a lot of requests for the neck. Our concern was as many of the ENTs are not into head and neck.
Yeah.
But I hope this will raise the interest amongst some people. See now the tumor in the find out. This is tumor surface.
Yeah.
See? And this is, non-tooth. So first of all, I have to define my upper and lower stumps. Okay?
Yes.
So the upper stump. Yes. This is superior, this is inferior.
Yeah.
And what I intend to see is the common carotid. Okay?
Yes.
मुझे लगा ना इधर कुछ समझ के देख This is all tumor.
Oh.
इसको खुलना पड़ेगा. It's quite developing the common as well.
Yeah.
Let me open up little more inferior. A lot of abnormal vessels.
Yes.
Huge abnormal vessels. See the common carotid below. which is enveloped by a number of vessels. AC चलाना है। क्यों?
So, how to distinguish between benign and malignant carotid body?
Carotid body. See, the distinguish you can do on the basis of metastasis, not histologically. You cannot, if in the lymph nodes or the distal places you find the same tumor, that is considered malignant. But there are no histological criteria like other cancers to distinguish between benign and malignant. Yes. Can you see the common carotid below?
Yes, sir, we can see.
We'll see these number of vessels over it. See, like?
So are these veins or?
Yes. See this?
Yeah, huge.
That is the Vegas now.
Yeah. Quite adherent.
Pardon?
Seems very adherent.
Looks. Let's see.
Yeah.
I cannot comment right now. See the carotid.
Yeah.
But see on surface the kind of vessels.
Vasculature, yeah.
Very, very vascular. छोड़ दो छोड़ नहीं मैं पकड़ूंगा छोड़ सेक्शन लगा. This vessel was so close to the Vegas. See, this was so close to the Vegas. If I go,
can we use ovulator on the carotid body tumor to make it sink like we do for angiofibroma?
Yeah, little bit. Wherever possible, yes. See here, why I am concerned. See that it is so close onto the Vegas. See this?
Yeah.
My concern is vagal palsy. If I,
Any preoperative consent specifically you are taking for this carotid body tumors?
Preoperative?
Preoperative consent. Any special consent?
Yes, consent of the stroke, consent of cranial nerve palsies.
Almost same consent.
See now, the tumor is now becoming more evident, or the vessel is now becoming more evident. See this?
Yes.
It is involving the upper common carotid also, no?
Yes. See, this is common carotid now. It was enveloped by the vessels, Can you see now better?
Yeah.
So this is the lower end, by and large. You need to have both the stumps under control,
So you have dissected the adventitia of the common carotid, I think.
Yes.
So, boss?
Yes, right. Yeah. So this is, common carotid here. See this? That is the carotid artery. See the subadventitial plane. Can you see?
Yeah.
Yes, very clear, boss.
So, leave it. Now, let's go up for the superior exposure. Okay? See now, we have not seen the external and internal dividing. This tumor, okay, let's follow from here only. See, I am in the same plane.
Yes.
Because we don't even want to blink in this case, you know. We don't even want to blink in this case.
This is totally adherent. So, the vessel on the surface.
Yeah.
See what this tumor is all about. Vessel, vessel, vessel. See, the mop. And I want to
लगाऊं क्या अपने को? हाँ, वीडियो कैमरा पर लगाऊं? हाँ, पूरा लगेगा? और अगर ऐसे हो जाऊं, जिसमें बहुत ही कम दिखाई दे मेरा,
We are almost at the level of bifurcation, I think. So.
Yeah, reaching.
Sir, is there any chances of pseudoaneurysm after removal?
If you weaken the wall, it can lead to. If you go, deeper and weaken the wall can lead to. See the main vessel? And your cautery use should be very, very, judicious. Not to weaken the wall. See how the tumor is engulfing the carotid. See, this is which now is coming, ANSA. See the tumor, the previous and this one, this is so invasive. Comparatively.
Very adherent vessel wall, boss.
Yeah. So I told you, you cannot preoperatively, by all means, you cannot say, cannot predict.
Can the same principle of carotid stenting be applied here as to what we do for glomuses?
We are ready with the stent. Stent. Same principle. We are ready with the stent in case required. See, you have to have patience to separate it slowly.
You should have patience and you should have good heart also, boss.
Let's go. Now I am going to go up and see now I am going to do a lot of maneuvers to go up. Number one, let me release the sternomastoid thoroughly. See, that's why I extended the incision. See this?
Yeah.
This is going up.
I kept this incision. Wouldn't be required.
So, what purpose will it serve was to improve the upper exposure?
Yes. I have to do all maneuvers to go up,
Shadow from Australia. Again, one question from his side. Can we use a vessel sealer in place of this cautery or ligation for this
Yes.
height?
Yes, you can.
You use it?
I don't feel like, I have vessel sealer. I'm using the same Martin cautery and we have a Martin vessel sealer. I can use it.
Is it the same as Ligashore?
Huh?
Is it something similar to Ligashore? No.
Yes. Same. See now, this is digastric.
Yeah.
And once I divide the digastric, I'll get the upper corridor. And then below the digastric would be the hypoglossal.
Yes.
Centralize, please.
See now, this is ansa hypoglossi. This is digastric going deep to the digastric, the hypoglossal, from where this ansa is coming. See that? Yeah, ye dikh rahe na? This looks like digastric hypoglossal only. See this hypoglossal?
Was the tumor looks more superior than it was in MRI? Superior extension.
It is, no. I will go above it. See this? We can go above it. No issues. It is superior. That's why I told you I've already raised the flap so that I can retract the sternomastoid. See this? Yes. And now I can divide the digastric and then I will go up and divide the styloid complex to open up the space further.
In the skull base, yeah.
Yeah. I'll show you.
All to gain access to the upper stump, right?
Yes, that is important. That is most important, boss. That is disaster if you don't get the upper stump. Now, this is my digastric. See, this is my digastric.
Yeah.
Yeah, boss.
It is setting because it is working very well.
Pardon?
Cautery setting right now.
Cautery is our lifeline. I cannot operate without cautery. See
Setting right now.
See the digastric. Digastric is such an amazing landmark.
Yeah.
All critical structures are deep to it. As long as you stay lateral to the digastric, you are pretty safe. And immediately when I cut the digastric, below would be the occipital artery, which I will take into control to go up. Nice. See this? We are more and more going up. बेटा हाथ बीच में हटाना. Yes, in the back. See how superiorly we have gone. Now, let's follow the hypoglossal first. This is here. Could you see the hypoglossal? Either side. Good. Could you see the hypoglossal? No. See, this is hypoglossal.
Yeah.
Separate. See how it is embedded. See how it is closely adhered to the lateral surface of the tumor.
Yes.
See this?
Yeah.
Amazing. See this hypoglossal.
Yeah.
Now, now let me see. This is my, accessory. Can you see here?
Yes. Crossing.
This is jugular. This is jugular. This is hypoglossal. And here is the styloid process laterally, This is styloid. So if I now divide the styloid, I'll have a huge excess above. See, that is the styloid process.
Yes.
So in case required, I will do that. In case, let me limit myself here and look for the carotid. Now I will follow the carotid and see if we could see the upper division. The upper end. Now, sir, first of all, this is jugular.
Yeah.
See this?
Yes.
That is jugular. See all structures converging about. This is 11th now. This one. Wait. This is 11th. This is jugular. And this is my internal carotid here.
Yeah.
Good. This is hypoglossal. Retractor लगाओ jugular के. Loop. Not this one. Loop. When loop. Yeah. See, I'm segregating the jugular.
Yes.
I hope you are oriented.
Yeah, very much.
Paramita, any question?
Everybody is spellbound watching. Nobody is asking questions.
दूसरी लो एक और सीजर्स लो.
Raj Kulkarni, you want to know any case of functionally active paraganglioma, any precaution during surgery?
Yes, there's a lot of work from the anesthesia side.
Yeah.
To manage the hypertensive crisis storm, all that things with manipulation of the tumor. See, this is your nerve, vagus.
Yeah, you can engulf.
करे जा.
Mubarak Khan, 3P for you.
Oh, he's still.
No, he's still awake.
Awake.
रात का राजा है वो.
3P for you: perfection, pure academician, and precision.
Wow.
No. See, all these tumor vessels, you have to use bipolar selectively control. Otherwise, they won't allow you to work, you know. See the number of tumor vessels. Now, I can show you the glimpse of internal carotid artery. See, this is the vagus. Can you see?
Yes.
And this is internal carotid here. Totally embedded in the tumor.
Yeah.
Now, see, tumor wall I can bipolarize, but making sure that that point of place, I should not be bipolarizing the carotid.
Yes. See tumor vessels. Yes.
Yeah. These are all tumor vessels, bipolar.
What is the power of diathermy?
Pardon, boss?
Power of diathermy now, right now.
What diathermy or?
Power of diathermy.
Power of diathermy. Your bipolar is 30. 30.
Many people are asking what this cohort is setting actually.
Yeah. The bipolar is at 40.
Yeah.
We can appreciate internal carotid artery now.
Yes. And see the tumor along it.
Yeah.
So it is stretched like a ribbon over the tumor now. It looks like that.
Embedded. See, embedded it was. See, it is. Now see the origin from the common.
Yeah. Yes, well seen.
So it's a marathon surgery, you can say, because you cannot rush here. See my, my bipolar is man of the match. See, my now goal is to separate this tumor from the internal earliest.
Yes.
Once it is separated external, we can manage our own way, on our own terms. You were asking me about the surface embolization of the tumor, surface coagulation. See what I'm doing?
Yeah. Extracapsular.
Good. The field is good overall.
Yeah, very good.
Very nice.
I can't say very good because a little bit of the oozing would go on.
Is the use of intermittent 4% xylocaine swabs advisable?
Yes, to prevent spasm. You mean to say prevent spasm?
Yes. I mean, whenever we come to this stage, we start using 4% xylocaine dips.
Anupam,
swabs.
कहाँ गया वो? या थोड़ा छिड़कता रहेगा. See, this for 10% spray.
Yeah.
See now what I am segregating here is the external now.
Yes.
See what there is medially is the hypoglossal. See, so many branches, so many vessels. See, this is external.
Yes, it's in branching.
Hypoglossal.
Too much bipolar can lead to aneurysm in the future, on the carotid.
Yeah, if you injure the vessel. If you injure the wall, then only. Depends upon how you use the this thing. Artery.
The most important tip here that the bipolar tip should never be used end on the vessel. It should be always sideways.
And number of branches from the external carotid giving supply.
Yes.
I am devascularizing the tumor here by means of separating from the external.
Okay.
See now the fork.
Yeah, very well. The classical liar sign.
Yes.
Beautiful. Achieved picture right now.
It's seen so well, huh? So beautiful.
This is looking so nice, yeah. White carotid. Like a tree.
Looking like I may have to divide the external carotid later. Let's see. See the internal carotid.
Oh, yes.
Beautiful.
the एक vessel है nerve column. Yeah. See, this is the all the vessels along the nerve. मेरे को इनको लेने दे बस नहीं मानेंगे This way I'm separating the nerve and the vessels both. See the carotid and the vagus. See internal carotid being separated. Suction. Suction रखना है Suction. जरा depth में tumor. See the carotid being separated.
Yes.
Section. ऐसे नहीं. वो लगाओ folks. Reflector. Yes. Yeah. Give me section रखो अच्छे से. No, let me bipolarize the tumor first. See, once you segregate the tumor, you can bipolarize it.
Yeah.
To reduce the vascularity. See, once it is away from the critical structure, you can do that.
Yeah. Beautiful.
See now?
Absolutely beautiful.
Guru.
Both branches are hugging the tumor.
Yeah, there are so many.
What is the current blood pressure of the patient?
Blood pressure is 112 by 76. So now a tumor is deep,
Yeah.
Vessel is involved on 360 degree. Even the deeper aspect of the carotid is involved, Now what we'll do? No. No. First define the upper pole. What will define? Hello?
Yeah, we are with you.
Now I'm defining my upper pole control.
Yeah.
That will give me a big relief. See now?
Yeah, we can see the carotid going away.
Yeah, my upper pole is absolutely under control for any
Yeah. Fabulous. Wonderful.
That was my first goal. Suction. कुछ रख दे. Now we have to separate this tumor. So what we'll do, we'll take the external in loop, okay?
Okay.
And rotate the specimen because our internal is 360-degree involved. So now, so I will take it closest to the
bifurcation. Yeah.
Yes.
Yeah, always.
Section रख बे हट यार section रख पंचर किसमें गया पंचर किसमें गया show me पंचर in
Bigger section maybe.
bulldog there. There was some puncture in the external carotid. Come on. कहाँ पे कहाँ लगा दिया यार हाथ से section का कॉमन दिखा ना एक बार कहाँ okay
I think that's under the finger.
see this puncture in the external carotid, you know?
Yes. Yes.
Because anyway thyroid branch, huh? Yes.
Second branch, second, I think.
तो नहीं कॉमन में गुरु कॉमन में ना कॉमन में तो put a stitch जल्दबाजी नहीं करनी चाहिए ना लाओ scissors दो वो forceps no issues there is a small rent which will suture see the rent in the carotid how it bleeds
Yeah.
no artery दो यार artery yes and you know give me the scissors लो suture लो एक जना इसकी सुनो जो करा Who? There is? कहाँ है? Common में ना? एक मिनट bulldog. See, I put a bulldog below. Can you see?
Yeah.
Yes, we can see.
Yeah. Put it. Section ले. इसको ले ले यार हटा दे इसको कोई मतलब नहीं है इसका. And see, you can see a small rent there. लो. Section. लो section लो. See the suture being taken?
Yeah.
Yes.
The rent. लग गया ना? I know. Yes. Yes. Again, no? I can see.
Again.
Yeah. See, this is a suture on this rent. So, हो गया. No. इसको तो टाइट करते हैं. Is a tie. Can you see the tie?
Yeah, yeah.
Yes, yes.
On the end. एक सूत्र और लेता. So now it is by and large under control. See that the forceps, that time reached into the vessel wall. नहीं अभी इसको कुछ मत करो. नहीं अभी रहने दो.
It's at the junction of the bifurcation, common.
Yeah. When
common and external, yeah.
When we were taking the external, na?
Yeah, where it is branching off right there.
It went through the artery.
No, leave it.
Yeah.
Will you later apply something else also over it, Dr. Satish?
Pardon?
Once you have ligated, it has come under control, but would you apply something more before the closure over it? Just in case.
We'll put one more suture. See this?
Yeah.
It was coming through. Anyway, let's remove the tumor. That is not going to make any difference to us. So I just put a bulldog and taken a suture.
Which suture you used, boss?
That's a good
question. This was 6-0 proline.
Initially, the clamp was on common carotid.
Pardon?
The bulldog clamp.
Hello.
Yeah, was in the common carotid. Yes.
Common. So how long we can apply the clamp?
Pardon? What?
How long can we apply the clamp on the?
5 to 10 minutes is okay. कहाँ गया वो bulldog? देखो तो bulldog. दिख रहा?
Group Jaipur is asking how the stent is going to help once the carotid tumor is removed. Has to be removed.
How the?
Any role of a stent in this case, Pankaj Gupta from Jaipur, from your, I think
Stent is a temporary thing. A stent is not permanent. In case you are doing a resection anastomosis, if you are doing a resection anastomosis, then a stent. चलो Stent is a temporary phenomena for reconstruction to provide the circulation.
Is it from the same side? Ooze.
Pardon?
Is it from the same side? The oozing?
Yeah. One more suture. Yeah.
Sangeet Poddar from UAE, he is saying, moderator, please request those who are cardiac patient, please, they can switch off the mobile.
Pardon?
Somebody is advising, please, those who are cardiac sensitive patient, cardiac problem, they should switch off this mobile or laptop now. At this level.
See, now it is completely come under control.
Yes.
Okay. Okay, no? Chalo.
This is what 50 proline?
50 proline.
Yeah.
Now we'll take the external carotid properly and rotate it.
The pulsations.
You know. ये section रोको यहाँ. नहीं राजा नहीं चलाऊँ. That is superior external superior thyroid.
Thyroid.
ये मेरे को दे दो. ट्रैक कर. पानी. Irrigation. Yeah. Now everything coming under control. All these external carotid branches are the major supply to this tumor, you know.
Yeah, you sit right on that CT angle.
Yeah. Now we'll take it. See, this is just a suture. This is just a temporary measure for a small rent, nothing else. We are all set in case required to do a resection anastomosis. And if had we done earlier, we have been through by now, but we want to save it. लगाओ, artery लगाओ. Yes, उधर भी लगा दो. That is superior thyroid.
Thyroid, yeah.
I want to turn it around by means of, sacrificing this.
We have 4,882 people live right now.
Huh?
882.
I didn't get. Yeah?
4,882.
Wow.
Really?
People logged in right now.
The cardiac people have turned off.
Very soon we'll be through now. Hopefully next 10 minutes we'll be through.
True, yeah.
And the next last case is already induced. That will not take longer. Pakad. Band this. Section. Ani. Karo. Retractor. Retractor लेके करे. Retractor लेके करे इसमें.
Dr. Manprakash Sharma is asking, do you always keep a cardiovascular surgeon with you while operating such tumors?
Always. Always we have. But I tell you again, most likely we will not need resection.
Yeah. Looks like.
All this tumor.
Have you ever had to split the mandible in any of the tumors going up?
Pardon?
Any need of splitting the mandible in case the tumor is going high up?
Yeah, if it is going to the skull base, then you have to do a lot of maneuvers. First of all, the best is vertical ramus osteotomy rather than doing a total mandibulotomy. Then if it is going right up to the jugular foramen,
Yeah.
Then we may have to do convert to infratemporal fossa A,
Yes.
like we did for the glomus that day.
Yes.
See this number of vessels.
Yes, so many feeding vessels are there.
So you have to be prepared with all these, huh? Nothing is unusual, you know.
Yeah, yeah.
No problem.
मत करो आप लोग। Okay. See now?
Yes.
Reaching the upper end from the opposite side as well. So cut this. Cut this. See, I am on the surface of the tumor on this side. Completely under my control now.
Yeah. I think we are reaching the medial aspect of the tumor.
Pardon?
Are we towards the medial aspect of the tumor?
Yes, almost.
Yeah.
Yes.
Yeah, I can see that. Yes.
It is quite big. We have seen on
It has got
imaging.
a lot of vascularity after so much of devascularization also was.
What are the different ways to manage the major carotid artery bleeding or puncture on table?
Puncture we have managed. Puncture is.
Yes, other ways, right?
See, here you are doing an open surgery. You can manage the puncture very well. You can do anastomosis, puncture, repair, anything. With this good of exposure, you know, you forgot. Staying above the carotid, huh? No control. Artery. See, segregating from superior aspect.
Yeah.
Superior and medial aspect. And hypoglossal you can see above.
Yes.
So bleeding will scare you, the carotid will scare you. Knowing the fact, you have to be prepared. ये गया section. इधर इधर दो. Artery. Pottery. Cut. Give me bipolar. Yeah. Very soon we are getting it out. Yeah, what is that? Yes. See, the tumor is
Almost out, yeah.
No, but it is
Attached to the internal carotid, medially, yeah.
Scissors. Scissors. एक मिनट. Wait. रुको. धीरे. उसको हटा दे. Now we are in the final stages.
Yeah.
We leave it. Yeah. नहीं common. रुक जा अरे जल्दी मत कर यार.
Wait. And heads up to your team also. They are ultimate.
Well tuned, yeah.
अनुपम थोड़ा पेपरोइन डाल दे. नहीं एक वैसा लेनी चाहिए. दबा ले. Let me see. दिखा इधर सक्शन कर. No, मेरे को वो दे. Scissors. Not sharp only. No. ये दिख रहा है मेरे को. रुक जाओ. See now.
Yeah.
Last part I want to do only sharp dissection. Wait. Guru, wait. One tooth. Oh.
That blunt dissection looks dangerous.
Dissection. Don't pull much.
Yes.
Don't pull much. Section. चला मत करो. Again. अब हटा ही देता हूँ उसको ना.
लोडेड रखना शिक्षा.
दिख रहा नहीं? ये लो लगा दो.
बुलडॉग लगा के कर लो.
Yeah. See the tumor out?
Yeah.
And we'll just put a suture. Nothing. Suture. Suture दे जल्दी. See the flow in the carotid, you know? Yes. Just one suture. See this rent?
Yeah.
निकालो निकालो. See through the bleeding vessel.
Yes, yes.
Persistent suture.
Yes. See the carotid. That's it. Over. Then I will clean the field and show you. Yes. Huh. पानी डालो. पानी डालो. Irrigation. See the common and the internal carotid.
Yeah.
And give me the Doppler. हटा दे. See now the tumor is out. Could you see the tumor out?
Yeah, very much.
Yes.
And now the last part, a little bit of the oozer in the bed.
Amazing, boss.
See the bed beating carotid.
Yes.
Small rent here, which was insignificant.
So it was a very aggressive tumor, but you saved the carotid, boss.
I told you it is the intraoperative part will tell you how aggressive it is.
So otherwise, anybody would have, I think, resected the carotid.
Pardon?
It's very difficult to save the carotid in this type of tumor.
Yeah,
you did that. Amazing.
Absolutely.
And this small rent is hardly anything. You can do any time such things. Many a times we have repaired Petrus carotid like this. I told you during glomus surgery, the tumor aggressively, surgical. Yeah, no? Now, छोड़ दे. Everything, remove everything. See now, complete hemostasis.
Yeah.
Fantastic.
Now we'll see all the landmarks. See, this is the common carotid. This is the internal carotid.
Yes, you can see.
Give me a surgical.
If you were to show us with the Doppler.
Pardon?
You have to use the Doppler.
Yeah,
We
Doppler.
can see the carotid pulsating so well.
The pulsations.
Just for demonstration. Now
see the hypoglossal above.
Yeah.
And see. Can you see the pulsation?
Yeah, very well.
This is the Doppler probe I have applied. Now see to the distal part of the internal carotid. See this. Can you see?
Yeah. Super.
Can you hear the sound?
Yeah.
Yes.
Excellent.
So that's sometimes the vessel may go in spasm and all that. The flow is good. This suture is good. Nothing is to be done. Forget about it.
Okay.
There's a small surgical we kept in the bed. And there's no bleeding at all. So still, we could avoid the resection anastomosis.
Yes.
Yeah, another case we'll be keeping after 2 weeks with a bigger one, twice the size of this one. That will probably mandate resection anastomosis. This was a good one.
खजाना है खजाना आपके पास.
See, this is Vegas. This is hypoglossal, and this is 11th. See this again.
Centralize.
This is 10th.
We can't see Dr. Satish. Yeah.
This is 10th. This is 11th. This is 12th.
Yeah.
Beautiful.
And the carotid and the bed, tumor bed, absolutely dry. 5 मिनट के लिए एक वो रख दे सर जी से जेल फोम ये मेरे को बाइपोलर दे.
Follow up of this case. Follow up means after when you will go for the further investigation to rule out anything.
Nothing. I don't think you have not done anything to give him aneurysm. See, the vessel is so strong.
Yeah.
Aneurysm happens to occur when you have thinned out the vessel wall at some places. Correct. This doesn't look like. See.
How do you take post-operative care of this patient?
Post-op? Nothing. Yeah. Just give 2-3 days antibiotic and remove your corrugated drain and discharge. Now,
corrugated drain?
Yeah, we'll leave for 2-3 days. Corrugated. Okay. So just 1 or 2 sutures on the carotid, one side rent. And I think that could have been avoided. There was nothing else. It's a regular one.
And imaging protocol, after how many months you do MR or some DSA?
See, once you have removed completely, you are intraoperatively quite sure. See this.
Yeah.
Why to imaging? Why to image? Now for your satisfaction, patient satisfaction or anything, you can get done anytime. Otherwise,
not needed.
What is frontal sinus?
These are benign tumors.
Yes, exactly.
You don't have to follow like cancer.
Somebody is snoring.
Is that the patient or somebody?
Okay, so next case is a short one.
Yeah, wonderful, Satish. Superb.
Thank you. Any question? Anything?
Amazing, boss.
Spellbound.
How could you see that in the rent where to put the needle and where to take it out?
Yeah, you have to take 2 or 3 sutures around that region to bring the vessel wall in approximation. One suture, then along parallel second, then the third one, that will completely secure the vessel wall. And see, it is always better in a bleeding vessel,
Yeah.
The vessel, the way you saw the suture was taken when the vessel was bleeding.
Yes.
That is always better.
Yeah.
You ask any vascular surgeon, this is the way. You always suture in the bleeding vessel. Hello?
Yeah.
Okay, I think so.
Somebody is snoring.
Last case. MRI का है इसका CT MRI दोनों जल्दी CT का है पिन needle hello
Yes, boss.
Needle
हेलो कैरोटिड बॉडी
अरे नहीं यार ये लगा दे यार जो भी कर
पार्टिसिपेट करता हूं
MRI कहाँ है इसमें लगाई थी तूने यार
अभी तुम्हारा मॉडल
लगाई है
Deepak boss, what were you saying? I missed your comment.
Hello.
Yes, boss.
Boss, are you getting the picture?
Yes, we are.
What picture are you getting?
We are getting the
MRI. Yeah. Okay. Now see the MRI compare on both sides. She presented to an ophthalmologist with proptosis, and he must have consulted somewhere and started antibiotics. And now she has been on antibiotics for last 10 days.
Okay.
Now look at the MRI picture on both sides. See the orbit, superior-medial part.
Yes.
Inflammation.
Yeah.
Inflammation. And there is isolated frontal sinusitis. Can you see?
Yes.
Yes.
See the condition of the orbit. She had proptosis. She had, completely chemosis, proptosis, inflammation, and painful eye. So, I will show you this one, the axial. See the condition of this eye and this eye.
Yes.
A lot of inflammation in the intraconal part as well.
Yes.
Lot of preseptal cellulitis. See this orbital cellulitis?
Yeah.
And the reason is the isolated frontal sinusitis, this one. Okay, give me the CT scan. Now the same patients. Yeah, the same patient CT scan. Our goal is to treat the isolated frontal sinusitis. So once again, I take this opportunity to invite Sunday. Sunday will be starting 10 o'clock or so with the stay session.
Okay, Chief.
See this?
Yeah.
This is ethmoids and this is frontal sinus. See this? Which is see, this is looking like some osteoma.
Osteoma, yeah, exactly.
Yes.
I was wondering.
Is there any communication with the orbit in this case?
It is not always a rent in the orbital wall.
Inflammatory.
Mostly through the hematogenous or lymphogenic route. It is not always a continuous through and through rent and infection.
It's an osteoma.
Yeah. Looks like.
Yeah.
Osteoma involving the beak and this thing, I think. The posterior table as well.
Yeah, somewhere. Let's see. I will see the 3D view to give me exact location of the osteoma.
The big osteoma.
Yeah, but it is below the level of the frontal beak.
Yeah.
The ethmoid
is getting attached posterior
Just to the agar. Just
to
next. Yeah, just attached to the agar.
I am just waiting for all the files to open so that there's still 400 files left. See, without having a dynamic CT scan on, CT.
You cannot go to the place.
See, this is osteoma.
Yeah.
Let's see where the osteoma is. Seal all planes. Hello.
Yes.
This is in the frontal recess region.
Yeah.
Some bony hyperosteosis or osteoma, whatever. This is purely in the frontal recess. This may be a cause for the obliteration of the frontal outflow. See this? Completely obliterated, almost. Let's see.
It has an attachment anteriorly, laterally, and posteriorly also.
Yeah, it's favorable. It's favorable. It doesn't look like attached to the skull base. It may be at this place.
Yeah.
Major attachment is on the anterior wall.
Yeah.
See this?
Yes.
Yes.
Let's see. We may need a little bit of drilling. So, let's start.
What's the plan, boss? Lothrop?
We have to drain the frontal sinus. We have to widen the frontal outflow. So we have to work in frontal recess. If this is osteoma or some bony thing, we have to remove it to give a wide drainage.
Yes.
To approach, you will plan Lothrop, boss, in this case?
If warrants, if I think that I need to give a little more drainage, I may do a draft 2B. That will be intraoperative decision. But my prime goal is to achieve good frontal and ethmoidal clearance.
Yes.
Yeah.
बिल्कुल शेटी लग रहा है. Hello.
Yes, boss.
Yes, we can hear you.
So, are you getting endoscopic picture now?
Yeah, we are.
See now here. That is our region, area of interest.
Yes.
Is there a history of surgery? I think you said in this case.
Not really.
Okay, this is a fresh case.
Yeah. But he has been on antibiotics for 10 days.
Yeah.
Okay. Yeah. Looks like you'll find the osteoma right under that bulge.
Yeah, could be.
Because the bulla is quite enlarged, that area.
This is just simple application of adrenaline.
Yeah.
This is your uncinate. That is your bulla. See this uncinate?
Yeah.
Merocell, once more. See, we don't inject. I tell you, we never inject. So this is just topical.
So looking at the mucosa, we can feel that it was a little infected previously.
Yeah, it looks infected.
Yeah, sir.
I can anticipate little more oozing.
More bleed.
Yeah, more.
Yes, sir.
So now anybody, if you are doing neck surgery or anywhere, if you find a rent in the carotid, you can suture it without having any fear. Hello?
Beauty was that continuous irrigation was the main plus point, main point where you can, somebody was irrigating over there and you were suturing it.
Yeah, continuous irrigation, low grade suction and
irrigation is important, suction is important.
It was a big treat from you, boss, for today's case. Big tumor, carotid rand, and everything that we can expect. Great case.
The bigger award should go to somebody who was snoring at that time when everybody was sitting with bated breath.
Deepak sir?
Yes, boss.
Shetty lag rahe ho, Shetty.
Dawn of the.
See this uncinate? I'm going up with a red 40.
Yeah.
That is the osteoma.
Yes, right there. Yeah.
See, my prediction was right. It's right under the mucosa.
I told you this is below the level of the beak.
Yes.
That was quite evident in all three planes. So we are right on the target. See this?
Yeah, very much.
This is bulla now I am removing. And see, this is the orbital wall.
Yeah.
See how it is inflamed.
Yes.
The only one tool working, that is micro debrider so far.
Right.
I didn't change any single instrument. Posteriorly, we don't have to do anything. Our area of interest is here only.
Yes.
See that?
Yeah, very good.
This is our orbital wall.
Yes.
Yes.
This is our osteoma. Chisel. Debrider. So, soon we are going to be through.
Yes.
The only man on this planet who can start the case at 11:40 is this madman from Jaipur.
You remember your theater.
We started a angiofibroma at 1:10 in the night and finished at 4 o'clock in the morning.
At your place.
And you took the flight to Jaipur after that.
See this osteoma coming?
Yeah.
Very nice.
That was the thing which was blocking, giving us frontal sinusitis. See this?
Yeah, wonderful.
Everything so far is with 0. Now give me 70. 72, finish off. That's it. Yeah. Debrider. See the pus.
Yeah.
Debrider. Give me debrider straight away. And give me 120 now. $120. See now, I am entering into the frontal. Can you see?
Yes. And we can see something inside also.
Yes.
Fungus or
you see this pus, purulent discharge.
Yes.
Yeah.
Because of osteoma, I think.
Articulated. I will remove this wall with a punch a little bit. Widen it. Articulated. See this wall. This wall.
Yeah.
This is our articulated punch. Debrider. And now wash. Fast, man. See, that is the interior of the frontal sinus.
Wonderful.
And this is the supraorbital cell, which may be the culprit in giving her orbital issues. See, the cell wall is open.
Yeah.
The recess completely open. This one.
Yes.
What is supraorbital recess?
Yes. Yeah. I think it was the combination of the osteoma and the supraorbital cell.
Now I will get a wash and it is done. Wash. See, the pathology is treated,
Yeah, absolutely.
Quite an interesting case, such an isolated disease with just a small osteoma.
Yes.
And frontal sinus involvement, not very common.
We'll keep having such, variety of cases. There are sinuses, variety,
See, the osteoma came out moment you entered. It knew you are going to find it. And the sinus opened immediately. So...
Yes. That is over here, 0 degree. Straight, the brighter.
Osteoma knew that he was going to find it at exact 11:45.
Exactly, yes. That's what I was...
In Deepak sir's language, 11:45 p.m.
So, that is the final picture going to be. Straight. Just 1 minute. A little bit of this.
Wash.
Yeah. This little bit of, the mucosal work. So this patient will not develop any future sinusitis. See this?
Yes.
That's it.
I think one more case is left. Angiofibroma.
See this? One more we can show. We'll keep next time that intracranial angiofibroma.
Yeah.
So this is done. You disconnect. So finally, any questions before we call it a day?
Primarily means a frontal sinus disease. So what besides this screening, you want to put any stent, anything?
Not really. See, now such patients, if you follow them with saline irrigation, some days with proper debridement cleaning, and this is not a mucosal disease which is going to give neoosteogenesis or frontal, that happens in eosinophilic disease. So this is not going to give any problem.
And you find isolated frontal quite often. Isolated sphenoid is generally secondary to fungus. That's what we have seen.
Yeah.
But isolated
frontal even we see in our eye hospital. I see quite a few patients like that. They come to the eye department and then they are referred. Isolated frontal sinus. In fact, even vision loss, everything, great proptosis. Big frontal sinus system, benign, not involving any other sinus. We see quite strange.
Yes, isolated frontal disease is not uncommon.
And they keep visiting an eye surgeon for years. One eye operated for 10 years. She was visiting an eye surgeon and the eye was completely out. I think probably I would have sent the photos.
And you must be getting such amazing cases because you have a huge eye center there.
Eye hospital. Yeah. They are referred from eye only.
Yeah. So, any more questions? Rajeev boss?
I'm doing Paramita's job. He was on the way actually.
Paramita, I think, has slept.
No, some issue with the net actually. So I think questions are almost over.
So and before we conclude, I would like to thank Mishi Madam, Sandeep Karmarkar boss for making, sparing your valuable time and it took your entire evening,
Pleasure was completely ours.
Deepak sir, Rajeev,
4 p.m.
Abdullah, you keep coming, please.
Sure, boss.
Deepak sir, thank you. Your blessings are always important.
Hey, who is blessing whom? You are my teacher. I am your student. You have to bless
no, sir. And 3 cheers to Rajeev boss.
Yeah, of course.
Commendable, yes.
Person behind this entire thing.
Thank you, Rajeev, Venus there, and
thanks to Venus.
And उसको राजीव को तो पूरी रात तेरी आवाज ही गूंजती होगी नींद में भी.
Finally,
we had a great time when I was in Jaipur. You know.
Yeah.
He's from SMS only.
Yes.
We used to have a good time when he was there.
Okay.
You have to disclose the energy levels. From where do you get energy levels now?
The cases only give him energy. This carotid, I'm sure, gave him a lot of energy.
All this.
Fabulous. Superb.
Fantastic. We really enjoyed. I didn't know I'll stay on for that long.
Mr. Burman is there? I think he's on.
Yes, sir. There's a sign there. I'm there. On behalf of Sun Pharma, my heartful thanks to all of you. Thank you, sir. Thank you very
Big
much.
thanks to Sun Pharma, sir.
Thank
Once
you, sir.
again, thank you so much.
Thank you, sir. Thank you.
And see you all on Sunday morning.
Yes, sir.
Okay,
Thank you,
boss.
sir.
Bye.
Right, sir.
Bye.
Thank you, Rajeev. Satish was great.
Thank you. Thank you. Thank you.